Secretary General of Bangladesh Society of Anesthesiologists. I'm welcoming all of you in our second day of first International E-Conference on Critical Care 2020. So this is the second day actually. First day was yesterday, and that was a fantastic day we have passed yesterday. It was started with inauguration session, followed by three very nice, well-oriented and organized scientific session. কে যেন ভিডিও শেয়ার করতেছেন, একটু stop the video sharing please. Stop the video sharing. Okay, thank you. Honorable Prime Minister, Her Excellency, was inaugurated this e-conference, and her speech was so nice that it gives a very good direction how to develop the subspecialty service in anesthesia. I think it will be very helpful for the development of the subspecialty of anesthesia, like other discipline like surgery and their subspecialty, how they have developed their subspecialty. And Honorable Health Minister also joined as the special guest. Other leaders and WFSA past president and president-elect joined from Norway and New Zealand. And SAARC countries' leaders joined on that inauguration session. And a good number of international faculties, national faculties, and all the BSA members joined on that inauguration session. It was a totally fantastic program in our anesthesia conference. Scientific session, there was 3 scientific sessions on that day, and 15 presentation was there. I thanks all the speakers, chairmen, and moderators of yesterday's session. Today we have 5 sessions today and 1 valedictory session. Valedictory session, Professor Adrian G. Gell is the present president of WFSA. He will join us in the valedictory session as chief guest. He will join from San Francisco, California, USA, and it will be on 9 p.m. today. So within this 5 sessions, we will start with our Bangladesh session today. It is a purely Bangladesh session, and it is divided into 2, 4A session and 4B session. For A session, it is based on our last national COVID ICU guideline, which has been prepared from Bangladesh Society of Anesthesiologists and with the help of the DGHS. And it is a guideline-based presentation, it will be. And in the 4B session, in that session, all the head of the departments of COVID ICU in Bangladesh, they will share their experience in that session. So I'm going to the moderator. I'm introducing the moderator today. Moderator is Dr. Mantosh Kumar Mondol. He is working as Associate Professor, Department of Anesthesia, Analgesia and Intensive Care Unit, Bangabandhu Medical University. I would like to request Dr. Mantosh to continue and moderate the session. Thank you very much.
Thank you very much. for your nice introduction. Honorable chairpersons, respected speaker, and dear participants from home and abroad, good afternoon. Me, Dr. Montosh Kumar Mondol, Associate Professor, Department of Anesthesia, Analgesia, and Intensive Care Medicine, Bangabandhu Sheikh Mujib Medical University, Dhaka. Welcome you all to second day of first International E-Conference on Critical Care 2020, organized by Bangladesh Society of Anesthesiologists. This is a very important time demanding conference arranged by Bangladesh Society of Anesthesiologists. I hope we all will be benefited from this conference. I like to give my thanks to our dynamic leaders of Bangladesh Society of Anesthesiologists to arrange such an important conference. Already mentioned, there are 5 important sessions, and each session, in first session, that is 4A, there are 5 important speakers, and they will speak on different aspects of the COVID-19 patients management. I am very much delighted to introduce our renowned speakers. I am requesting to all our speakers to complete their speech within time. That is 12 minutes for each. And my humble request to share the session to Professor Wahidun Mahmood Sir, our respected teacher. He is the Director Medical Service of Square Hospital and Senior Consultant and Head of the Department of Anesthesiologists. And Professor A.K. Kamrul Huda, Professor, Department of Anesthesia, Analgesia, and Intensive Care Medicine, Bangabandhu Sheikh Mujib Medical University, Dhaka. And he is working long time in our ICU, and he is dedicated to work in ICU. And also our respected teacher, Professor Saidur Rahman, he is working as a head of the Department of Anesthesia, Pain and Intensive Care Medicine, Community Medical College, Rangpur. He was also ex-professor and head Department of Anesthesia, Pain and Intensive Care Medicine, Rangpur Medical College Hospital. Now, I am requesting for the participants, if you have any questions, please write on chat box. Now, I would like to request our first speaker, our very experienced teacher, Professor Abdur Rahman Sir. He is working as a professor and in charge of Intensive Care Unit, Bangladesh Medical College Hospital. He was also professor and head the Department of Anesthesia, Pain and ICU, Dhaka Medical College Hospital. Sir, please unmute yourself and speak out about your talk. Sir, Rahman sir, please. Sir, Rahman sir, can you hear me?
রহমান স্যার আপনি আনমিউট হন, আপনার মিউট হয়ে আছেন।
Unmute করা,
It's okay. এখন unmuted. Okay.
Can you hear me?
Yes, sir. Carry on.
Okay. Can you see the slide?
দেখা যাচ্ছে, you can see. Start, please.
Very nicely.
Thank you. Honorable Chairperson Professor Wahidun Mahmood, the experienced and most delighted teacher of our Society of Anesthesiologists in Bangladesh. He was also the first General Secretary General of the Society of Anesthesiologists. And another chairperson, Dr. Saidur Rahman, he is my good friend of me, and Dr. Kamrul Huda, also a good friend of mine. And thank you very much, and all my teachers, respected teachers. I'm seeing Professor Iqbal Sir, Professor Fatima in the screen, and my special salam to them. and all the participants. Thank you very much. In the next 12 minutes, as time is declared by our Mantosh, I will be talking on the principles of the ICU admission, that is the decision-making process. Actually, in this discussion, I will be discussing on the process by which we made the protocol and the guidelines, national guidelines, which is endorsed by the most of our medical societies in Bangladesh, and that is also accepted by our DG Health Office. That is protocol is that the guideline is in the website of Director General of Bangladesh. I'll be discussing on that, what are the things actually we took into consideration in preparing this guideline. If I introduce like this, the pandemic of the coronavirus 19 is a great impact on the international health worldwide, and it is also have a great impact on the healthcare delivery system, because the spread of the virus is very rapid, case load is very high, and high proportion of the patients require intensive care support, that is the respiratory support. And that is very much unprecedented, and the service in the not only in our country, but in the whole world also. And therefore, sometimes sound ভালো আসতেছে না?
না, আর একটু যদি কাছে
আমরা কিন্তু খুব ক্লিয়ারলি শুনতে পাচ্ছি। আমরা
ভালোই শুনছি, আমরা ভালোই শুনতে পাচ্ছি,
কিন্তু রহমান আপনার কথা কেটে কেটে আসতেছে।
আমরা ভালো শুনতে পাচ্ছি, এটা বোধহয় ডিভাইস সমস্যা।
হ্যাঁ, আমরা শুনতে পাচ্ছি
ম্যাডামের ডিভাইসের সমস্যা।
হ্যাঁ, ম্যাডাম আপনার ডাউনলোড স্পিড কম আছে আপনার। ঠিক আছে, ক্যারি অন।
Okay. So therefore, sometimes the available medical resources are not sufficient to meet the needs of all the patients. This is happening throughout the whole world. So considering all these things and considering our resources, our manpower, and our facilities which are availing in our country, we are prevailing in our country, a guideline was very much potential, was very much required. And as Bangladesh Society of Anesthesiologists responded to the increasing demand and the demand of this country, and they ultimately, the Bangladesh Society of Anesthesiologists formulated a guideline, and that guideline is endorsed by, as I earlier told, most of the medical societies, including the Society of Medicine and the Society of Surgeons, or many other societies in our country. And that is also endorsed by the Director General of Health Services, and Director General kindly has accepted that guideline, and that guideline is published and displayed in the website of DG Health Offices. And actually, nowadays, this management of this COVID-19 patients in the intensive care unit is being done as per the guideline laid out by the Society of Anesthesiologists. Thank you very much to the members of the Society of Anesthesiologists who worked hard to formulate this guideline. But still, before telling to the guideline, we have to say that the care for the non-COVID patient, that is also valid in case of the COVID patient. Each and every patient should get equal care. And criteria for hospitalization and admission in ICU for the non-COVID patient is valid in case of COVID patient also, most of the cases. Though some principles we have to follow. That is the collegiality, that is important. Who will take the decision, who will take the trials, and who will be the responsible person to give the decision of admission, that is the important. Patient wishes should be respected, and attention to the patient's previous conditions to be there, and much attention to the current clinical severity also is an important factor, and the patient's comfort have to be assessed. And everybody should be fully committed to give equal care to all the patients, those who will be coming after being infected with COVID-19 patient. So if you consider the previous condition, age is sometimes, especially in some of the European countries, they gave preference to the age about 65 years. They were scared to take the patient in the intensive care unit, but now it has been pushed down because in one study, in the European study, they have found that the patients more than 65 years who are not taken to the intensive care unit and the patients who are taken to the intensive care unit, the cure rate of the patient above 65 years of age was much better those who are taken to the intensive care unit. So age bar is now in question. Neurocognitive status, patient general condition, whether it is a worsening or not, that all to be taken into consideration. Clinical severity also is a matter. If the respiratory rate by patient is suffering from respiratory hypoxemia, that is the respiratory rate, and the patient need oxygen supplementation more than 6 liters per minute, or the patient has severe respiratory distress, that is severe work of breathing is there. If the patient's hemodynamic is becoming unstable and neurological scale is coming down, or patient's organ dysfunction is worsening, possible, then these patients are a good candidate for taking the patient into the ICU. In formulating the guideline, applicability is an important part, and fundamental ethical principles have to be upheld, because fundamental ethical principles is for each patient, whether COVID or non-COVID, that is equal, and equity of the management, equity of the resource should be there. So that all the things we have to, so that we can preserve many lives as it is possible. And as per the declaration, or as per the campaign of Anesthesia Day 2020, the well-being of the professionals should be ensured, and this should be taken into consideration. To all these things, to get it very nicely, we need a criteria, that is the ICU triage criteria. That is when the patient to be admitted, whom to be given care, whom not to allow the given the care, or when the patient is being admitted, when the patient has to be discharged, which made to be made available for the next patient, that are to be considered as I declared, as I told earlier. But there are some specific recommendation. Recommendation is that maximize benefits to be maximized to all the patients, and all the patients should be treated equally, and rewarding instrumental value should be promoted, and worst of patients should be given priority. In normally, when a trial is being done, the two way admission criteria is being done. One is the medical benefit, and another is the first come first served basis. Patients, those who are too weak or too sick or too well, are not the candidate to be admitted in the intensive care unit, but definitely they have to be monitored carefully. Society of Critical Care Medicine, they always consider the expected outcome. According to the Society of Critical Care Medicine, that is basically all society we know, and they consider the outcome. In general, patients with good outcome, prognosis or recovery, they get the priority in being admission into the intensive care unit. In contrary to that, American Thoracic Society, they follow the first come first served basis. But here also there is some dilemma or the first come first served basis. Which one will be the first? Whether the ICU trials person, the trial person knowledge, or the patient who will apply for first, or who will be admitted into the hospital first. So these are all dilemmas that has to be cleared off. For the American Society, first come first served basis. Most state, but what about the method, whether in the medical ground or first come first served basis? These criteria should be declared, should be there. That is accepted by all the societies and most of the persons, those who are being involved in the management of this intensive care unit. That should be the explicit, the criteria should be expressive, that should be fair, criteria should be very fair, and that should be disclosed in advance. In which method the trials will be done, whether in the medical ground or it is in the first and first safety, that is have to be disclosed in advance. And this trials should not be based on the race, ethnicity, sex, financial status, or the social status. Everything should not be the criteria of the trials. Everyone should get the equal facilities and equal advantages and equal chance of being treated in the intensive care unit. That is the normal way. But in the pandemic situation, this is also valid, but there is some modification I have to make because trials in the patients is very much challenging in case of COVID-19 patient, and also this is controversial because resources are very limited most of the time. And if we see the experience of in Europe, China, America, and even in our country, that the resources is overwhelmed by the patients. So it is strongly recommended that the institution should develop a prospective, objective protocols and algorithms, because the resources, the personnel, the facilities, the equipments, the capability, all are not same for all the institutes. It's vary from institute to institute. So taking into consideration what they have the resources, what they have the manpower, what they have the facilities, considering all these things, they should make a objective protocols and algorithms to overcome this pandemic situation in intensive care unit. Some exclusion and inclusion criteria can be considered, and we considered in our when we made this guideline, these things are being considered. Whether there is an inclusion, that is if the patient, if I consider the inclusion criteria, first thing is that the patient needs respiratory support or not. If the patient saturation is less than 90 with more than 0.6 FiO2, or the respiratory acidosis is there, that is the patient pH is coming down less than 7.2, or the respiratory failure is evident, or there is the respiratory failure, and if the patient cannot maintain or protect this own airway, then these patients need to be admitted in the intensive care unit, and maybe that these patients, after a proper escalation system of this oxygenation of this patient may need artificial ventilation. And second criteria, inclusion criteria, is that if the patients require inotropic or vasopressor support, that has to be increasing. They need to be increased to make the patients hemodynamically stable, and that patient's is on level of consciousness is being altered, urine output has been decreasing, or other signs of organ failure are there. These are the strong inclusion criteria to make the patients who need to be admitted in the intensive care unit. There are also some exclusion criteria, like if the patient give a directive that I don't want to be ventilated, that the patient wishes to be honored, if the patient refuses that I don't want to be admitted in the intensive care unit, I want to be treated in the general ward or in care also, then these patients, that's one of the exclusion criteria. And if the patient's prognosis is like that, the ultimate prognosis is very poor, or at least is not in favor. So like the patient has some metastatic cancer or hematologic cancer or poor prognosis, that patient need not to be admitted into the intensive care unit. Then some prioritization can be made: priority 1, priority 2, and priority 3, and priority 4. Priority 1, that the patient, if the patient ASA is 1 or 2, that the patient does not have any previous disease or illness, patient was completely all right, was completely fit patient, and that patient now has come with 1 organ failure, and the predicted survival rate is more than 80%. If this is the priority 1 patient. Priority 2 patient is that ASS2, there is the mild disease, the patient was there. Patient was suffering from some mild disease. On that top up of the disease, patient is now infected with COVID virus. There is also 2 or 3 organ failure already there, or predicted survival is still not very bad, not very good, but still it is more than 50%. Then this patient should get the priority 2. And priority 3 is that if the patient have the severe disease, earlier severe disease, that is, say, grading score is 3, and the patient has got more than 4 organ failure, and predicted survival is less than 50%. And priority 4, that the patient already have AD and cardiac arrest, either witness or unwitness, or the patient have some end-stage organ disease. Patient is, in addition to that severe burns, or ASA score is more than 4, then this patient is in the priority 4. So recruitment of invasive ventilator support, if the patient needed, then that patient, that is the patient, the most wanted patient in the intensive care unit, and that patient will be get in the priority. Hemodynamic support is there. But then the consideration is the exclusion criteria that I told you. If there is an exclusion criteria, then that patient, if one of the exclusion criteria is fulfilled, the patient is not to be admitted in ICU. The patient has to be treated into the general ward, and a consultation with the patient party should be made. And Society of Intensive Care Medicine Switzerland, they form a scoring system with the 6 parameters. They took into consideration the age, respiratory rate, oxygen saturation in the room air, oxygen supplementation necessary, systolic blood pressure, pulse rate, and consciousness level. Accordingly, they score the patient, and if the score is within 4, then the patient simply hospitalization is there with the normal ward. That is in the COVID normal ward. The patient is being managed and monitored. If the patient's score is more than 5, or but less than 6, or in any parameter the score is more than 3, then the patient will be admitted into the SDU, that is the high dependency unit of the intermediate care unit, as they told in the Switzerland. And if the patients get more than 6 points, that patient is to be admitted in the intensive care unit. Swiss Society of Intensive Care Medicine has formulated this scoring system. The situation has been, one situation is, I think in our ICU also, we face this situation. There is 1 bed is only there, but the demand for the patient is more. A single bed is available, and the 2 beds meet us by ICU criteria. What to do? Then 4 options are there. First option is there, that is the most logical. If we can transfer the patient in another ICU where bed is available. For this reason, to do this, to have this, to achieve this, we have a central system, so that each ICU have got the idea in which ICU bed is vacant, and accordingly making a transfer protocol with them or transfer conversation with them, the patient can be transferred after being stabilized in that ICU where bed is available. Second possibility is that patient oxygenation can be tried to maintain in the general ward with monitoring, and oxygenation to be maintained till we get another bed to offer the patient. Third possibility is that is the national policy should be there if ICU bed can be increased. But there is also some limitations. Without manpower, if the bed is being increased, the patient will not get the optimum care. So escalation of bed should be made according to the manpower, according to the resources, according to the healthcare facilities available in that institute. Otherwise, all the patients will be undertreated, or under care of the patients will be underrated. And last possibility is that a trials can be done, home to be admitted and home not to be admitted, according to the trials policy of the particular institute. Some situation like that, emergency admission. When the patient is coming in the emergency room, patient is coming with respiratory distress, but you don't know, or the ICU personnel don't know, even the emergency men don't know whether the patient is COVID, suffering from COVID or not. In that case, what to do? Actually, we give some emergency trials in our guideline. That is, the patient will be coming and not known, they will be taken away neurology, while all the facilities of the respiratory care will be there, and the patient will be given respiratory support and COVID test will be sent for. And when the COVID test will come, or the patient will be confirmed that the patient is not non-COVID, then the patient will be transferred to the green zone, the non-COVID zone. If the patient is tested positive, then the patient shall be sent to the red zone. So this is the zone of the intensive care unit. With this, I like to conclude that for good management of this COVID-19 patient and to overcome the oversourced patient, we have to do a triage. The triage should be done according to the resources, according to the manpower, and all equity should be maintained for all the patients so that each and every patient get the equal chance of treatment. Inclusion and exclusion criteria to be applied during this triage criteria. Non-COVID patients should not be admitted into the COVID unit, and COVID-19 patients should not be admitted into the non-COVID unit. With this, thank you so much. Ensure well-being.
Thank you, sir. Thank you for your very much informative presentation. I believe your presentation will help us a lot to manage COVID-19 patients in ICU. Thank you, sir. Now, I would like to request our second speaker, Dr. Fatima Ahmed, a young dynamic intensivist. She is working in critical care unit, Bardem Hospital, Dhaka. And she will speak on oxygen therapy for COVID-19 patients. Dr. Fatima Ahmed, please unmute yourself and start.
I'm hearable. শোনা যায়? শোনা যায়?
শোনা যায়, সাউন্ডটা একটু কমে, একটু কাছে আসেন কম্পিউটারের সাউন্ডটা একটু বাড়ান।
সাউন্ডটা বাড়িয়ে দাও।
এখন শোনা যাচ্ছে?
জি, শোনা যাচ্ছে।
ওকে। Hello everyone, assalamu alaikum and good afternoon. First of all, I would like to give thanks to the organizer of BSA for inviting me in the first international e-conference in critical care medicine 2020. I feel proud that I am presenting a auspicious event in honor of the father of our nation. Okay, let me introduce. I am Dr. Fatima Ahmed. Thank you, Dr. Montosh Kumar, for nice introduction. I'm working in Bardem ICU as associate professor. Honorable chairperson and co-chair of the session, I am going to focus on oxygen therapy in COVID-19 patients. Before my presentation, Rahman sir clearly depicted that first preference of ICU admission of respiratory failure. And COVID-19 is a multi-system disease and mortality is highest in lung involvement. So oxygen therapy is the first line treatment for hypoxic acute respiratory failure. When a patient came to the hospital, first we have to assess the patients who need oxygen. Yes. For this reason, we have to assess the patient with a scoring system, BRCA scoring system. These 4 symptoms, if one is present, patient needed oxygen. Dyspnea, respiratory rate more than 22, PO2 less than 65, and SpO2 less than 19, and significant worsening of extra chest. And we need to analyze the data round the clock, oxygen requirement, workup breathing, respiratory rate, and PF ratio. It's a very important that viral disease, COVID virus, is a very notorious infectious disease. So when we use oxygen devices for oxygen therapy, it can produce air dispersion, aerosol generation, and more dissemination of viruses. For this reason, we need to take precaution, contact droplet, and sometimes airborne precaution in during using oxygen devices. In this slide, we can see that most of air dispersion is maximum in NIV and nebulizer, and hyponasal oxygen and non-breathing mask is minimum air dispersion only 5 to 10 centimeter. And it is, if we want to improve oxygenation in a patient from mild disease to severe disease, we need to use low flow oxygen to high flow, and then non-invasive sometimes for occasionally, and invasive ventilation. And invasive ventilation with ECMO, still we don't have ECMO availability in our country in broad spectrum. And oxygen devices are low flow system, some are high flow system. Low flow systems are nasal cannula, simple mask, reservoir mask like non-breathing masks, and high flow system are venturi and high flow nasal mobilities. Nasal cannula can provide 6-liter oxygen, and nasal cannula is amazing instrument because toning is possible with nasal cannula. And simple face mask can provide 35 to 60% of FiO2, and non-breathing mask can provide 10 to 15 liter per minute oxygen flow. This is on the slide. We can see that conventional oxygen devices can meet up only 15 liter flow, not more than that. And hyponasal and venturi mask can give more flow. Hyponasal mask, nasal oxygen can give up to 80 liter of flow. So there is some limitations between low flow devices and high flow devices. Venturi mask can control fine FiO2, and in case of COPD, it's a better option. And for improvement of oxygenation, airway secretion clearance is very important because it needs humidification. And when we give oxygen more than 4 liters, we have to concentrate on humidification, either bubble humidification or heated humidification. When patient having a trachypnea and getting worsening of trachypnea, we need to escalation of oxygen therapy, because when there is tachypnea, low flow system cannot meet up the patient's inspiratory demand. So we need high flow oxygen therapy. High flow can be given with high flow nasal cannula or invasive ventilators and critical care ventilators with high flow, only non-invasive high flow modes. Can be given with nasal cannula, can be given with through tracheostomy interface, can be given with oxygen mask who are open mouth breather. And high flow physiologically, it affects on patient. What it do that? It wash out nasopharyngeal carbon dioxide, and it decreases, it preserves mucociliary clearance, it increases functional residual capacity, prevents atelectasis, and finally, it improves gas exchange. And for this reason, high flow is very popular in COVID-19 hypoxemia. In comparison to conventional oxygen therapy, nasal cannula, face mask, rebreather mask, high flow had heated and humidified oxygen. It has an option for control fraction of inspired oxygen provision. Maximum flow, at least 80 to 100 liter flow can be added. It has a peak effect, but in conventionally, we can only give 15 liter of oxygen, and dilution of oxygen causes reduction of concentration of oxygen. For this reason, patient is not getting higher amount of oxygen when they are very sick. This research showing that when hyponasal oxygen is using outcome, 90 days outcome is better than standard oxygen and non-invasive ventilation. In that slide, we can see here that what the high flow nasal oxygen can affect on respiratory rate, dyspnea, supraclavicular reduction of supraclavicular recession, reduction of thoracoabdominal asynchrony, and pulse oximetry improvement. What is very important in hyponasal cannula dramatically reduce the work of breathing, so patient become more comfortable within few hours. And for this reason, COVID-19 patient became more better in hyponasal oxygen and less number of patients getting mechanical ventilation, and is a bridging therapy between mechanical ventilation and non-invasive therapy. I'm not going through the whole thing. It's BiPAP, CPAP is limited use in COVID patients due to aerosolization. BiPAP is significant exposure risk with high level of aerosolization, but it can be used in case of flash pulmonary edema and COPD exacerbation. CPAP can be also used through non-invasive mask and CPAP valve and with bucogenic CPAP system. Helmet system also important because it can prevent aerosolization. Proning also improve oxygenation. This is awake proning, this is paralyzed proning, and my key message. So this is my last slide. Probably I am concluding my total lecture within 12 minutes. It's a supplement oxygen is essential. It's COVID-19 with hypoxemia is often remarkably well tolerated until a certain limit. When high oxygen is requirement, high flow is definitely a better option. Thank you very much. Thank you very much.
Thank you very much for your nice presentation. Now I would like to request our third speaker, Professor Abdul Kader. He is an expert anesthetist and intensivist. He is working as a professor and head Department of Anesthesia, Pain and Intensive Care Medicine, Shohid Tajuddin Ahmed Medical College and Hospital, Gazipur. So I am requesting Kader Bhai, please unmute and speak out your topics. And he will speak on intubation and extubation for COVID patients. Kader Bhai, please. Kader Bhai, can you hear me? ছিল তো একটু আগে দেখলাম। কাদের ভাই, Kader bhai, can you hear me? Just few minutes ago I seen him in the stream. এই তো আছে তো। Kader bhai, please unmute. Please unmute yourself.
Yes. Okay. I have made ready my lecture in laptop, but now laptop is a technical problem. So I will present my lecture in mobile, which I am not used to. So these problems arises. Thank you all. Assalamu alaikum. Good evening. I am now sharing my screen with you. Is my screen visible? Is my screen visible to you?
No. No, your screen still not visible.
Okay, 1 minute, please.
Please open the presentation first and then share it.
One minute, please. I'm trying to share. As
নেক্সট স্পিকার কি শুরু করা যায়, কারণ টাইম যেহেতু লিমিটেড।
please, my
No, your screen is not visible.
screen. Okay, please start the next presentation. I am trying by this time. Okay, sorry for the inconvenience. Please
Okay.
start the next meeting.
Montosh, would you start next
Yeah.
speaker?
Okay.
Please invite the next speaker.
Okay. Now, I would like to request our fourth speaker, Professor ASM Arif Ahosan, the very much sound intensivist. He is the professor and head Department of Critical Care Medicine, Bardem Hospital, Dhaka. He will speak on drugs for COVID patients in ICU. So, thank you, Professor ASM Arif sir. Please unmute and start your presentation.
দেখা যাচ্ছে আমার প্রেজেন্টেশন?
জি দেখা যাচ্ছে।
দেখা যাচ্ছে?
Okay, fine.
Honorable Chairperson, honorable faculty members from home and abroad, respected teachers, dear moderator, and my dear audience. Assalamu alaikum and welcome to this presentation. First of all, I'd like to thank the Bangladesh Society of Anesthesiologists for arranging the first international e-conference on critical care 2020, and also for inviting me as a speaker. All of you know that novel coronavirus was first identified in late 2019 in Wuhan, China. It has since spread rapidly, resulting in a pandemic. In Bangladesh, first case was identified on 8 March, and cases is rising day by day around the globe. So far, many drugs have been used with variable efficacy, and most of the drugs are used in the context of clinical trial. And some drugs have been used through FDA emergency use authorization for severe COVID patients. Let us highlight on these drugs. Hydroxychloroquine was used initially for both therapeutic and preventive purposes. Initially, China claimed that it improves radiological finding, enhanced viral clearance, and reduced the disease progression. But the data was insufficient to support it. Moreover, there is a number of side effects with hydroxychloroquine. These are QT prolongation, ventricular tachycardia, ventricular fibrillation, and some cases death is reported. Both azithromycin and hydroxychloroquine are associated with QT prolongation, and combined use may potential their adverse effect. So NIH treatment guideline panel recommends against the use of chloroquine or hydroxychloroquine with or without azithromycin for the treatment of COVID-19 patient in hospitalized patient. In non-hospitalized patient, panel recommend against the use of these drugs except in a clinical trial. NIH treatment guideline also recommend against using lopinavir, ritonavir, or other HIV protease inhibitors to treat COVID patients except in a clinical trial. Remdesivir is a novel nucleotide analog that showed excellent recovery with statistically significant. It is available through Food and Drug Administration emergency use authorization for patients with COVID-19, severe COVID-19. These drugs are used for hospitalized children and adults with severe COVID if SpO2 is less than 94% on room air, or patient is getting supplemental oxygen, or patient is on mechanical ventilator, or getting ECMO. Panel recommends prioritizing remdesivir for use in hospitalized patients with COVID-19 who require supplemental oxygen but who do not require oxygen delivery through high flow device, non-invasive ventilation, invasive mechanical ventilation, or ECMO. For patients with mild to moderate COVID-19, there is insufficient data for the panel to recommend either for or against the use of remdesivir. For patients who do not require oxygenation delivery through high flow system, non-invasive ventilation, invasive ventilation, or ECMO, the dose should be given for 5 days or until hospital discharge, whichever comes first. For patients who require oxygen delivery through high flow system or non-invasive ventilation or invasive mechanical ventilation or ECMO, as because there is uncertainty about the clinical benefit. In this group of patients, the panel they cannot make a recommendation either for or against starting remdesivir, and those should be continued for 10 days if the patient is on mechanical ventilator or it is contraindicated. It is not recommended if the ALT is more than 5 times of the upper limit of normal, or if the GFR is less than 30 ml per minute. Safety and efficacy of the remdesivir for the treatment of COVID-19 patient in case of pregnant lady has not been evaluated, and it should not be withheld from pregnant patient if it is available. Another important drug is anti-cytokine or immunomodulatory agent, tocilizumab. As the pathophysiology of organ damage in COVID patient is amplified immune response, elevated IL-6 level, and cytokine release, what is called cytokine storm, tocilizumab, a monoclonal antibody, IL receptor antagonist, which is approved, FDA approved to treat rheumatoid arthritis cytokine release syndrome. This drug has been used in early reports success. One study showed it was associated with decreased risk of invasive mechanical ventilation or death. IL-6 inhibitors may be associated with increased risk of secondary infection. Sarilumab and siltuximab, which also target IL-6 pathway, they are being evaluated in clinical trial. IDSA guideline panel recommends tocilizumab only in the context of clinical trial. The prerequisites for tocilizumab are patient must be COVID positive, abnormal chest X-ray that is consistent with COVID-19, rapidly worsening gaseous exchange, and patient is getting more than 60 liters per minute oxygen, or patient is on a mechanical ventilator, absence of systemic bacterial fungal co-infection, high clinical suspicion of cytokine release syndrome. Dose is 8 milligram per kg, all of you know, and maximum dose is 800 milligram per dose, and it can be repeated after within 12 hours, in 12 hours if there is no clinical improvement. Maximum 2 doses can be given. Regarding corticosteroid, CDC and World Health Organization do not recommend routine use of glucocorticoid in patients with COVID-19 unless indicated. Society of Critical Care Medicine recommended use of glucocorticoid in patients with severe ARDS, that is PO2-F5 ratio less than 100. According to NIH, dexamethasone is recommended for severely ill patients who are on supplemental oxygen or on mechanical ventilation. Dexamethasone is not recommended for either preventive or treatment of mild to moderate COVID patient, that is patient who does not recover. For severe COVID patient, dose of dexamethasone is 6 milligram daily for 10 days or until discharge, whichever is shorter. For ARDS, intravenous dexamethasone 20 milligram once daily for 5 days, then 10 milligram daily for 5 days, or you can use methylbenisol. For refractory septic shock, hydrocortisone 50 milligram 6 holding, and cytokine release syndrome, you can use either dexamethasone or methylbenisol. Dexamethasone is preferred corticosteroid. If it is not available, then equivalent dose of other steroid can be used as an alternative. Though the data supporting the use of these alternatives are limited. One meta-analysis showed glucose reduced. Convalescent plasma is another potential adjuvant therapy for COVID-19 patients. It provides clinical benefit when it contains high neutralizing antibody titer, and if it is given early in the course of the disease, that is in patients who do not require mechanical ventilation. In the United States, FDA has granted emergency use authorization for hospitalized patients with COVID-19. IDSA guideline panel recommend COVID-19 convalescent plasma in the context of clinical trial. So patient must meet the following criteria before receiving convalescent plasma. Age must be more than 18 years, COVID must be positive, and one of the life-threatening features must be present, like increasing dyspnea, respiratory rate more than 30, SpO2 less than 88, PO2 ratio less than 300, lung involvement more than 50% within 24 to 48 hours, septic shock and multiple failure. Regarding ivermectin, this FDA-approved drug inhibits the replication of SARS coronavirus virus in vitro. Study showed single treatment reduced the presence of virus by 5,000-fold within 48 hours. So ivermectin has been proposed as a potential therapy based on this in vitro activity. Clinical trials are going on. But NIH recommends against the use of ivermectin in the treatment of COVID-19 clinical trial. Other agents like interferons, sofosbuvir, daclatasvir, and colchicine, vitamin D, and zinc has been proposed for the treatment of COVID-19 patients, but clinical data were insufficient to support their role in COVID-19, and their use should be limited to the clinical trial. Additionally, start an empirical antibiotic for pneumonia in selected cases, particularly if the patient is admitted in ICU, and also start prophylaxis, preferably low molecular weight heparin. At the same time, evaluate for the presence of thromboembolism. If you get present, if there is an evidence of thromboembolism, then therapeutic dose of anticoagulant should be started immediately. So this is all about drug management for COVID-19 patients. Thank you all for patient questions.
And thank you very much, Professor ASM Arif Ahsan sir, for your very elaborate and time-demanding talk. Thank you very much, sir. Adir bhai, are you ready now? Dr. Abdul Qadir bhai, are you ready? Or we'll go to the next speaker? Okay, now I would like to request our fifth speaker, Professor Manush Kumar Bosu. He is very much experienced, cooperative teacher, our teacher as our mentor, and he is working as a professor and head, Department of Anesthesia, Pain and Intensive Care Medicine Unit, National Institute of Cancer Research and Hospital, Dhaka. And sir will present on very important topics in this COVID era, that is dead body disposal for COVID-19. So I am requesting Professor Manush Kumar Bosu sir, please unmute yourself and talk out, please.
Thank you, Dr. Maltosh. Honorable Chairperson of the session, my teachers and colleagues. My topic is disposal of the dead body from ICU. In this era of COVID pandemic, when a patient is admitted in the ICU, though there is great despair, but everybody expects that we would be able to return the patient to his life and the family. Though the doctors are trying very hard in our country also, but many times the patients are not returned back to their beloved ones and his life. Then the question comes to enable the deceased family to obtain the funeral services, and at the same time, it is our duty to protect the involved personnel from the disease like COVID-19, and also to prevent the spread of infective environment to the to other environment. These are the objectives of the disposal of the dead body from COVID-19. The dead bodies of COVID-19 infection are in category 2, and this categorization depends on the mode of transmission and the risk of infection of the diseases. Like anthrax and plagues are in category 3, and all other dead bodies are in category 1. Those who are not fall in category 2 and category 3. So main duty of us is to minimize the risks of the involved personnel and the environment. And it is said, though the dead bodies are potential risk for infections, but most organisms in the dead body are unlikely to infect healthy personnel. But it may be transmitted when persons are in contact with blood, body fluids, or tissues of the dead body. So a dead body should be handled in such a way that these blood, body fluids, and tissues don't come with the contact of the persons who are involved. So there is a question of setting a standard of procedures, and that is the creating safe working environment. And that can be achieved by training and education, use of recommended safety devices, which we know all in the meantime, and not only the recommended safety devices availability, but also the appropriate safe work practices are very important to prevent the spread of infection. So not the doctors and paramedics, but all staff should be trained for the prevention of infections, and they should be trained how to avoid the direct contact of these tissues, fluids, and blood, and they should be supplied with ample personal protective equipment. The lists we know from the shoe covers, head covers, gloves, and goggles, and also the standard face mask. And we can stick a poster like this so that the personnel can follow the serial of actions by seeing it and following the steps. They can be observe the strict personal hygiene, and that should be observed by the observer or supervisor who is heading the ICU. And we know that the wearing PPE is important, strictly adopting procedures. Otherwise, the wearing PPE is very futile. And after all these preparations, the dead body should be prepared. And before removing the dead body from ICU, all the lines, catheters, and other tubes like endotracheal tube and NG tube should be removed. And the sharp equipments.
স্যার ও একটু ডিস্টার্ব করি স্যার, আমার স্ক্রিনটা কি ফুল স্ক্রিন করে দিবেন? ফুল স্ক্রিন। রাইট। ওকে, থ্যাংক ইউ স্যার।
Okay. And it should be ensured that any wounds, cuts, and abrasions are covered with waterproof bandage and dressings. And all the orifices like oral and nasal orifices of the dead body should be closed to prevent the leakage of body fluids. After doing this, the body should be placed first in a robust and leak-proof transparent plastic bag, which is no less than 150 micrometer thick, and that should be zippered closed. And for the Muslim deceased, a white bag is advocated, and when using coffin, the dead body should be first placed on the coffin and tied properly following the religious rules, and then be placed in the enclosed plastic bag. And this baggage body should be either wrapped in a mortuary sheet or placed in an opaque body bag, and then an appropriate warming tag indicating corona dead body should be attached on the outside of the body bag. Then the outside of this body bag should be wiped with 1 in 4 diluted household which is available in the market that mixing 1 part of the 5.25% bleach with 4 parts of water, and it should be allowed to dry it in air. In our part of the world, bleaching powder is available more than the solution available in the market. We can prepare chlorine solution from this bleaching powder, and mostly available bleaching powder is 35% calcium hypochlorite. To make 1% solution, 30 gram or 2 spoonful of bleaching powder should be added to 1 liter of water, and it should be prepared very carefully. The person who is preparing should wear extended PPE, and it should be added in a bucket with clear water, and it should stir for 10 seconds and wait for 30 minutes. And the level should be sticked on the or attached on the bucket, and it should kept away from sunlight. And when prepared once, it can be used for 6 hours. So it can be used for environmental control. The used equipment should be autoclaved or decontaminated with disinfectant solutions in accordance with established disinfectant policy, and all the surfaces of the isolation area like floors, beds, railings, side tables, IV stands should be wiped with 1% hypochlorite solution, and a contact time of 30 minutes should be allowed, and to be dried in air. And the metal surfaces and the monitors can be wiped with 70% alcohol. The surfaces where visible contamination is there with blood and body fluid, it should be wiped with 1% bleach and leave it for 10 minutes, and then rinsed thoroughly with water. After doing this, or removing the patient from ICU, the protective equipment should be removed by the persons, and it should be disposed very carefully, and then they must wash their hands with liquid soap or sanitizer. But if the PPE or glove comes in contact with the body fluid, then it should be changed immediately. And if there is accidental exposure to blood or body fluids, that is through percutaneous injury or mucocutaneous exposure, then the injured or exposed area should be washed with copious amount of water, and all such incidents should be reported to the supervisor so that he can decide for the management of the injury or exposure or further management. This is the last slide, but not the least. All the procedures should require a good communication with the family members, and it provides a good counseling respecting their sentiment. So then all the efforts taken by the healthcare professionals may be clear to the family members, and some sort of consolation may be offered to them. Thank you very much for your kind listening.
Thank you very much, sir, for your very much informative presentation. I think your presentation will guide us to safe disposal of dead body in this COVID era. Thank you, sir. Now, I'd like to go for our last speaker, Professor Abdul Kader.
Dear
sir, are you ready?
Dear Dr. Montosh, I am ready. By the help of laptop and mobile phone, I will try. There we may have some inconvenience. Please excuse me.
Okay, please continue.
Am I visible?
Yeah.
Am I visible to you?
Can you make the screen larger?
My
ওকে, তোমার কাদের কি এখানে ইয়ার লাইন আছে না, জুমের লাইন নাই কাদের?
technical error.
আচ্ছা ঠিক আছে
Now excuse me, sir. My presentation is about tracheal intubation and extubation in COVID-19 patient. Tracheal intubation and extubation generate aerosol, so it is potentially a high-risk procedure for airway manager and healthcare worker. During these procedures, anesthetists need to be in close proximity to the patient's face and airway during pre-oxygenation and or after extubation. Mask ventilation sometimes becomes necessary in case the patient desaturates. Procedures, especially extubation, commonly are associated with coughing. We should remember three important things. Principle, SAS. S for safe, safe for staff and patient. A for accurate, avoiding unreliable, unfamiliar, or repeated techniques. And S for swift, timely, without rush or delay. We have to be prepared before we do intubation or extubation. What are the preparations? These are, we have to prepare the institution, we have to prepare the team, and we have to prepare the individual. For institution, intubation and extubation is safe in a negative pressure room where the airway flow is more than 12 times air changes per hour in the room. We will have to communicate the plan to all of the members of the team, and the team will contain minimum number of persons, usually 3 persons. We should prepare the airway equipment and drugs outside the room. The best skilled airway manager present should manage the airway, aim to succeed at the first attempt, use reliable techniques. These are all the things which we do to become less exposed to the virus or viral state of the patient. We have to prepare the card. We have to arrange us like the intubator will be in the head end of the patient. The assistant will stand on the right side. The person who is introduce drugs and monitor the patient, he will be on the left side, and the outside the room, one other helping person will be stand. Intubation procedure. We have to establish all the monitoring. The most important is continuous wave from capnography, as because we're wearing the PP, we cannot use the stethoscope to hear the auscultatory sound of the vocal sound, respiratory sound. So we use this continuous wave from capnography. We have to check all the things which are needed for intubation. We have to then we have use our hands like BE manner, and use 2 persons should be engaged for ventilating the patient. One will hold the mask by 2 hands to minimize the leak of gases, and B hold is accepted. You see here B and E pattern, never C and E pattern. Intubation procedure place, we will use the important thing in the case of COVID-19 patient, we will use HME filters, and the HME filters will filter the virus, and we have been exposed less in the viral environment. Then we will use closed circuit section, which will also spread less viral.
Kader bhai, can I interrupt a little bit here? Kader bhai?
Yes, yes.
Just hold. Dear all panelists and attendees, please go to your speaker's view. You see in the right side in the upper top, there is speaker's view. Otherwise, you cannot see the presentation. Go for the speaker view. Click on the speaker view. Can you get my point? No, 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 no,
I'm
not
using
no, no, no.
using
You
the
just
mobile.
no. You just hold. It is not your issue. If
Yes.
all the speaker, all the attendee, if you want to see the, আমার মনে হয় যে সবাই দেখতে পাচ্ছেন না তার প্রেজেন্টেশনটা।
এখন দেখা যাচ্ছে, আমি আপনার কথা অনুযায়ী স্পিকার ভিউতে গিয়েছি এবং এখন ভালো দেখতে পাচ্ছি আমি।
গুড গুড, সবাই স্পিকার ভিউ করে
স্পিকার
নেন,
ভিউতে যেতে বলেন, everybody will be able to see.
আর নাহলে
হ্যাঁ দেখা যাচ্ছে।
go for speakers view, otherwise
I'm sorry
gallery view
for-
you can't see.
For the inconvenience, I'm
Okay,
again
হ্যাঁ হ্যাঁ দেখা যাচ্ছে।
carry on, carry on,
we
carry on,
use
Kader bhai.
HMI filter, then
good.
we'll use RSI technique, rapid sequence induction technique, then to avoid cardiovascular collapse during the induction period, we may use ketamine where it is appropriate. Paralysis will be done, full relaxation we'll use rocuronium or saxabetulium. Then intubation procedure. Do not, we try not to ventilate the patient after giving the muscle relaxant saxabetulium. If needed, if the patient desaturated, we will ventilate the patient with low pressure. Intubate with appropriate size tracheal tube, and the tracheal tube will be pushed 1 to 2 centimeters below the course. Otherwise, it will be introduced on site in the bronchus. So we'll only push 1 to 2 centimeters after the vocal cord we have seen. Inflate the tracheal tube cuff to seal the airway before starting ventilation. Because if we start ventilation before making the seal, then the virus will spread. Confirm tracheal intubation with continuous wave from capnography. Intubation procedure. We usually use the usual tracheal intubation algorithm, and we will keep ready bolus infusion immediately available, as because they may become hypotensive. We should not use which technique we are not used to. We should discard the disposable equipment safely after use, decontaminate reusable equipment fully and according to manufacturer's instruction. After leaving the room, we should ensure doffing of PPE in meticulous way. This is a checklist which we can use and which we can display in the outside the intubating room to follow it, read it and follow it. Here, what we should do with in regards of PPE, then we should prepare our equipment in this manner. We should prepare to make us ready to so that we can prepare ourselves for difficulty. We have some maneuver which we have to done in the room. It is in the protocol, in the checklist, and post procedure the following things should have to be done, which should have been written in the checklist. Now we shall tell about extubation in COVID-19 patient. Clinician should ensure the patient is ready to liberate from the ventilator. The patient will be able to maintain a patent and protected airway following extubation. That is technically and logistically feasible to manage any complications such as the need for re-intubation. Steps in extubation. There are some things which we should follow. This is plan, prepare, perform extubation, and post extubation care. This is an extubation checklist. We should do the perform extubation according to these following points. We should pre-oxygenate. We know actually we uses this protocol in all patients. Perform extubation, then we shall show one thing, how we can minimize the viral spread, which is the main concern for COVID-19 during extubation. We can use an extra mask which is attached to an HME filter. The mask will be applied in the at first the tie of the tube is cut down, then the tube is pushed in the angle of the mouth, one mask ready with an HEV filter from before is applied, and the mask is tightly fitted with the face, and then the face, the tube is extubated, and the HEV filter, here you see two filter will assure more our safety, our more safety. Therefore, we should think where we can use the HEV filter to filtrate the virus, we'll use it. The procedure we all know. Actually, for less exposure, the one person will stand behind the head of the patient. The patient position will be 30-degree head up, then optimizing the anesthetic, face mask seal, attach a second airway filter to the face mask, which we have demonstrated earlier. Then we will show one video which will demonstrate how can we make safe the extubation procedure during the COVID period. Let's watch a video. Let's watch a video which will show some procedures to make the environment safe for the healthcare workers. 3 persons, one near the head in, one on the left side and one on the right side. One polythene sheet is applied on the face and about the chest of the patient. Now closed suction has been done. Now the tie has been removed. Now ventilator off, and the tube, one person is deflating the tube, extubating it, and as soon as extubated, they have put a mask about the face. And as soon as possible, on surgical face mask is applied on the face of the patient. Now, these are the some instruments which are being tried to use in case of COVID patient. This is a tent produced. This is another method to make it lightweight. This is also a tent. All the procedure are used to make the extubation procedure less harmful, for making the viral spread less, so that the healthcare worker can remain safe. On conclusion, we can say intubation and extubation in COVID-19 patients differs from that in non-COVID patients. Obvious risks and challenges of intubation and extubation in COVID-19 patients. Checklist and algorithm for intubation and extubation in COVID-19 patient is the good way. We should remember it. Checklist algorithm for intubation. Checklist and algorithm. Follow the ways and techniques meticulously and overcome the risks and face the challenges. That is in a nutshell about intubation and extubation. Thank you all, and I'm sorry, again expressing my sorry for your inconvenience for technical problem.
Okay, thank you very much for your nice presentation. I think your presentation will help us for intubation and extubation of COVID patients safely. Okay, thank you, sir. Now my humble request to our Kadir bhai, please omit your share screen. Please stop your screen sharing. Now my humble request to our honorable chairpersons to comment on presentations of this session. First of all, I like to request our respected teacher, Professor Wahiduddin Mahmood sir, to comment on today's speaker. Sir Wahiduddin Mahmood sir, please.
Montuzda, sir, Wahiduddin Mahmood sir, just I am taking 10 seconds. Dear all panelists and attendees, please just convert it to change to your view as gallery view, so that you can see everyone. Change it to speaker view to gallery view. Go to the up and right side top and change your view from speaker view to gallery view. Okay, thank you very much. Okay, carry on, sir. Wahiduddin Mahmood sir.
Wahiduddin Mahmood sir. Sir, unmute yourself, sir. Sir, unmute first.
Right, right. Can you hear me now?
Yes, sir.
Can you hear me now?
Yes, sir.
Yes, sir. Okay, right. Right. Thank you for the organizers. Thank you, BSA, for holding this international webinar. And we had an excellent 1.5 hours, I think more than 1.5 hours of 5 speakers. It was really a very absorbing. First was Dr. Abdul Rahman, Professor Abdul Rahman. He talked about available resources, about guidelines in BSA, which was really very nice thing. And plus, very important thing was the available resources. Guidelines has to be made according to the country's resources. Even not only the country, I think the district to district and even hospital to hospital, the guidelines to be made like that to get a good outcome. Next was Dr. Fatima. She was a good speaker. She talked on the oxygen therapy and COVID. Those are the standard things we learned, starting from face mask to up to high flow nasal cannula. Then it was Dr. Arif Hassan who spoke on drugs. I would like to just comment on the drugs. There's a small question to Arif. Can remdesivir be given in the early stages or even on outpatient basis? Is he here?
Sorry for that. Dr. Arif Bhai already left because his mother issue. She is very sick. That's why he left.
Oh, okay, then we just move forward. And then it was, I think, can you hear me?
Can I respond this question, sir?
Yeah, sure.
Yeah. What I feel is antiviral. This is the antiviral drug. So antiviral. So when the virus is active stage, that is the lifespan of the virus is. Please mute, please, everyone. So it's an antiviral. So the lifespan of the virus is 10 days only. So within 10 days, remdesivir, it works very good. But after the 10 days, it will not work at all. So this is the background knowledge. But evidence is not clear yet. What time and what time actually it is indicated. But background knowledge is very clear. When the virus is active in antigenic phase, that is the first 10 days, this is the good time for the remdesivir. Otherwise, it's a wastage of the money actually.
But now they say there is no use of evidence, says there is no use of remdesivir anymore. No effect at all.
Actually, that's what I'm saying. There is a lot of controversy coming around. Actually, whether it has any effect, whether it has effect or which it has to be given in the early stage or later stages, it's still a controversial thing. That's what I wanted to clear with Dr. Arif actually. Anyway, can you hear me?
Yeah, sure.
Yes, sir. Yes, sir.
Carry on, sir.
Okay, right. Right. Okay. Right. I think they'll be good. And then Manos spoke on dispersal of body fluids. And one question to Manos: how long are the body fluids infective? I just wanted to know.
Sorry, sir.
Is Manos around? No. Manos, yes, he's there.
Yes, sir.
Reasonable.
Sir, can you?
Huh?
Sir, can you mute everybody? Only talk the chairman and the question asked to whom?
To Dr. Manos, just a question. How long are the body fluids infective after a patient's death? That's what I want to know. Any study on that?
So I have not get any study, but it is stated that the dead body is not does not infect the persons who transfer it from the ICU to outside. No such study yet, sir.
But can I make it a comment on that?
Sure.
Actually, the evidence shows that if the dead bodies remain in any mortuary or that in up to 24 hours, so after the 24 hours, the viral load will be reduced automatically. As we know that the viral load is very important, and this dead body can spreading the disease only for the 24 hours. That's why these are customs in the hospital that dead body remains in the hospitals at least for the 12 hours. Then they can make it in the body bag and hand it over to the relatives or to the relevant authority.
One thing can I add, Wahiuddin Mahmood sir?
Yes, please.
Yes, it's again the background knowledge when the evidence is not very clear because the disease is very new. On that time, background knowledge is very important to justify that one. So what I am telling, the virus, how many times the virus is alive, that is a very important issue. So when the patient is died, that is after 15 days or 20 days, beyond 10 days, so there is no virus is alive inside the body. Only the body is a inert substance on that time. If on the over the surface, if any new viruses come over the surface, like any table, your other material like this, if new virus comes from the new patients or from the healthcare worker, then it's an issue. It can transmit. Otherwise, the virus that affect that body, that person, all virus already dead because he has been infected 10 days or 20 days before actually. I think got my point.
I can support the Kausar Shaddar also that point because the time is very important. But the test, PCR test, after 20 days, after 13 days, it may be positive.
Bonik, whatever may be, but the thing is the infectivity remains till the 10 days. And they said the virus cannot survive in any body for more than 3 hours. That's why we said it is safe even after 3 hours, except the body fluid.
Yeah, and in response to
I think this is the national guideline. After 3 hours, no, in the fluid or in any part of the body, the virus is not surviving. This is the in the national protocol or guide.
Yes, in response to Bonik sir, one point I want to add, that is the virus, the RT-PCR can be positive up to 37 days. And 37 days after, this is reported the maximum day, what have been reported yet. But that is explained what is the causes of why the RT-PCR is still positive. That is the antigenic dead virus of the antigenicity of the dead virus actually. That is not the notorious actually. They are showing the false positive result. Thank you, sir.
Right, infectivity and RT-PCR has got no relation actually. RT-PCR can remain positive for a long time with dead viruses. So main thing is
most important is infectivity, I think.
Infective, right? So according to Dr.
You are right.
Dr. Maksud, so after 24 hours it's safe. According to Dr. Maksud, it seems. Anyway, I think there will always be a controversy on this because the disease itself is new to the world. And next was it Dr. Kader. He spoke on intubation and extubation. Main thing was his SAS, safe and swift.
After good packaging and everything, it is not usual to remain the dead body in 24 hours in our. There is no mortuary and other things. So we can not recommend that after 24 hours the dead body is hand over to the party or thing. I think after proper packing and everything, and the dead body is disposed after packing. But still
right, okay.
remain in hospital.
Right. Okay. Thank you. And thank you again. Thank you all the speakers and all participants. Thank you for a very interactive session. Right. That's all for me.
Okay. Thank you, sir. Thank you, sir. Thank you for your very important comments. And now I would like to request our second chairperson, Professor A.K. Kamrul Huda. Please, sir, your comments on today's presentation.
Thank you very much. Can you hear me?
Yes, sir.
Yes, thank you very much to the organizer to give the opportunity to play some role in this e-conference, which has been the first in our Bangladesh 2020 conference on critical care medicine. So, as a chairperson of this session, I'd like to thank Professor Wahiduddin Mahmood, who has already covered all the areas, all the speakers' statements, or they have told, on which he gave some recommendations. I just don't like to repeat the comments, but some new comments on some of the speakers. First of all, Professor Abdur Rahman, he has given very elaborate speech. I very much liked his speech, and that is very informative and very much helpful for the care providers. In addition to this, I like to recommend on switch scoring system, which is very much helpful for scoring the patients for admission in ICU. Next speaker was Fatima. She covered all the areas of oxygen device, and she advised one thing in information is that the aerosol generating procedure, the positive pressure ventilation has got the aerosol generating procedure. So you have to avoid the aerosol generating procedure. So you have to keep the device on spontaneous ventilation. You have to give some oxygenation, out of which the high flow oxygen nasal cannula is the best one, which provides PEEP, which can generate some increased FRC, and it increases the oxygenation. As the flow is increased, respiratory rate is decreased, so tachypnea will be diminished. Next speaker is the Professor Arif. He has covered all the areas of present management system. One thing we observed that we have one patient who was getting chloroquine, and he developed prolonged QT interval. So it is very much proven that chloroquine has got some adverse effects, and that patient has QT interval that may precipitate, culminate to any times toxicity point is or polymorphic ventricular tachycardia. So it's very life-threatening situation. So chloroquine has got very disadvantage. So we should not use this drug very frequently. Another drug, remdesivir, has got FDA approval, or European Use Authority has approved the drug. But in case of liver failure or renal failure, we should not use these drugs very frequently. But still then, some question arises whenever we should use this drug, has got some criteria by which we can select the patient for giving remdesivir. So we cannot give it as outdoor basis or mild to moderate degree of patients. When the patient is severe degree of illness from COVID-19 patient, we should give these drugs in that cases. Tocilizumab, another drug which has got some disadvantage. If the patient has got secondary infection from bacteria or virus or fungus, we should not recommend this drug, otherwise patient would die. And last of steroid dose is very controversial. In our setup, we have been using steroid. In case of ARDS, 10 to 20 milligram for 5 days or up to 10 days. And in case of ARDS, we have been giving hydrocortisone. In case of septic shock, we have been used hydrocortisone 50 milligrams 6 hourly. And if it is cytokine release syndrome, we can use steroid or methylprednisolone. Otherwise, CP and other ivermectin drugs, these are not very much useful nowadays and not been recommended nowadays. One thing I repeat, Professor Manoj Bosu, who spoke on the disposal of the dead bodies of the COVID patients from ICU, the debate has been developed that how when the patient is free of infection, when we can be get safety from the patient when touching the patient. It is recommended that after 3 hours, there will be no living virus in the fluid of the body. So the recommendation is that 3 hours, after 3 hours, we can handle the patient very safely. So there will be no risk of getting infection. That's why the huge population, those who have been handling these patients or managing this COVID patient, very few patients got infected of this group of people. It is observation. So we can recommend that it is 3 hours to 3 hours, the patient, the blood body has no capacity to spread the infection. Another thing is that the bleaching powder, Manush Basu recommended bleaching powder, that is calcium hypochlorite. And nowadays in the market is a very available Protex solution, this sodium hypochlorite, which is very cheap. Only 5 liters only cost 200 to 300 taka. And that can be diluted up to 50 times. And the 50 ppm to 100 ppm is very much effective to kill the all organism, including spores and others. So prepared solution is available in the market, so we can use Protex solution in place of calcium hypochlorite, which is Protex solution is better than that of the bleaching powder. So we can get the prepared solution from manufactured company, so we can use very easily for this. So thank you very much for giving me the opportunity. Thank you all of the speakers who have given this speech.
Okay, thank you, sir. Thank you, sir, for your nice comment and information. We are already short in time. So lastly, I am requesting our last chairpersons of this session, Professor Saidur Rahman, sir, please. Professor Saidur Rahman, sir, please. Sir, unmute yourself first. Sir, unmute.
Yes, already done. With the permission of President, Secretary, and moderator of this session, I'd like to say that I won't talk much on all the topics. I only highlight a few problems to those who are working in the peripheral hospitals. This, what Professor Rahman has said, the criteria and policy of ICU admission of the patients should disseminate to the society, to the administrators, both health and civil administrators, and the others. You can see an alarming situation in the peripheral ICU that COVID and non-COVID patients are treating in the same ICU. And the doctors, the hospital, they are in very much pressure of this from these local elites and like this. So this should be, there should be a propaganda or like this, that this should be the criteria of admission of the patients in the ICU for the COVID patients. Thank you all.
Okay, thank you, sir. There is a question to Professor ASM Arif Hassan, sir. Sir is here or already left? There is a question to Arif, sir.
Yes, he has left the session.
One question, can you answer?
Dr.
Arif is absent, you just...
Dr. Montosa.
Yeah, just have one question.
You can share the question if anybody can answer.
Okay, okay. Okay, sir. Thank you.
Dr. Montosa.
This is the end of our session 4A. Okay. And now I am handovering to our respected Secretary General of BSA, Professor Kausar Sordar, to continue the next session.
Okay, thank you very much for your nice conduction. I thanks all the chairperson and the speakers of that session. It was very interesting session. We enjoyed a lot this session, and it was on our guideline what we have published in with the DGHS for the COVID ICU management. Thank you very much all. We are already 45 minutes down from our exact time, so it will affect, I think, total program. So from the next session, I would like to request Dr. Javed. He will conduct the next session. He will control the thing very nicely, and this is a very interesting session. I think everybody will enjoy it. It is based on actually sharing of the COVID ICU experience in Bangladesh. We have added here all the head of the departments of where the ICU, COVID ICU is there. government, non-government, and autonomous. All we have included. So I think you will enjoy this session. I would like to request Dr. Javed to continue. Javed is the organizing, is the Office Secretary of Bangladesh Society of Anesthesiologists.
Thank you, Honorable Secretary General, Professor Dr. Shandar sir. Dear respected chairperson, faculty, speakers, and participants from home and abroad, Assalamu alaikum and good evening. I am Dr. Mohammad Javed, Assistant Professor in Science Church, Department of Anesthesiology, Pain Medicine, and Intensive Care Unit, and now attached in as a Deputy Program Manager of Hospital Services Management, Directorate General of Health Services. Now I am moderating that session. At first, I welcoming you to all in second day of first International E-Conference of Critical Care 2020. In today's session, the topic is sharing of COVID ICU experience in Bangladesh. Actually, due to shortness of time and for smooth continuation of this session, I would like to request my honorable speaker will try to complete their papers within 3 minutes time. We'll appreciate the question. Sorry. Can you hear me?
Yes.
Can you hear me, please?
Yes. And continue, Javed, continue.
We'll appreciate question and answer session after completion of the presentation. If you have any query, please note your question in chat box. Now I want to introduce the chairperson and honorable speaker of this session. At first, I humbly request for charging the chair of this session today, Professor Brigadier General Richard Rabia Khanum Madam. She is now working as a head Department of Anesthesiology, Intensive Care and Pain Medicine, Shohid Captain Mansur Ali Medical College Hospital. Our another honorable chairperson, our mentor and senior anesthesiologist, Dr. Rokeya Sultana, senior anesthesiologist and Health and Population Affairs Secretary, Bangladesh Awami League. Our another chairperson, Professor Dr. Debabrati Bonik sir, our mentor, our teacher, ex-chairman, Bangabandhu Sheikh Mujib Medical Vishwavidyalaya, and our honorable president, Bangladesh Society of Anesthesiology. And Dr. Muhammad Monjur Haq Loskor sir, our senior anesthesiologist, our mentor, and our teacher. And I now want to introduce our honorable speaker of this session, Professor A.K.M. Akhtaruzzaman sir, our mentor, senior anesthesiologist, our teacher, and chairman of Department of Anesthesiology, Pain Medicine, and Intensive Care Unit, Professor Muzaffar Hussain sir, head of the Department of Anesthesiology, ICU, and Pain Medicine, Dhaka Medical College Hospital, Dr. Muhammad Anisur Rahman, head Department of Anesthesiology, Intensive Care, Pain Medicine, Muga Medical College Hospital, Dr. Sadat Hossain Masoom, head Department of Anesthesiology, Intensive Care and Pain Medicine, Kurmitola General Hospital, Dr. Muhammad Akhtaruzzaman, Assistant Professor and Consultant, Kuwait Bangladesh Friendship Hospital, Professor Ranjan Kumar Nath, head of the Department of Anesthesiology, Chittagong Medical College Hospital, Dr. Nitai Chandra Sarkar, Shohid Ziaur Rahman Medical College, head Department of Anesthesiology, Dr. S.K. Fariduddin sir, head and Department of Anesthesiology, Ullah Medical College Hospital, Dr. Ahmed Musal Anam from Square Hospital, Dr. Muhammad Jafar Iqbal from Evercare Hospital, Dr. Rehan Uddin Khanum sir, Associate Professor and Head of the Department of Anesthesiology, Intensive Care and Pain Medicine, Sheikh Rafael Gastro-Liver Hospital, Dr. Muhammad Ataur Rahman from Kumilla Medical College Hospital, Dr. Abu Hena Mustafa Kamal sir from Rajshahi Medical College Hospital, and last one, Dr. Mehdi Ahmed Munna, Silet Osmani Medical College Hospital. At first, I now inviting our
Can you see me?
Sir.
Yeah.
Yes, sir.
Can you see me?
Yes, sir. Yes.
Okay. Respected chairpersons, my colleagues, ladies and gentlemen, on behalf of the Department of Anesthesia, Analgesia, and Intensive Care Medicine, I welcome you in this sessions. I must thanks to our BSA Scientific Committee to give me the 3 minutes in for giving me on the ICU activities BSMMU. As you know that we have started our ICU about the 3.5 months before in the July 4th of this year, and so far we have admitted 2,440 patients. That is and out of them, the 63% admitted in the patients appearing at the driest area of BSMMU. And we have that death rate so far in the BSMMU is the 249, and out of that, 165 is from our intensive care unit. Let me, can you hear me? Hello?
Continue, please. Sir.
Yes, sir, we can
hear you. Yes,
okay,
carry
thank
on,
you. Just I have closed my sharing. Just give me a just I have
just it's okay, but have to go for the slideshow only.
Yes,
slideshow in the downside.
Yes,
down in the
I know
bottom. Just bottom. There is a slideshow.
You just
no arrow will be in the bottom side. There is slideshow. Just click on slideshow. Yeah.
That one. Beside. Yes, sir.
Just slideshow.
Not here.
It is bottom right side. A little bit left. No. Bottom. Yeah. Bottom right side. Bottom the right side. First note, then comments, then 4 box, then slideshow.
Just a minute. Yeah.
It's okay.
Okay. So, what are the challenges during when we start our intensive care unit for the COVID patients? First of all, our challenge is it makes the zero infection rate for the healthcare workers of my universities. As you know that there is a journal that JAMA network published in the 2020 that the healthcare workers in the Netherlands, they have their infection rate is around 6.25%. But in our hospitals, we have the overall infection rate is about 0.85%. How we can make it possible? We have changed the intensive care unit to some structural changes and to some the teaching and practice sessions is also. So we start the stand-alone HEPA filter in our ICU, and we make it is a separate donning and doffing area for the healthcare workers of our universities. And of course, we giving the full protective gears for all the staffs in the same way. Regarding the teaching, we have published our practicing our COVID ICU management protocol in our own. This protocol giving us the guiding the oxygenations, that is the most important for the COVID patients, especially how to use the high flow nasal cannula And we started a special CPAP machines. We call it the CTEX CPAP machines, and sometimes we're using the non-invasive ventilations. Regarding the steroid, especially the dexamethasone, dexamethasone is a drug of choice for the moderate to critical COVID patients only. And initially, we have started the 10 to 20 milligram a day, but after the recovery trial from the WHO, we have changed our protocol to make it in the 5 to 10 milligram once daily dose, not for the 5 to 10 days. Regarding the new drugs, that is a procedure now. So we are not using these drugs on and off because we have the facilities to estimate the IL-6 levels in our university. So that's why we are not using these drugs too much. We use the antiviral, of course. It's not more than 5 to 10 days. Antibiotics as our university policy, and we give the special area on the blood sugar management. As you know that this patient has got some steroids, and he or she is developing the high blood sugar levels. Regarding the fluids, this part is neglected here. So we usually give the liberal fluid therapy in the early part, that is after the admission of our intensive care unit, and after that we balancing it according to the needs. And physiotherapy is very much important in the intensive care unit, especially in the COVID intensive care unit. And we have assigned especially graduate physiotherapists for this purpose, and we boost up some. And supervision is very much important for managing the COVID patients. As you know that we are afraid of from the giving the on and off the in-person round. But in our ICU, besides the daily healthcare workers, physicians, nurses, and physiotherapists and lab technicians, one of the associate professor is taking care of this day, and he is going to the in-house, giving the in-person around to the intensive care units and make it possible to the any suggestions giving to our junior physicians and at night we are again make it is a consensus meeting with our faculties and all the members of our department on the virtual meetings. So in every day at the 10 to 11 p.m. we are discussing in the individual patients and make some decisions, either they continue the same treatments or make it in the some changes. So as you know that COVID is a new disease in the world, and we are learning a lot from with the times. So in our departments, we make it possible to make some research on different aspects of the COVID patients. Especially, we make some observational studies, that is we call the case fatality trial. We make it some academic research on the association between the D-dimer and outcome of COVID patients in ICU. And we are making another trial on the cytokine storm prevention by using the steroids and specific drugs. These hospitals is we are making special newer equipment trial in my departments. We call it the new CTEX CPAP machines. Is a joint or collaborative research from the UK, OLC universities. And we are starting our second research on the same university. We call it the virtual COVID ward with the help of the software.
Sir, please unmute yourself. please unmute yourself. Yes, thank you.
And we are taking another research on the powered air purifying PAPR also, yeah. So some few important things that we could change it in our ICU like that. So as you know that we are using a lot of medications. There is some psychological trauma to the patients, and that's why there is an increased rate of delirium. And in our ICU, we change this rate of delirium by reducing the dose of steroids. Initially, we are using the 10 to 20 milligram of steroids, and there is chances of delirium is increases and blood sugar changes. So we make it in the 5 to 10 milligram, and now the delirium rate is reducing. Second is the oxygen escalation system by giving the ROX scale calculation. It's mandatory. Because of that, this COVID patient is coming here with the hypoxia. So this patient, if the patient is hypoxic for a longer time, the results, the mortality and morbidity is increased. That's why we are giving the special emphasis on the shifting the non-invasive ventilation to some extent in the positive pressure ventilation like the CPAP or NIV, and physiotherapy as I call it earlier. So why it occurs while the patient is hypoxic here when he or she admitted in the hospital. In our
temporary unmuted at the second.
We are the refusal of the invasive ventilation is one of the obstacle here. Late admission is another obstacle, and remain hypoxic for a longer period and then refer to the ICU as these are faulty referral systems. And don't follow ICU referral. So it's another pitfall our managing intensive care unit. So this is my last slide. This is the slogan from the WHO. Also the wear protective mask, stay safe, break the chain. Thank you once again, Mr. Chairman and BSF for giving me the opportunity to say a few words. Thank you.
Thank you so much, Professor A.K.M. Akhtaruজ্জামান sir, for sharing your experience in ICU COVID ICU in Bangladesh. May I request now our another speaker, our mentor, senior anesthesiologist, Professor Muzaffar Hussain sir, Professor and Head, Department of Anesthesiology, Pain Medicine and Intensive Care Unit, Dhaka Medical College Hospital. Professor Muzaffar Hussain sir. Sir, please unmute yourself. Can you hear me, Professor?
Yes.
Sir?
Dr. Javed.
Thank you, sir. We are hearing you.
মুজাফর দেখা যাচ্ছে, স্টার্ট করো।
Carry on, sir.
You can start. মুজাফর স্টার্ট করো। মুজাফর স্টার্ট।
Just a minute. Thank you, Dr. Javed. First speaker, my friend, Dr. Akhtaruজ্জামান has taken 27 minutes. So is it 3 minutes? So if it is 3 minutes, I'm not going to details.
But it was 3 minutes, you can just to maintain account. Beyond, we are already behind half an hour.
Thank you. I am talking about the only ICU, not beyond the ICU. We know the Dhaka Medical College Hospital is the largest hospital in Bangladesh. It is 2,600 beds. We started the COVID management in this hospital from last May last May 2020. So through the two ICU, through two building, one is COVID-1 building, that is we call it surgical COVID. It is 300 bedded hospital with 10 bedded ICU and four operation theater. And another COVID-2 building, it is DMC's 2 building, it is non-surgical hospital, COVID hospital, which is 600 bedded and 16 bedded ICU we have. Both of this ICU from the May 20, total admission was 401. Total death was 240. That is 59.85%. That's almost 60%. Total patient on ventilator was 114. That is 28.4%. So I am not going details. Just I am telling about some problem we have faced. First problem was the protective measure. We know that there are so many questions about the personal protective equipment, mask, etc. In national, that was once time, that was the national issue. Protection from the high generating aerosol and air dispersion from the oxygen equipment and from the ventilators. That we have managed by, in case of high flow nasal corona, just put a double surgical mask on the patient. Protection from the high aerosol protection from the ventilator, we are providing some filter on ventilator and circuit. And we have managed some plasma sterilizer on the wall of the ICUs. And we are using the video laryngoscope. Totally, initially we had no high flow nasal cannula machine. Now we have gotten 6 high flow nasal cannula from donation. One is made in New Zealand, Fisher Packen is functioning. Another 5 is from Chinese origin and not good function. Luckily, we have 35 ventilators having high flow nasal oxygen therapy facilities. We are comfortably using these ventilators. And Dr. Akhtaruজ্জামান has said details about the management. We are also following the almost same protocol, oxygen therapy from the various oxygen giving apparatus, like cannula, mask, and then high flow nasal cannula, NIV, last of all is ventilators. We are maintaining the principles, prone position, using anticoagulant, empirical antibiotics, and also steroid. We are following the protocol of steroid, except if we use dexamethasone, it is categorically 6 milligram per day. If we use methylprednisolone, it is 2 milligram, 32 milligram per day. If we use hydrocortisones, we use 160 milligram per day, and others than. So probably I can finish within the 3 minutes. Thank you all.
Thank you so much, Professor Mujaffer sir. Now I would like to request Dr. Mohammad Anisu Aman sir for sharing her experience in COVID ICU. Dr. Mohammad Anisu Aman sir. Can you hear me, Dr. Mohammad Anisu Aman? I think
Roman, Mukta Hospital.
From Mukta Medical College Hospital, Dr. Mohammad Anisu Aman. I think later he will join with us. Now I invite Dr. Mohammad Akhtaruজ্জামান, consultant, Kuwait Moitri, Bangladesh Friendship Hospital, Kuwait Bangladesh Moitri Hospital. মোহাম্মদ আসাদুজ্জামান।
Thank you, Javed. First of all, I like to show my gratitude to my mentor, Professor M. Abdur Rahman, and my ex-head of the department, Professor M. Muzaffar Hossain, because when I was transferred to Kuwait Moitri Government Hospital um, as a critical care specialist to develop ICU for COVID-19 patient in Bangladesh. Uh, this both my mentor helped me a lot to establish my 26-bed ICU for COVID-19 patient in Bangladesh. Uh, uh, at 30th March, first patient entered into my COVID ICU who required invasive ventilation, but unfortunately he died within a week. Uh, uh, at the we began firstly in Bangladesh, and first time we dealt the seriously COVID ARDS patient, and as a protocol that were given at that time, we are trying to manage the patients by giving mechanical ventilation. But within 15 days, the maximum patients were dry. We are given to mechanical ventilation, and I thought mechanical ventilation will not work. Then I talked to with my some colleagues of critical care medicine, and that time assistant professor of medicine Dr. Moinuddin was admitted into Kurmitola Hospital. That time he was suffering a lot. Then we tried with the Society of Medicine to find out a high flow nasal cannula for him. So unfortunately, that time no high flow nasal cannula was available. That time he was given to mechanical ventilation. All you know, he died from mechanical ventilation. This thing struck me again, and then I tried to find out some high flow nasal cannula who delivered this high flow nasal cannula to Bangladesh, Fisher Paykel, the original company, Yarvo 2 from New Zealand, and I contacted with them. And at that time, they delivered 6 high flow nasal cannula to CMSD with the help of UNICEF, and then I take 4 high flow nasal cannula from CMSD, and we are using that high flow nasal cannula, and it was working tremendously. Then we tried to give up the patient to giving mechanical ventilation, and we are giving the only high flow nasal cannula and non-rebreather mask. The outcome is that time very good, but at the time of June, the mortality of my ICU and high flow, at that time high flow was not working. Then we are thinking again, what should we do? Then we are giving the patient in NIV, and some patient who are felt they are maintain their saturation to high flow nasal cannula, but can maintain saturation in NIV. And from the June, we are now using the high flow nasal cannula, NIV, and non-rebreather. But we are not giving any mechanical invasive ventilation. We are explaining to the patient relatives and the patients, and we are trying to avoid invasive ventilation. Till September 2020, we are treated 289 patients. Out of 289, 139 patients survived and 138 patients died and one patient took to DORB. So almost the recovery rate is 50% in my ICU. Thank you, BSA, for inviting me, for sharing my experience in COVID ICU. Thank you again.
Thank you, Dr. Mohammad Asadujaman, for sharing your experience in COVID ICU. Now I would like to request Professor Ranjan Kumar Nath from Chittagong Medical College Hospital. Professor Ranjan Kumar Nath.
Thank you, moderator, Dr. M.D. Javed, to give me the floor. Respected chairpersons, all the learned participants, very fine good afternoon. First of all, I give thanks to the Honorable President and Secretary General of World Federation of Society of Anesthesia for arranging such a wonderful international e-conference. And I also give thanks President and General Secretary of Bangladesh Society of Anesthesiologists for conducting the e-conference. This pandemic has made to rethink about healthcare system. A million of people have already died and the number is increasing day by day. It has proved that lots of things to be discovered and invented as well. Chittagong Medical College Hospital is a tertiary care hospital which represents large population of Bangladesh. It is dedicated for both COVID and non-COVID patients. We started a makeshift COVID ICU of 10 beds at the last week of May 2020. High flow nasal cannula, which is recognized as a popular source of oxygen delivery device for COVID-19, are not much available initially. Later, we collected from many sources. Now we have more than 30 high flow nasal cannula devices. Initially, when we started to use high flow nasal cannula, the central pipeline pressure was reduced in COVID dedicated zone. Later, new VIE, that is become insulated evaporator with pipeline oxygen delivery system, was installed and pressure increased to normal. Our healthcare providers were not trained at the beginning. Now they have gathered much experience. We had limitations. We solved them successfully. We are now well equipped with adequate high flow nasal cannula, CPAP, ventilators, infusion pump, etc. And we have a group of energetic frontliners. Till 11 October 2020, we have received 94 patients in COVID ICU. Among them, 68% are male, 32% are female. Our COVID ICU death rate is 64%. Most of the patients died are having different comorbid factors and chronic kidney disease, etc. We applied high flow nasal cannula 277 of our patients as a first line oxygen therapy modality. 26 of them respond well and were cured. Non-rebreather masks, non-NIV like CPAP and BiPAP were also introduced, but success rate was minimal. We intubated 11 patients out of 94 admission in ICU, but outcome was not satisfactory. We started to get benefit from digitalization, which was dream of our Honorable Prime Minister Sheikh Hasina. We are getting updates regularly using guidelines, webinar, modified our treatment protocol. This e-conference has created the opportunity to share our experience standing in the same platform. To conclude, I will say that this is human against invisible but not invincible opponent. We already have lost many of our warriors. They are our heroes. The heroes never die. We are hopeful for the success in ongoing war till we are united. And with the quotation from Time magazine, we must get it into our heads that our lives have changed. Thank you very much for patient hearing.
Thank you so much, Professor Ranjan Kumar Nath sir, for sharing your experience. Now I would like to request to Dr. Nijay Chandra Sarkar sir from Shahid Ziaur Rahman Medical College. Professor Dr. Nijay Chandra Sarkar. Can you hear me, sir? Dr. Nijay Chandra Sarkar.
Thank you. Can you hear me? Hello?
Yes, sir. Yes. Carry on, sir. We all are hearing you.
Good afternoon. Respected chairperson of the today's session, delegate from home and abroad, special thanks
Unmute, please.
Please unmute yourself. Please unmute yourself.
Unmute karo. You unmute. Nitai. Unmute yourself. Thank you.
Hello? Shona যাচ্ছে?
শোনা যাচ্ছে। Carry on, please.
From beginning, we are serving the share on the phone. Hello? Hello? Can you hear me?
তুমি স্ক্রিন শেয়ার করছিলে সেটা স্ক্রিন শেয়ারটা বন্ধ হয়ে গেছে।
শোনা যাচ্ছে স্যার?
হ্যাঁ শোনা যাচ্ছে কিন্তু স্ক্রিন শেয়ার করছিলে যেটা সেটা বন্ধ হয়ে গেছে। Please share your screen. Please. And now it is okay. Now
okay.
Now it's okay.
Initially, we start our service in the Shahid Ziaur from Mohammad Ali Hospital, 250 bedded COVID hospital. There was no ICU bed. From the help of Shahid Ziaur Medical College, we started 10 bedded ICU bed in the Shahid Ziaur Medical College. There at least 105 patients admitted in the Mohammad Ali Hospital, recovery 41 and death 46 patients. And from July we start our activity in the Shahid Ziaur Medical College. Here we
Dr. Nijay sir, please sorry to interrupt you. I think due to shortening of time, slide presentation can be omitted. Just sharing your view and experience in COVID ICU in Bangladesh. And just only 3 minutes. Yeah.
Hello, we started our
carry on.
In the ICU Shahid Ziaur Medical College. We start 2 new ICU, new COVID ward. So shortage of facilities, shortage of trained nurse and intensivists. We anesthesiologists carry on both sides, COVID and non-COVID ICU. So we taking from the help of the BSA, Bangladesh. I train some doctors every weekly before going to the COVID ICU. Totally we train 105 doctors and 31 sisters. Now we share my experience. We arrange 14 high flow nasal cannula, 10 ventilator, and continuous ICU doctors in ICU. Total admission in the Shahid Johar Medical College Hospital, suspected and positive case 850. 850. Recovery 700, and around ICU admitted 190 patients, referred 20 patients, and then 84 patients in Shahid Johar Medical College. Here, most of the patients refused to ventilator. They want high flow and high flow with non-rebreathing mask. They are not agreed to intubate and high flow. Where in limited nurse and patient ratio 1:0.5. Really, we try to enrich our nursing support, but limited due to limited nurse, we are not having such a noise. Thank you to give me opportunity to share my experience. Thank you.
Thank you, Dr. Nijay Chandra Sarkar sir. Now I would like to request Dr. S.K. Fariduddin sir from Khulna Medical College Hospital. S.K. Fariduddin sir. Can you hear me, S.K. Fariduddin sir? I think later he will join with us. Now I would like to request Dr. Mohammad Musal Ano from Square Hospital. Dr. Mohammad Musal Ano from Square Hospital.
Thank you, Dr. Javed. I hope you can hear me all. And honorable chairpersons of this session and the learned audience, thank you very much for giving me this opportunity. So in Square Hospital was one of the most earliest private hospital to start with a COVID unit, starting in a separate building. And we started with only 8 beds of ICU at first, but as the necessity increases, we expanded it to 25 bed. And we have enough ventilators and 15 high flow nasal cannulas that we are using. Till now, that means yesterday, we have had admitted 1,596 patients, and among them, 302 were in ICU. And we are very happy to say that our survival rate of ICU patients are about more than 66%. We are mostly using the high flow cannulas, not using invasive ventilations much. And we are using adequate appropriate medications, especially the antivirals, steroids, and to some extent, where as per indication, tocilizumab and baricitinib, the anti-inflammatories, and we are really getting very good results on that. I believe all the learned audience would be encouraged to use those. And we have been, we have got referred patients from different parts of the country, especially the other parts other than the capital, and many hospitals from government and non-government hospitals in Dhaka city also. We have what we have found difficult that sometimes most of most of the other patients that being referred from other hospitals, the secondary infections are very high. The hospital-acquired infections, and those are the patients that are getting not surviving with all the cares we can provide. And also we feel that we were not following a common guideline in all the hospitals of Bangladesh. We believe, we in Square believe, if we could have had a common guideline where every patient could get the same treatment, it would have been beneficial. That's the experience I can share at this moment from Square Hospitals, and good health to everybody. Thank you very much.
Thank you so much for your nice sharing, for your nice experience with our Dr. Ahmed Mursalano. Now I would like to request Dr. Mohammad Japur Iqbal from CARE Hospital. Dr. Mohammad Japur Iqbal.
Assalamu alaikum and very good afternoon. Thank you, Dr. Javed. Are you hearing me?
Yes, we all hear you.
Thank you very much for your nice introduction. And as I got the instruction, I am not go through the slide sharing. Thanks BSA for having me here. With due permission of honorable chairs and faculties and respected panelists, I would like to share my COVID critical care experience. CARE Hospital, former Apollo Hospital, is a tertiary care hospital, and we started our COVID IC with 8-bedded after getting the government clearance by May. Now we are running a 20-bed ICU SDU with full capacity, COVID dedicated, and over the last 5 months, we handled around 350 patients in critical care area. In terms of our experience, if I show my demographic data, most of the patient average age was 55 years, and 2/3 of the patient was male here, and our overall survival rate was 68%. And in terms of support, approximately 72% patient get advanced respiratory cares, and 30% patient get advanced cardiovascular support, and 10% get the renal replacement therapy. If I want to share my experience in terms of treatment, I would like to say the oxygen therapy, almost 60% patient has got high flow nasal canal oxygen therapy. And among this, the failure rate of high flow nasal canal oxygen therapy was 22%. And this 22% patient get ultimately ventilatory support. Only a couple of patients who have managed non-invasive ventilation, and few of patients do not intubate consent, so they are not intubated. In terms of therapy, others like steroid therapy, after a lot of debates and adjustment, readjustment, our institutional guideline is dexamethasone, if no contraindication, 5 mg BRD, and we are getting a good result. If any CT scan or disease process is aggressive or early fibrosis, we are extending the steroid therapy for longer period. In terms of blood thinner therapy, we are using our low molecular weight heparin, and if D-dimer is more than 2 times in our therapeutic range, in our normal range, we are giving a therapeutic, that means 1 mg per kg BID, and if it is less than our therapeutic range, less than 2-fold, then 1 mg per kg once in a day. And we experience only three patients with hemorrhagic complication, like 2 retroperitoneal hematoma, 1 was in the arterial side hematoma. We nicely managed, and no casualties regarding the blood thinner related. Regarding the antiviral, we all know that most of the patient get ICU admission after 9 or 10 days. Minimum effect of antiviral here. If we get any patient before 8 days or 9 days, then we start the remdesivir straight away. Special therapy, we are using the tocilizumab as cytokine release syndrome related. We have the all inflammatory marker, and inflammatory marker guided. We are using the tocilizumab. We are getting a good result. So we are still using it, though the using of tocilizumab is in a down trend. Regarding the convalescent plasma, our experience is we are still using the convalescent plasma if the patient landed ICU before day 10 and the disease process is aggressive. And other special therapy like cytosol therapy, we have 3 patients with cytosol therapy experience. 2 of the patient was AKI with maintenance dialysis with concomitant bacterial sepsis, and we have got 2 positive result, and another patient was hepatorenal syndrome. This patient we have the negative result. Regarding the immunocompromised patient, we are using the IVIG quite frequently. We can say especially patient with kidney transplant, patient with hematological malignancy, or patient with radiotherapy, chemotherapy. We are using the IVIG therapy and we are getting the very promising result, especially multi-system inflammatory syndrome related baby. We are using the IVIG very frequently and we are getting the result. In my final comment, the treating of the COVID critical care patient is not evidence-based practice, it's the experience-based practice, and day by day we are gathering our experience and we are reducing our death rate and the infectivity rate of our healthcare worker. And in Bangladesh, my final conclusion, we need a ECMO center and we are desperately looking for this. Thank you very much. Thank you, BSA, for having me here. Thank you.
Thank you so much, Dr. Jafar Iqbal. Now I would like to request Dr. Rehanuddin Khan, Associate Professor and Department Head of the Department, Sheikh Russell Gastro Hospital. Dr. Rehanuddin, can you hear me? Dr. Rehanuddin Khan, please unmute yourself. Please unmute yourself. Dr. Rehanuddin Khan, please unmute yourself. Unmute yourself. Can you hear me, Dr. Rehanuddin Khan? Please unmute yourself.
Hello. Hello.
Yeah. We all are hear you.
শুনতে পাচ্ছেন? The respected teacher and my dear colleague, Assalamu alaikum. আসতেছে নাকি? না, এটা দেখতে আসে না।
কি দেখাতে যাচ্ছে?
শেয়ারিংটা
এটা তো যাও এই যে সমস্যা।
জি। Sheikh Russell Gastro Institute and Hospital is a tertiary level referral hospital for patients suffering from gastrointestinal, hepatic, biliary, and pancreatic disease. It has gastromedicine, gastrosurgery, anesthesia, intensive care medicine, radiology, and imaging and laboratory medicine. At present, in COVID-19 pandemic situation, government has dedicated it as a declared full-fledged COVID-19 hospital, which provides services for mild, moderate, severe, and critically ill COVID patients. In this hospital, there are 250 beds, among them 160 beds dedicated for COVID patients, including 16 ICU beds. COVID-19 ICU service started from 13 June.
Sorry, interrupt you, Dr. Rehanuddin Khan. Not sharing any slideshow. Please just sharing your experience within due to shortness of time. 3 minutes. Only just sharing your experience. Please omit the slideshow.
ICU admitted patient, total patient 173, transferred to the ward and cabin 84, and death 82, and current admission 7. Outcome of the patient, survival rate about 52%, mortality rate about 48%. আচ্ছা, ম্যানওভার আমাদের ম্যান পাওয়ার স্ট্যাটাস, অ্যাভেলেবল ইকুইপমেন্ট সেগুলো আছে। পেশেন্ট হু রিসিভিং অক্সিজেন থেরাপি থ্রু ডিফারেন্ট ডিভাইসেস। Out of the 173 patient, high flow nasal cannula 60 patient, non-breathing mask 73 patient, CPAP 30 patient, and mechanical ventilation 10 patient. Percentage of the mechanical ventilation 60%, CPAP 17%, high flow nasal cannula 35, and 42% non-breathing masks. Want to share some experience. COVID-19 positive with other comorbid such as ages patient, hypertension, diabetes, COPD, CKD, and cancer, mortality rate is more than other patient. Outcome of invasive ventilation of COVID-19 patients in our hospital is not satisfactory. That means survival rate is almost 0.
Out of the non-invasive ventilation, CPAP and BiPAP relatively good. That means recovery rate nearly about 40%. Outcome of the high flow nasal cannula is very good. That is recovery rate near about 60%. Some experience regarding to the medical management COVID-19 ICU patient. Only steroid and low molecular heparin and other supporting management. Then my experience, the antiviral drug remdesivir and interleukin-6 tocilizumab is no specific positive outcome in our ICU. Congratulations and heartfelt thanks to Bangladesh Society of Anesthesiologists for among first international e-conference and critical care 2020. Thanks.
Also thanks to you, Dr. Rihanuddin Khan.
আমি একটু
for
শেয়ার
sharing
শেয়ার
this.
শেয়ার দেখাতে চাই একটু দেখানো
চলে
যাচ্ছে না,
যেতেছে। কি যাচ্ছে?
এই যে এটা দেখাতে যাচ্ছে।
কি দেখাতে চাও? মানে কিছু নাই তো।
Sorry, already finished your time. Due to
জি না
talking or-
এখানে
Thank you so
আপনাদের জানার জন্য বলি যে আমাদের শেখ রাসেল 16 বেডের আইসিইউ বেডের মধ্যে আমাদের 2 বেড হলো ডায়ালাইসিস বেড এবং আমরা অনলি 1 পেশেন্ট ডায়ালাইসিস আমরা সম্পূর্ণ করেছি, যেটা আপনাদের জন্য আমরা ঢাকায় বোধহয় একমাত্র আইসিইউতে যেখানে আমরা ওই কোভিড পেশেন্ট ডায়ালাইসিস করতে পেরেছি এবং তার আউটকাম ইজ 100% বেটার এবং তাকে আমরা স্টেপ ডাউন করতে পেরেছি আইসিইউ থেকে।
Thank you, Dr. Rihanuddin Khan. Now I would like to request Dr. Mohammad Ataur Rahman from Kumilla Medical College Hospital. Dr. Mohammad Ataur Rahman, please unmute yourself. Dr. Mohammad Ataur Rahman. Can you hear me, Dr. Mohammad Ataur Rahman? Please unmute yourself.
Javed, he is unmuted. He is unmuted, but I think problem in the device. I think for the next one.
Okay.
I think in the earphone. I think earphone problem.
Thank you. I would like to request Dr. Abu Hena Mustafa Kamal from Rajshahi Medical College Hospital. Dr. Abu Hena Mustafa Kamal. Can you hear me, sir?
Thank you. Thank you very much, Dr. Javed.
Please within 3 minutes because our next session. Thank you so much, sir.
Thank you very much, Dr. Javed. Thank you all. And respected chairperson, co-chairperson, moderator. I am Dr. Abu Hena Mustafa on behalf of Rajshahi Medical College Hospital ICU. I like to get privileged to hear COVID ICU experience in Rajshahi Medical Hospital, Bangladesh. The Rajshahi city, here Rajshahi Medical College Hospital. Now Rajshahi is a green and clean city of northern western part of Bangladesh. Rajshahi Medical Hospital established in 1958 for 530 beds. Now it is 1200 beds. In the ICU, Rajshahi first established 2011, only 2 beds. It is the first published hospital ICU from serving this region, Rajshahi, Rangpur and Khulna division. It was first ICU ventilator used in Rajshahi Medical Hospital in 2007 in post-operative patient management by me. At present, it was actually 10 beds from September 2014 to now. It is our old ICU for before COVID ICU. Now we change our structure for our ward setting, necessary equipment and facilities, and committed area, contaminated area, strictly contaminated area changes, buffer zone also established. Now this is our ICU where steel high glass separate for each bed, and also we have 3 negative pressure room. It is another point, so different points of access should be set for medical staff and patient, making sure that I will arrange a separate gate for entering the staff in ICU. We also, for infection control, especially COVID-like infection, we use medical fogger machine, where we use flow-tech solution for every disperse of patient from each unit, each bed. We have changed our ICU staff. Also, it's the same. Most of the country same. Our first patient is admitted in Rajshahi Medical Hospital 27 April. And after this April, May, and June, we have only 45% survival rate, or actually 55% death for that time. But from July to September, reverse the situation. We are now survival rate 57% and death 47%. And below 50 years, we have 73% survival rate in our ICU, 27% only death, and above 50 years, 45% survival death, and 55% survive. We also, for our staff, we arrange a program for fit test procedure assessment with home-made assessment kit to frontline COVID-19 healthcare workers, and with the ethical permission of our Rajshahi Medical College ethical committee. We have done 35 doctors, nurses, ward boy and ward boy cleaners also attend this test, and I will may publish this article within very few days from internationally. We have used a checklist for personal protective equipment in donning area in our ICU, but unfortunately, we for 3 doctors, Dr. Abdul Rahman, Dr. Mustaq Ansari, and Dr. Mohd Aftabuddin are lost in our ICU, Rajshahi. But out of 18 doctors and senior staff nurse admitted, but they are survived. We in here, Rajshahi, we use that heroes working here, Rajshahi Medical College Hospital. It is a great slogan in our Rajshahi. And thank you very much. We want to good morning in next day. We ensure, inshallah. Thank you.
Thank you so much, Dr. Abu Hena Mustafa Kamal, sir. Now I would like to request Dr. Mehdi Ahmed Munna from Silet Usmani Medical College. Dr. Mehdi Ahmed Munna. Can you hear me?
Yes, I can hear you. Am I audible?
Yes, yes. Please carry on.
Dr. Javed, it's a moment of honor to me to be able to talk here. I'm very much thankful to the organizing committee. As we are in a very time crunch, I would like to go straight to the main topics. I am working in a COVID ICU as a consultant in Shohid Shamsuddin Hospital. It is the first dedicated hospital in Sylhet, and on 4th of March, first suspected case was admitted, and on 8th April, first confirmed case was admitted. In very early setup, a makeshift ICU, only 2-bedded, arranged in pre-existing operation theater, and the ventilator and other logistics are borrowed from MSG Osmani Medical College. And thereafter, government allotted budget, as well as many non-government organization and many philanthropists came forward with great contribution, and then we are able to establish a ICU with 16-bedded capacity and 2 dialysis unit and other like 14 invasive ventilator, non-invasive ventilator, high flow nasal oxygen device 7, and so on. And manpower, we are maintaining, some of them are permanent here and some are working here at ad hoc basis. Still, we have some constant and demand, like we lack liquid oxygen plant, we still lack some testing facility and a central monitoring system. Now I'm sharing some statistics of our hospital. These are data up to 10th of October. A total 1,398 patients were admitted in this hospital, and among them 998 were confirmed COVID and 400 were suspected COVID that are clinically. And the mortality rate of confirmed COVID are 8.7%. And the mortality rate of suspected COVID patient are 19.5%. You can see here, the mortality rate is double in suspected compared to confirmed case. There might be many reasons, but our suspicion is this group of patient encounter difficulties to get treatment because they neither can admit in a non-COVID hospital nor in a COVID dedicated hospital. And the total death rate of our hospital is 11.5%. But the picture of our ICU is a little bit different because here in our ICU, total 240 patients were admitted and the mortality rate of our ICU is 40%. And the ICU policies we are maintaining, there's all doctors and health staffs are divided into groups to maintain the duty and the quarantine side by side. And we are following the national guideline and some international journals as well as expert opinion.
Hello, শুনতে পাচ্ছেন? Can you hear me?
Hello. And I would like to share some of our observation experience. Now I would like to share some of our observation and experiences. First of all, age factor. In our ICU, only one patient below 20 years of age were admitted and he recovered. And 20 to 30 years of age, 6 patients were admitted, all of them are recovered, and among them 2 are antepartum, 2 are postpartum, and 2 are male. And the rest of are mostly above 50 years of ages. And another factor is profession, lifestyle, and immunity. These are interrelated because in our ICU, none of them are
sorry, interrupt you. Mr. Media, I already finished your time. Please,
please give me 10 seconds. Only 10 seconds.
Sure,
okay.
Sure.
None of them are day laborer or doing manual work for their living. And in early recognition of CRS, in cytokine storm syndrome, we found that early recognition and its management is better than the late management. Okay. And the reinfection cases, we found 3 documented reinfection cases in our hospital. So the reinfection is actually happening in our area. Thank you very much. This is it. I think I have completed my topics within time.
Thank you so much, Dr. Mehdi Ahmed Bunna, for sharing your experience. Now I would like to request Dr. Mohammad Atar Rahman sir from Kumilla Medical College Hospital. Dr. Mohammad Atar Rahman. Can you hear me, sir? Dr. Mohammad Atar Rahman, please unmute yourself. I think there have connection problem or internet problem or any device problem. You unmute, but we cannot hear. Dr. Mohammad Atar Rahman, sir, can you hear me? Dr. Atar Rahman, sir, please, can you hear me? I think your headphone is not adjustable in your laptop. That's why the sound.
Can you hear me?
Yes. We all are here.
Okay.
Please carry on. Yeah, okay. Please carry on.
Okay. Now I share my experience. You know that's Kumilla is thickly populated area. About 62 lakh people live in Kumilla. And we started our COVID dedicated ICU from 3rd June 2020. And from starting 2 days, total admission in our ICU, 340 patients. And among them, 242 male and 100 female. Out of this 342 patients, discharged 105 with fully cured. And about them, 73%, 3 male and 32 female. Death total 229 and COVID positive death only 47 and others 182 were suspected. Our bed, initially we started 10 bed, but demand we increase another 8 beds. That is now our ICU run 18 bed ICU. Initially we have no high flow nasal cannula, but now we use about 23 high flow nasal cannula and monitoring and other facilities now available except some manpower, but day to day we train up our manpower. Now we treat the patient high flow nasal cannula, rebreathing mask, and non-invasive ventilator, that is CPAP and BiPAP. We have also 5 non-invasive ventilator, that is 3 CPAP and 2 BiPAP patients. And actually, the survival rate is more in case of non-invasive ventilator. We try to not to give the patient into ventilator because our experience, when we put the patient in the ventilator, death rate is near about 100%. So all patients try to manage without non-invasive ventilator. Others, we use antiviral and cytochrome storming drug, anti-cytochrome storming drug, that is tocilizumab, antibiotic meropenem, as usual doses. Now, total death, our total death 229, and out of this, only 47 was COVID positive and other 182 is suspected. Thanks a lot to Society of Anesthesiologists to give me opportunity to share my experience. Thank you. Thank you.
Thank you so much, Dr. Mohammad Atul sir, for sharing your nice experience. I would like to request now again Dr. Mohammad Anisur Rahman sir from Mugda Medical College Hospital. Are you here? Dr. Mohammad Anisur Rahman sir from Mugda Medical College Hospital. I think later he will join with us. I would like to request Dr. Sadat Hussain Masood, Head Department, Kurmikula General Hospital. Dr. Sadat Hussain Masood, sir. Okay, thank you so much. Thank you for sharing your nice experience in regarding COVID ICU in Bangladesh. On behalf of Bangladesh Society of Anesthesiologists, I am Dr. Mohammad Javed. Thank you, all of you, our speakers, for giving your valuable time to us. Now we are going to question and answer session. Have any question in the chat box?
Can I interrupt a little bit yours?
Yeah, sure.
Okay, just go to the chairperson of this session because we are already 1 hour down. So next session will be very seriously interrupted. So you just go to the chair and in chat box, individual speaker will answer on the chat box. No problem. So go to the chairperson comments.
Okay, thank you. Okay, now we are going to the chairperson comment session. At first, I would like to request our mentor, senior anesthesiologist, our teacher, Professor Devabroto Bonik sir, Honorable President, Bangladesh Society of Anesthesiology. Professor Devabroto Bonik sir, can you hear me?
Thank you. thank you all, and the pioneer and especially front fighter of this COVID-19 and critical care patient management. In the all, I think we can cover all of the hospital in Bangladesh who are treating the private and government sectors and the hospital. But everyone they share their experience and how to start and everything and how can improve this point. One point is I think everyone can miss the point is that how much facility standard facility near to standard facility is there. We are demanding the government to facilitate with the negative pressure ICU and HEPA filters and others and staff pattern, manpower development and a training program and all a standard PPA. And how one is the important point of how much our healthcare are infected during their COVID duty in ICU. This is the one of the important point is that in their experience it is the drawback, and I think that everyone in Dhaka Medical College, Bangabandhu Sheikh Mujib Medical University, Komilla, Bormitola, I can visit it in the many hospital, and they have many of our colleagues is infected and suffering from the COVID-19 patient. So it is the very important to the statistical data, how much the healthcare is infected by doing the critical patient management or further improvement of our critical care management. This is the one thing left that our all presentation, but all things are all are trying to present their experience in good way. Thanks to all of them, but we are in short in time. I have many things is there, but in the Evercare Hospital, how can they? What are the rule of use of the immunoglobulin? And I think that everyone can follow our national guideline and the same guideline to follow the same guideline in proper way. And so, if you can take any problem, we can contact with us or or the contact with our any seniors and must follow to national guideline and to overcome the every difficulties. So I thanks to all departmental heads who can participate in their end and who can hear this and join this webinar. Thank you.
Thank you, Honorable Chair, Dr. Devagaboni. Now I would like to request our mentor, our leader, Senior Anesthesiologist, Dr. Rukia Sultana Madam, Senior Anesthesiologist and Health and Population Affairs Secretary, Bangladesh Army. Dr. Rukia Sultana.
Thank you, and very good evening to you. I'm very glad to see everybody, and mostly I want to say that Salimud-Jaman is here. We know her. Sorry, him. We know that it's a global crisis, and every day we are gathering a new information. So we should share the knowledge. Today the lectures are the brilliant, and in this speeches I'm very glad to heard it, and everybody trying to maintain the time because I want to say if we every month we can sit here, then we can share in our country mostly, then we can share the knowledge and the technique and everything. Thank you, everybody. Thanks.
Thank you so much, Honorable Chair, Dr. Rukia Sultana. Now I would like to request our mentor, Honorable Chairperson, Professor Brigadier General Retired Radia Khanum. Professor Brigadier General Retired Radia Khanum.
Good evening to everybody. Can you hear me?
Yes, madam, we all are here. Yeah, hear you.
Yes.
Carry on, ma'am.
Good evening to everybody. The session is very vibrant session, and the speaker spoke about the challenging and vivid experience in treating the COVID-19 patient. The first speaker was Dr. A.K.M. Akhtaruzzzaman. He very nicely he presented the topic and he told about the protocol of management of COVID-19. I think he has given all the guidelines how to treat a COVID patient according to the national guidelines. And the one thing he said, the supervision, it was direct and virtual. So one should, and he also said few important findings about the COVID-19 patient. But during the treatment, the doctors, they donned with the PPE. For how many hours a doctor can be wear that PPE without any complication? I want to know from him. The others, everybody told about their own experiences. Somebody in some hospital there was no ICU, so they have to make a new ICU and all borrow or buy the new equipments. So then and some ventilators, etc., for the treatment. So and I think everybody has covered all the aspects of this session. So I asked Dr. Akhtaruzzzaman to please tell me about his bit experience while he was working.
Thank you, madam. Thank you, madam, for asking me the time of using the PPE for the duration. It depends on, actually in our hospitals, my hospitals, we are using the disposables PPE, and even in the N95 mask with the cap and shoe cover is they are all are the disposables. So once a doctors or a healthcare workers wearing these PPE in the donning area, their usual working hour is in the morning and evening is around the 6 hours and to 7 hours, and in the night it's around 12 hours. So we give the 2 extra PPE for them in case they need to change it. There is a usual recommendation is that, so if we can continue using the same PPE up to the 6 to 7 hours. And in the intensive care unit, the viral load is a tremendously high in rather than in the other COVID all. So in their area, we though in the eastern, even in the first world, they are using the mask, which is very much important. The mask is a reusable mask, but we are giving the tremendous support on that. We using the disposable mask, that is the N95 mask. We use the 6 hours and it dispose it and dispose it in according to the in the doffing area. So by this way, we are reducing our infection rate. You see the paper is in the JAMA that in Netherlands, their healthcare workers infection rate is 6.7%. But in our settings, if I told take it in the doctors, nurses, physiotherapists, and other healthcare workers in combinations, it is less than 1%. But in case of doctors, it is a 2.3%. But in case of nurses, it's less than 1%. So we are at par in the Western world. In US, their infection rate is around healthcare worker infection rate is around 10%. because of that, probably they are mixing into each other, even in they are going to the home. But in our hospitals in Bangladesh, they are isolated from their family for the 14 hours, for 14 days, 7 days in the duty hour, and 7 days in the isolation from in the hotel. That's why we can reduce our infection rates. Thank you, madam.
Thank you, Dr. Akhtar, for your nice presentation and nice and detailed presentation.
Yes, madam. But we can, we need more research and more research and documentations in our country, in our country, because we are lag behind on the research and documentations.
I must give thanks to all the speakers and to BSA for arranging this, and also the our moderator, Mr. Dr. Mohammed Zabir. Thank you all.
Thank you so much, our mentor, Professor Dr. Brigadier General Richard Radia Khanum, madam. And at last, I thank all of the speaker and chairperson and our faculty for presenting a very nice session. And on behalf of Bangladesh Society of Anesthesiology, I salute all of the health heroes who work and fight in the ICU daily and manage all the patients with very limited resources. Hero never dies. Hero are always remain in our soul. Hero are always remain in the heart. We all salute of our health heroes. Thank you all. Thank you so much. Now I hand over the program for next session to our Honorable Secretary General, Professor Dr. Kausar Sardar.
Thank you very much. Thank you very much, Dr. Javed. We are actually 1 hour and 15 minutes down. It was very difficult to control for the Javed because every presentation was too long. But it is true that it is difficult to share their experience within very short of time. So we can arrange another program after this conference, and we should have a good plan for the management and the outcome survey, which will include all the institutions of Bangladesh, government, non-government, and the autonomous. So we will go for the documentation. We are discussing with the DGHS, and with the collaboration of the DGHS, we can go for that project in a suitable time. That is the management and the outcome survey of the COVID ICU in Bangladesh in this headline. So thank you very much, all the chairpersons and moderator and speakers. So we are moving to all the in the next for the next session. All speakers from foreign and chairpersons are ready, I think. Moderator for the next session is the Amir Hossain Rahat. He is the Vice President of Bangladesh Society of Anesthesiologists, and very renowned speakers is there. Professor Naila Asad, Pakistan, is here. Dr. MD Salimujjaman Bhia, he's from UK, he's here. Anushka Modalaj from Sri Lanka, she is here. And Professor Arshad Taki, sir, he from Pakistan, is here, I think, yeah, he's here. And Dr. Wahid Altaf from Ireland, he's here also. So I would like to request Dr. Amir Hossain Rahat to moderate the next session.
Thank you, Dr. Kausar Sardar, Honorable Secretary General of Bangladesh Society of Anesthesiologists. Am I audible to all?
Yes, you are audible.
Thank you very much. It's my great pleasure to be here with you people as moderator of the session. This session will be chaired by Professor Mohammad Khalilur Rahman, a legendary professor of anesthesiology in Bangladesh, rather say not in Bangladesh, in the arena of anesthesiology in the world. Professor A.K.M. Shamsul Alam, another legendary professor of anesthesiology, and Dr. Raghib Manjur, renowned anesthesiologist of Bangladesh. These three persons will chair our session. As our Secretary General was mentioning, there are 5 presentations in this session. All the keynote speakers are from different countries. Among them, Professor Naila Asad from Pakistan. She will talk about infection control in ICU. Dr. Mohammad Salimujjaman Bhuiya from United Kingdom. He will talk organizational setup for critical care services. Then Dr. Anushka Mudalij from Sri Lanka. She will talk on moving forwards in critical care in a resource limited setting, a personal experience. And then Professor Arshad Taki from Pakistan. He will speak on specialist training in critical care in Pakistan, how we started, where we stand. And finally, Dr. Wahid Altaf from Ireland. He will talk on outcome of elderly patients, respected chairpersons, learned speakers, my dear colleagues, ladies and gentlemen, very, very good afternoon, and I am welcoming you all to this session. First of all, I would like to request our chairpersons to take their seat. Probably they have taken their seat. Then I would like to request Professor Naila Asad from Pakistan to present her papers on infection control in ICU. May I request Professor Naila Asad from Pakistan? Do you hear me?
Yes. Assalamu alaikum. Can you hear me?
Yes, it's okay,
Okay,
loud and clear. Please start.
I'll share the screen.
Sure.
It's okay. Let me see. I'll move the
It's okay.
slideshow. Shall I? Is it? I just want to put it on the slideshow. Can I?
Yes, it's. We
Is
can
it on
see.
the slideshow?
Yes.
So I wanted to put it. Let me see if I can put it on the slideshow, please. This one. Okay, I can't see the slideshow going.
Okay,
Icon
you
here.
just, Naila, you just come in the bottom and you see in the almost right side. Your charge is 83%, and just left come plus minus, then in the bottom side.
No.
In the bottom side,
The bottom side, no, just wait, let me
you see plus, minus, then slideshow here.
Wait. No, this is sharing screen. I can, and this is, I think I can't see that. Just in a minute, I will just put it on full screen.
Or you can, in the upper side, there is 2 ways. The upper side of number 1, 3, 4, 5, number 6.
Can you see it now? No.
Okay, right now. It's okay.
Is it okay? Can I go on?
Yes, okay. Please start. Proceed on.
Okay. Okay, sorry for this trouble. Bismillahirrahmanirrahim. First of all, I would like to thank all the organizers, Professor Kausar Sardars and all the organizers. And I would like to say Assalamu alaikum to all my dear colleagues. So I thank you for inviting me as a speaker to talk about infection control in ICU. So an overview, let's talk about an overview. What I would be talking about is definition of hospital-acquired infections. Why do we need to focus on infections? Factors contributing to infections, factors responsible for cross-transmission, infection control measures, which are standard and specific. Defining hospital-acquired infections, everybody knows that these infections are acquired within 48 hours of admission within the hospital, and 10% of the hospitalized patients are infected. According to WHO rate of infection, 7 to 12% was seen in high-income countries, 5.7 to 19.1% in low to middle-income countries. And in Aachen, a study was done in which they found 29.13% of patients acquired hospital-acquired infections. Now, why do we need to focus on this? Well, the problem is that it increases the prolonged hospital stay, long-term disability, increase in antimicrobial resistance. It increases the socioeconomic disturbance and the mortality rate. Risk factors. We need to know what are the risk factors which put the susceptible patients into this, because in ICU, all patients are susceptible patients having extremes of age, presence of comorbidities, presence of physiologic derangements. They are immunosuppressed with protein energy malnutrition. They are septic, and their length of stay is prolonged with use of multiple antibiotics. Another big risk factor, which I would say is in developing countries, we have lack of awareness among the staff and healthcare workers. There is because they have poor knowledge of the basic infection control measures. There is lack of control policies and inappropriate use of invasive devices. Presence of multiple indwelling catheters, central venous catheters, urinary catheters, NG tubes, endotracheal tubes, surgical drains, arterial lines, all of these are a source of infection which put the patient on risk. Pathogens. The most important, 80% Acinetobacter causes this. Intestinal tract bacteroids, Clostridium difficile that causes antibiotic-associated diarrhea and colitis, and Enterobacteriaceae. The incidence, 5% incidence is seen in viruses, hepatitis B and C. Then multi-drug resistant organisms. They are caused by gram-positive, gram-negative. In gram-positive, we know it's MRSA and vancomycin resistant pterococci. And fungal parasites are the Aspergillus candida albicans. Factors responsible for cross-transmission. These are the most important is the environment, airborne and the contaminated surfaces which surround the patient. Also, the careless attitude of the healthcare worker, and then lack of hand wash facilities. In these developing countries, patients are close together. There is inadequate decontamination, and then contact, which could be direct, indirect, respiratory droplets. The common vehicle is these laryngoscopes, which are used in every patient. Then you have is the fiber optic bronchoscopes, fiber optic laryngoscopes. So, and lack of isolation facilities. Measures. What measures should be taken to control all this infection? Well, I have put it up as standard principles and specific principles. The standard principles, the foremost, which is staff education and training. There are no policies, there are no workshops we do in developing countries which should appropriately educate and train the staff, paramedics. Administrative measures. There should be development of infection control policies. Policies for controlling traffic flow, which comes in and out of the ICU. Hand hygiene. Use of personal protective equipment, which accounts for gloves, gown, eye protective wear. Then we must have written cleansing and disinfection protocols. Antimicrobial policies, then the appropriate disposal of waste, the disposal of sharp objects and needles, which should be in puncture-resistant containers, and then the fumigation. Now I'll talk about a little about direct contact transfer. How do you transfer it? 80% diseases are transmitted by hands. We are not appropriately, we do not wear gloves as our staff workers sometimes just come up and touch the patient, moving on to the other one. The most effective measure in infection control is washing hands. Let's give everyone a clean hand. There is no substitute for hand washing. Just with a simple soap and water, we can provide this hand hygiene. Doesn't require any extra effort. When should it be done? The WHO gave us 5 moments of hand hygiene. Before touching a patient, before a procedure, then after a procedure, or the risk of touching any body fluids, after touching the patient, and after touching a patient's surrounding. These are all the moments we should always wash our hands with. This is a chart which we have displayed in our ICU, and this was given by the Director, DG Health Services Punjab. It tells us in our language that it should be 40 to 60 seconds of hand wash that does the job, that prevents. And this is that these are all WHO measures which are given. That you just put soap in your hand, you rub your palms, and then you interlace your fingers, and then after that you just cross your fingers and do that, then the thumb. It's all the measures how you can wash your hands with soap and water. Simple measure for the hand hygiene. Protective gear. This is my surgical ICU, and here I have my colleague, my assistant professor, with all the gear, and she's intubating the patient. And this is a norm. We just make it sure that if we don't have disposable gowns, we can wear the sterilized gowns. The mask should be there, the cap should be there, the shoe cover and everything. Another picture with this was a COVID patient, and we took that, so we have all the shield. The other factor important is environmental cleaning, which removes all the organic material from surfaces. Not much of it is required. Water, detergent, antiseptic. And we can even twice weekly cleaning the surfaces and the walls can prevent infection. Floor cleaning, that depends how much inflow you have, but at least it should be 2 to 3 times per day. The patient area when he's discharged or he expires, then you clean the area. And if the linen becomes wet or it's moist, you remove it within 24 to 48 hours to prevent fungal growth. Disinfection. What is disinfection? We are all the time talking about it. It removes all the pathogenic organisms from the objects except bacterial spores. There are high-level disinfectants, intermediate-level disinfectants, low-level disinfectants, which is 70% alcohol. This is provided everywhere. With high level, we have Cidex, 2% glutaraldehyde, 1% sodium hypochlorite. With intermediate level, we have 0.1% hypochlorite, phenolic solutions, and iodophos. What is the hierarchy of using these, killing the organisms? Is the high level disinfectant kills bacterial spores, and the intermediate level kills mycobacteria, fungi, non-lipid, small viruses. The low-level disinfectant kills vegetative bacteria, lipid, medium-sized species. Another way is sterilization of reusable equipment, which this sterilization that completely eliminates the microbial life. This is done by steam sterilization. Everybody, you have autoclaves in which more than temperature of more than 100 degrees C, dry heat for instruments, and chemical agents. These are the SOPs which we have pasted in our ICU for disinfection of services in DOR, but we have pasted there as well. And we use Alpha Guard is there, which is used at the end of each case or at the end of when the patient goes in all the time. Then the use of antibiotics. We need to control this thing. We need to implement strategies to restrict the use of high antibiotics, broad spectrum, so that we should prevent multi-drug resistant organisms. The follow-up is, you can have a follow-up to check the effectiveness, and then there should be an optimal use of the narrow spectrum antimicrobial agents, use of agents in combination, we can use them to prevent this, cycling of antibiotics, that can be done. This again that I have placed this is the chart which is placed for disposal of waste. So we have placed that everybody can see in our language what should be placed in the red bucket, the yellow bucket. The red one is for the contaminated waste. The yellow one is for the infectious waste. The green is for the general waste. And then the sharps, the needles. These we have the yellow boxes, which you can see they are for the sharps and objects over there. Coming up to the specific measures. Specific measures, the most important, isolation rooms. We must have isolation rooms with negative pressure as for airborne diseases. Like they should have a minus 2.5 pascals pressure with more than 12 air exchanges per hour. And positive pressure plus 2.5 pascals with 12 air exchanges per hour for immunocompromised or severely neutropenic patients. This is a picture of our surgical ICU, which we don't have an isolation room, so we keep them 3 feet apart. So, but for COVID, we have a separate COVID ICU in which there are isolation rooms separate. Clapsides, central line associated bloodstream infections. 40 to 80% is caused by gram-positive organisms, which are coagulase negative, staphylococci most common. 20 to 30% caused by gram-negative. The International Nosocomial Infection Control Consortium surveillance data that reported from 2010 to December 2015, a clapside rate of 4.1 per 1,000 central line days. How can you prevent that? Bundles. We can follow these, are very easy to follow. Hand hygiene as usual, the protective barrier, aseptic measures, the patient should be draped fully, and they're scrubbing the hub. And the last most important thing is daily review of the line necessity. Do you need it? You want to remove it? Remove it. Or if there is any infection, you can see on the outside. Catheter-associated urinary tract infections. What specific measures can you take? The incidence of these are 20 to 30%. E. coli, Proteus, Mirabilis, Enterococci, MRSA, Staphylococcus epidermidis. You all know which organisms cause them. For these, we have bundles, checklist for prevention of quartiles, with the adherence to general principles, infection control principles, hygiene, aseptic insertion, proper Foley's catheter maintenance, Foley's catheter use, surveillance, and feedback. With B, you have bladder ultrasound may avoid indwelling catheterization. C, catheter alternatives. You can use intermittent catheterization. You can go for condom catheters. And the red one, D, do not use the catheter unless you must, if it is essential. E is and another one is early removal, as early as possible. And if you forget, use a reminder. Ventilator-associated pneumonias, 28% of patients who receive mechanical ventilation, they are affected by VAP. Organisms, gram-negative microorganisms are involved. And how do you get to know that the patient is having VAP? That is by X-ray, which you get every day in ICU. New infiltrates will appear. New onset of purulent sputum. The character of sputum will change. There will be fever will not settle down, and there will be increased or decreased WBC counts and the culture. Definitely you'll send the culture and you'll find it out. What are the VAP bundles? Elevation of head, 30 to 40 degrees. Mouth care, mouth washes, 1% to 2% chlorhexidine, 6-hourly. Aseptic tracheal suction, prevention of subglottic aspiration, daily assessment of readiness to wean, daily spontaneous trials to wean, prophylaxis for peptic ulcers, prophylaxis for deep venous thrombosis, and daily sedation medication as well. Another important factor is for prevention is surveillance. Surveillance is, why do we need the surveillance? To monitor infection prevention, ensure that actions are taken to minimize them and assist in quality care of the patient. Now, being in a developing country, we lack this. What challenges we have to face is in implementation of this surveillance is we do not have a written policy laid down for surveillance. We have increased workload. For this, we have insufficient hospital staff. And then above all, we have no electronic system which records how many patients came and when we record of the patients. And we have a paper-based clinical record. Once the patient, he leaves the ICU, he's discharged, the record goes into a storage area and it's very difficult to find it out. So this we lack here. These are the challenges which we have to face, but we should try to overcome these challenges and make a surveillance system. So my key message is
Professor Naila Asad, your time is over. I will request you to end it.
Just this is the last one. That's all.
Okay, thank you very much.
Yeah.
Please proceed for 1 minute.
Yeah, that's the last one. I'm done with it. Yeah.
Okay.
So it's attention, hygiene, and that's all surveillance. So thank you.
Thank you very much, Professor Naila Asad, for your nice presentation. I think the topic infection control in ICU is very, very much relevant in this pandemic situation. Thank you very much. Thank you for your nice presentation.
Thank you. Thank you so much.
Thank you too. Now, I would like to request Dr. Mohammad Salimujjaman Bhuiya. Dr. Salimujjaman Bhuiya will talk about organizational setup for critical care services. Sir, I would like to mention it that your allocated time is 20 minutes. Please try to finish it within the time limit. Please proceed on.
Yeah, can you hear me?
Yes, it's okay.
Yeah. Thank you for inviting me in this meeting. I would like to thank organizers of this conference, including moderator Dr. Amir Hossein Rahat and Professor Kausar Sardar. Can I download my slide first? Okay. I think I have. Can you see my slides?
Yes.
Okay, thank you. Now, the importance of intensive care service has ever increased due to COVID pandemic. I would like to talk about how to organize and set up a critical care service, especially in the DGS situation, because I work in DGS. First of all, I would like to thank my co-chairs today, my professor, Professor Khalilur Rahman, Professor Samsul Alam, and Dr. Raghib Manjur. Good afternoon. Yes, yeah. This is the Farnham General Hospital. It's a DGH in Northwest England. I work here for the last 13 years. Next 15 minutes, I would like to explain these points: history of intensive care, what is the definition of intensive care medicine, what are the types and levels of care in ICU, critical care beds, how to organize and design a critical care unit, what are the essential equipments we need, staffing level, admission and discharge criteria from ICU, multidisciplinary teamwork, outreach services in critical care, ICU follow-up clinic, and finally I conclude with a few words. History of intensive care medicine started in early 50s in Western Europe when there was a polio epidemic. Danish anesthetist Dr. Ibsen and the hospital surgeon and physician, they decided to rescue patients from bulbar polio, and they came up with the idea of tracheostomy and hand ventilation. And they managed to reduce the mortality rate of polio patients from 87 to 15%. This is Dr. Ibsen. He is the founder of intensive care medicine. What do we understand about intensive care? What is the definition? This is a service for patients where potentially recoverable diseases can benefit from more detailed observation and treatment, what is not available in the general ward and departments. What are the types? First of all, there are general ICU and the specialized ICU. General ICU, like DGS services, is mixed medical and surgical ICU. Specialized is cardiac ICU after cardiac surgery, neuro ICU after neurosurgery or after head trauma, pediatric and the neonatal unit, burn and plastic ICU, and also liver intensive care. When you talk about the level of care, we talk about what are the level we do from level 1 to level 3. Level 1 is the minimum one when a patient is at risk of deteriorating their condition, may need a support from the intensive care unit or their expertise and stabilize the patient in the ward situation. Like a simple example of oliguric patient needs a fluid challenge, and it can be done under CBP guidance. Level 2 is patient requiring more detailed observation and intervention, including support of single failing organ, or patient may have come from theater after a long day surgery, or patient may have been came from the upper level of care, that is level 3 care, step down to level 2 care. So level 2 means one organ failure or one organ support. Level 3 is the actual ICU. Here, the patient requires the advanced respiratory support alone or basic respiratory support together with the support of at least 2 organ system. And this is the area where patient comes with a multi-organ failure and multi-organ support. How to organize critical care beds? The number of the beds varies according to specialty. For the general ICU, number is small, but for the specialized ICU like cardiac and neuro, numbers are more. In general, rule of thumb is, on an average, district general ICU, 1 to 2% of the total acute hospital bed. This number is higher in Europe, like 6 to 8%, even higher in USA, like 12 to 15%. In UK, the DGHs are usually 5 to 6 bedded ICU. Cost? Average cost is 1,300 to 1,500 per day per bed, but the cost is higher during the first 48 hours of admission. How to design a ICU? We need a 20 square meter of bed space, curtain all around the bed. We need more bed space for the obese patients. As you heard from Professor Naila Assad, we need cubicles for highly infectious patients or immunocompromised patients. Each space should provide monitors, pipeline oxygen, piped air, suction, and emergency backups of all these facilities. There should be ICU chart, portable computer to write the notes and electronic prescriptions, and there should be a central nursing station where the nurses can view the monitor of every single patient. We allow daylights through a window to the ICU to give them an orientation what part of the day or night it is. We need computers for the investigation results and also to refer the patients to the clinicians and also to the other hospitals. Same computer needed for guidelines and protocols and literature search. We also need telephone and emergency blip system. We need a wash machines each bed with utility rooms. There are 2 types, clean and dirty. Clean is before using to the patient, dirty after use to the patient. Storage for the drugs and the equipments, including fridge, small lab for blood gas machine, oximeter, and thromboelastography for dynamic study of blood clotting. We need a relatives waiting room for the relatives to come and sit and we can discuss patient's condition with the relatives, staff room, and for the refreshment room. We need all sorts of equipment, including air and breathing equipments. You all know it, including intubation trolley and difficult intubation trolley. We need ventilators, breathing circuit, both invasive and non-invasive. We do bronchoscopy, chest drain. We need tracheostomy and the mini tracheostomy facilities. Also some monitoring, including arterial monitoring, CVP monitoring, cardiac output monitoring, intra-abdominal pressure monitoring. We do have defibrillators, external pacemakers. We do acute filtration of, hemofiltration of acute renal failure patients. We have got warmers, so body warmer for cooling, warming the patient. Also, cooling system, we call it targeted temperature management for head injury patients or post-cardiac arrest patients. Lots of infusion pumps, and also we need adult and pediatric resuscitation trolleys. Staffing level, there should be 1 trained nurse for level 3 patient, each level 3 patient. But if it is level 2, 1 nurse can look after 2 level 2 patients 24/7. There should be 1 nurse in charge in each shift, ICU support worker, consultant, intensivist 24/7 cover, and also resident anesthetist 24/7 cover. one of our consultant anesthetists works as an ITU director. He looks after the clinical governance issue, quality of the care issue, any critical incidences, or any protocol, and also a guideline to devise. We have got ICU managers and office clerk. What are the criteria? There should be strict criteria for admission to ICU, like those who require advanced respiratory support, those requiring one or more organ system support. And there should be a referral system directly from a consultant physician or surgeon to the consultant intensivist. At the end of the day, it's the consultant intensivist who decides which patient comes to ICU or not. But the right rule is the ICU is not suitable for terminally ill dying patients. Discharge criteria, of course, when there is no support needed, patient steps down to the lower level of care. We don't discharge them to the ward, we discharge them to the HDU or PPU. PPU stands for Progressive Patient Progression Unit. And critical outreach teams, they come and review the patient every day. I'll touch on the critical outreach team later. The ICU is not a single specialty, it is a multi-system or multidisciplinary team working. We have got physiotherapists coming twice a day. We need a dietitian. We have got microbiologists coming at 12 o'clock to advise us about the antibiotic regime, change antibiotic. We need a backup for pharmacy, hematology, radiology, and there is a daily review by the physicians and the surgeons. For a difficultly weaned patient from ventilator, we get support from the respiratory physicians. And for cardiac issues, we have got cardiologists to come and help us. For acute renal failure, we have got nephrologists to come and support us. For psychiatry and neurology issue, we have got neurologists and psychiatric consultant to support us. And finally, for a dying patient in ICU, we do have palliative care team. They come and they support us. I have mentioned about critical care outreach team. This is a service led by a critical care nurse. She goes round to hospital twice a day, or she gets a call from the ward directly. Her job is to make sure that there is early referral and early admission of a deteriorating patient in the ward. At the same time, she advises the ward to stabilize the patient, also to improve patients in the ward so that we can avoid unnecessary admission in the ICU. And also the outreach team follows up the recently stepped down patient from the ICU. ICU follow-up clinic, this is a new theme. We review the discharged patient in the outpatient clinic, and this is led by a critical care nurse or intensivist, and we listen from the patients and patient's experience we get, and then we get the patient's feedback. And also we tell the patient what happened to him and her during the ICU, what illness they suffered, and we learn from each other. And finally, we support the patient and guide them for further treatment, say refer to another specialty for any difficulties. Finally, I would like to say that the intensive care medicine deals with the management of sickest patient in the hospital. And this service is very important, essential and demanding and expensive. We need a dedicated multidisciplinary team to run the service efficiently and safely. Thank you. I can hear you. I think can you unmute yourself, Dr. Amir? Dr. Amir, you need to unmute yourself.
Yes. Thank you very much, Dr. Mohammad Salimujjaman Bhuiya, for your nice presentation on organizational setup for critical care services, which is very, very relevant in this pandemic. It will be helpful for them, those who are going to establish new ICU in their hospitals. Thank you, sir. Thank you for giving your time. And for presenting a very, very important topic. Now, I would like to request Dr. Anushka Mudalij, who is from Sri Lanka. She will talk on moving forwards in critical care in a resource-limited setting, a personal experience. May I request Dr. Anushka Mudalij to share your experience here? Can you hear me, Anushka? Hello. Dr. Anushka Mudalij, are you
There is
hearing
a
me?
screen share. There is a screen share.
I'm trying to come off the share actually. I can't find it. Anyway, I just log off and then I come back later.
But
Okay. Yeah, I'm finding that I can't find the end share thing actually. I'm just looking for it.
Selim bhai, apne screen is already share. Screen is already share. Selim bhai.
Yeah, I'm trying to come off the screen share, but I can't find it.
Selim bhai, just go to the top of your presentation and see that. Okay, good.
But time is very limited. Only 2 minutes left for Dr. Mohammad Salimun-Zaman Bhuiya. I think it is better to go to Dr. Anushka Mudalij.
Rahat, there is a screen share from the Salimun-Zaman.
But his time is over. Only 1 minute left. 1 minute.
Why did you allow him another 5 minutes? Because
okay, sir.
He's our okay.
Thank you, sir. Dr. Mohammad Salimun-Zaman Bhuiya, another 5 minutes is allocated for you. Please proceed on.
No. Yeah. Ammunition Rahat. No, there is another person is come here with the screen share. Consult Anushka
Mudalij. Anushka Mudalij.
There is a screen share, but later on after this presentation, you can give the chance to Salimun-Zaman Bhuiya.
Okay, sir. Thank you very much. Now I would like to request Dr. Anushka Mudalij from Sri Lanka. Please start your presentation. Dr. Anushka Mudalij, do you hear me?
We can't hear you, Anushka.
I think we can't hear Anushka. Please, I think there is some technical problems.
You unmute. Okay.
No, we are not hearing you.
Till now, we are not hearing.
Dr. Anushka, I'm seeing here he is unmuted already. It's a device problem, I think, either in the earphone or anywhere in his device. So it's
Please
a real
review
problem.
your settings. Not yet. We can't hear you, Anushka.
Maybe Bluetooth is taking over the charge. So disconnect Bluetooth.
Maybe. Till now, we are not hearing.
So Rahat bhai, what we can do, you can go for the next speaker, and when the problem is solved, they will come back again.
Can you hear me now?
Yeah.
Now
is it? Sorry about that. Yeah.
Welcome, Anushka Mudalij.
Yeah.
I am welcoming you to this session, and I will request you to start your presentation, please.
Okay, hello everyone. And first of all, thank you very much for giving me this opportunity to speak in this e-conference conducted by the Bangladesh Society of Anesthesiology. I'm really delighted to be presenting in this forum. And my topic for today is moving forwards in critical care in a resource-limited setting, a personal experience. I thought of talking about this topic particularly because I thought it would relate to the region and we can share our experience to develop each other. So this is Sri Lanka, a very beautiful country, and so many different diverse sceneries just a few kilometers apart. So unless there was the COVID-19 at present now, I would have invited you to come and visit this beautiful country. So since we are talking about moving forwards in critical care, I thought we would start with the how it all started in Sri Lanka. In 1968, the first intensive care unit was started in the cardiothoracic unit at the Colombo General Hospital, which is now the National Hospital of Sri Lanka, the biggest major hospital that is present. And it was started by Dr. Thisal Jayawardena, who was a consultant anesthetist, cardiothoracic anesthetist at the time. It was equipped with iron lungs and ECG monitoring. And this was 13 years after the first ICU was ever established in the world, that is in Copenhagen, due to the polio epidemic. Then in 1976, another ICU was opened in the same hospital, which catered for surgical and medical patients. And in 1980, the third ICU was opened in our almost second capital, that is in Kandy, Peradeniya. So since then, Sri Lanka has come a long way. Still, there's a lot of room for improvement. So talking about the current ICU infrastructure and equipment in Sri Lanka, we have 100 ICUs all over the country, covering all provinces and districts. Approximately 500 beds altogether, covering a total population of 21 million. There's an average of 2.42 beds per 100,000 population. Internationally, reports are available revealing ranges from 1 to 30 ICU beds per 100,000 population. So this is the Sri Lankan map. The purple area is the Western Province, where Colombo is. That is the most population dense area, where there's over 5 million population. And the orange and the green areas have the less and least amount of population. And as you can see, the Western Province, the most dense populated area, has the highest number of ICUs, 36. And as the number goes down, the number of ICUs also go down. And if you talk about ICU beds per 100,000, when you go down with the population, the number of ICU beds also goes down. So in the Western Province, the highest population, we have 3.27 beds per 100,000. And in some provinces, like the Sabragamo, it's only 1.3. So as you can see, the distribution of ICU beds may not seem that uniform. Then the types of ICU we have in Sri Lanka, we have general ICUs mostly, and also we have surgical ICUs, medical ICUs, maternal trauma, and specialized ICUs, like such as for neurosurgery, neurology, cardiology, and cardiothoracics, where the specialities exist, such as the major cities in the country. Now, the recommendation is to have 1 to 4 ICU beds per 100 hospital beds, if possible. That's the ideal. And a general ICU should have about 6 to 10 beds, where you can balance the standards and the cost effectiveness. And also, the ICU should be able to accommodate 95% of all the emergency requests that have been made. The ventilator support facilities should be on one-to-one basis, and the capabilities of analyzing blood gases, glucose, electrolytes, hemoglobin should be available around the clock. Now, in our Sri Lankan setup, the hospital goes as the national hospitals. There are 2 national hospitals, then there are teaching hospitals, then there are district general, general base, and maternal going down the hierarchy. So in the highest hierarchy, I have excluded national and teaching. For district general, we have 1.3 beds for 100 hospital beds. So as I said, 1.3 beds per 100 hospital beds, which falls below the recommendation, in the international recommendation. The median number of beds per ICU is around 5, which is in par with the recommendation. And this Hanifa R in 2014, in his audit, has found the basic infrastructure of all the ICUs when concerning electricity, running water, piped oxygen, and the basic equipment such as electronic monitoring and infusion pumps are adequate. So moving from buildings and machines to staff, nurses. We have around 2,000 nurses. The number of nurses per bed is 3 to 4. The recommendation is 4.5. And we have 1-to-1 nurse to patient ratio by around 87.9%, which should be actually 100% when we are considering an ICU setup. And training of nurses, the recommendation is the lead nurse of an ICU should have post-registration ICU qualifications. But in our country, there's only 56% trained lead nurses in the ICUs. And the rest of the nurses, the recommendation is to have at least 50% trained nurses. But in Sri Lanka, we only have 36% who are trained. So by number-wise as well as quality-wise, we are lagging behind when it comes to nursing. There is room to improvement. Then moving on to medical officers, recommendation is the doctor to patient ratio should not exceed 1-to-8. So we have a total of 790 doctors, that is 1.6 per bed. And the medical officer to patient ratio is 3 to 4. So we have an adequate number of medical officers. But the training of medical officers. Now, Gunasekara CHL in 2016 pointed out that there was no formal objective learning training given to medical officers in ICU. And the place and the training depended on where they were allocated to. And there was no formal training in pediatrics, cardiology, renal therapy, or other organ therapy apart from ventilation. There were no essential competencies that were signed off. And some medical officers were allocated for both anesthetics and ICU. And so this led for some turmoil, thinking that the training for medical officers in our country was inadequate. By this time, the College of Anesthesiologists of Sri Lanka was responsible for the training of medical officers as nurses, as well as the Ministry of Health. So because of this lack of training concept and the turmoil, in 2002, the Sri Lankan Society of Critical Care and Emergency Medicine also developed. This was a body of specialists. Apart from anesthesiologists, there were consultants in other specialties such as medicine, surgery, obstetrics. And they got together and they helped and worked together to make policies of health services in Sri Lanka. And they particularly focused on high quality care for critically ill patients. And as a result, after some time in 2019, an intermediate level diploma qualification in critical care medicine for medical officers was introduced. This was a program of 1 year's duration where the trainees would be trained in generalized as specialized ICUs as well as medical subspecialties. There was an entry exam and an end of course formal written and viva exam. But unfortunately, these doctors who are being released to 20 to 30 per year are being added on to a common pool of doctors and will be posted all over the country. And it's not ensured that they will end up in an ICU itself. So at times, this training is going to get wasted. Then about the ICU lead. Most ICUs in Sri Lanka are led by anesthetists, followed by physicians, surgeons, and intensivists. So you can see anesthetists, we have a leading role on the graph. And the recommendation for an ICU lead is the care must be led by a consultant in intensive care medicine. There should be continuity of care. The consultant to patient ratio must not exceed between 1-to-8 to 1-to-15. The consultant must immediately be available 24/7 and be able to attend within 30 minutes of an emergency. There should be twice daily ward rounds with 1 daily multidisciplinary ward round. And all treatment plans must have a clear objective given within a period of specific time. And where appropriate, it should be discussed with the patient or the next of kin. Closed versus open ICU. Closed units where there is a dedicated consultant making decisions on admissions, on discharges, and the treatment plan are an optimal configuration to delivering intensive care. Roha et al. In its comparative study has compared closed versus open ICUs and has found that the mortality, the overall complication rate, the number of consults and consultations, and the occurrence of AKI was significantly less in closed units, whereas the others like the monitoring, the antibiotics, the feeding, and the length of stay was identical. So what's the situation in Sri Lanka? Most of our ICUs are semi-closed and led by anesthetists, while a few are open. Now, this Edirisuriya M, an intensivist, had the experience of comparing an open versus a semi-closed ICU because during his time it was converted to a semi-closed. And he tried to compare the improvement of bed availability and the care given between the two ICUs. And it actually improved, the bed availability improved. But due to the lack of level 3 beds and delayed admission, the patient who got admitted were quite deteriorated by the time of admission. So as a result, the mortality did not change that much. So what that team advice was to have outreach services to make sure that the patients do not deteriorate before they come into the ICU, and to have end-of-life care so that unnecessary patients do not end up in the ICU as well. Now, about training of this ICU lead. The Postgraduate Institute of Medicine Sri Lanka, affiliated to the University of Colombo, is responsible for training all specialists in medicine in Sri Lanka. Now, in this PGIM, there are separate boards for each component of medicine. So for anesthesia, we have a board of study of anesthesiology. They were responsible for production of anesthetics. And there was a special program where the anesthetists with special interest in critical care was produced. So in this training, apart from the pre-MD 13-month critical care training, there is a post-MD 6-month ICU training. And they are produced from the PGIM, and they are posted in different ICUs all over, in different hospitals all over the country, where they will look after the Now in 2010, in UK, the Faculty of Intensive Care Medicine was established as a standalone speciality and as a sister faculty from the Royal College of Anaesthetists, UK. And by this time, the world was also having full trained intensivists and nurses playing pivotal roles in the developed world. And not falling far behind, in 2011, the government of Sri Lanka recognized critical care medicine as a separate specialty too. So as a result, in 2013, the Board of Study of Anesthesiology of the PGIM developed a hybrid model of training where anesthesiologists as well as general physicians will come to master the now clearly defined specialty of critical care following their MD qualification. So intensivists are formed post-MD. So these trainees will have general training in an ICU for 1 year, general ICU and specialized ICU. Afterwards, the anesthetist then will have another 1 year training in medicine and its subspecialties. And the physicians will have another 1 year of training in anesthesia and subspecialties in anesthesia. So 2 years local. Then 1 year there's a mandatory training in the UK or some recommended country by the PGIM, where they, if in the UK now our anesthetist trainees are exempted from the fellowship in critical care medicine part 1 and eligible to sit for the FICM part 2 straight. So FICM is the new exam in UK that lays the pathway to develop intensivist in the UK. Now, the trainees from medicine will have to sit for the MRCP and then they can go to the FICM part 2. All trainees, our trainees, will follow the FICM curriculum. Although not mandatory, most of our intensivists have the MRCP, the FRCA, the FICM, or the EDIC in their CV. And apart from that, there's a scientifically prepared research and an audit on an ICU topic that has to be accepted by the Board of Study by a qualified expert panel for these specialists to be qualified to practice as intensivists. And by this time, in 2014, the College of Anesthesiologists was renamed as College of Anesthesiologists and Intensivists of Sri Lanka. So that is the involvement of critical care in Sri Lanka. Now about audit and research. Now the world was thinking of doing some critical care research by this time, by the 1980s. And there was one specific move that they made. They made specific scoring system so that they can actually compare cohorts between countries or within countries. And in 1994, in the UK, the Intensive Care National Audit and Research, the ICNAR, was established, where all the data from all the ICUs were collected centrally, and it was analyzed, and the data was produced as a country. So the recommendations for measuring outcome or audit is that we have to measure mortality, long-term mortality, morbidity, critical incidents, and acquired infections and surveillance. And in order to measure these, you have to have a comprehensive database. And regular morbidity, mortality meetings and multi-professional clinical government meetings should be conducted. So what is the situation in Sri Lanka? In 2012, the National Intensive Care Surveillance was initiated. It was a critical care clinical registry for Sri Lanka led by the Ministry of Health to promote ICU bed availability. And they also contribute to the improvement of critical care services through regular audit. But still, we do not have data on our ICU patients, the population data such as demographic or comorbidities, or the outcome data such as the morbidity, mortality, and the disease patterns, or the long-term outcome of survivors. So, for example, there are some random studies that were done by Gunasekara again in 2016, where he compared deaths between medical and surgical ICUs, which were 32 to 15%, and the ICU general death rate of 21%. And again, Hanifa found that their ICU mortality was 17%. So there were some discrepancies between these studies as well. So as I said, we need a national database for the critically ill. It should be a national, uniform, structured database that allows to analyze the demographics, the disease patterns, and the severity and outcome of parameters of our patients. The intensivists in the country, which is a new thing, started about 2 or 3 years back, are now starting to form up these databases locally. So this is one of their studies that was done in the medical intensive care unit of the Colombo National Hospital of Sri Lanka, where they tried to compare the levels of the types of shock. And in the hospital that I work in, the Colombo North Teaching Hospital, for the past 4 months, we have also been gathering information on the MICU patients. And we have got, like, the admissions per month was around 25 to 31, average age was around 50, and male predominance with males being around 55%, average SOFA being 5.4, and the common causes of admissions being sepsis and including leptospirosis of around 39% and heart failure about 23%. The new onset AKI approached almost 50%. Average mechanical ventilation days was around 3.5. The length of stay was around 5.3 days, and mortality was 28 to 36. With the SOFA score of the mortalities being around 8.5 and the average length of stay being 6.5. But as I said earlier, we need to have a national system to monitor this. Then about the outreach services, the recommendation is all hospitals should have an early warning score, validated track and trigger system activated 24/7, created clinical response strategy and trained personnel for this. And again, a national outcome audit should be conducted to see its effectiveness. So what happened in Sri Lanka? We have locally activated outreach teams in progress, but adults and audits and published data are scarce. For example, the National Hospital of Sri Lanka has this modified early warning score as well as the procedure to do on a trigger after something's being triggered. But again, we don't have any data to see how effective this system is. Then about post-ICU care follow-up. Now the recommendation is, as Dr. Sali Musaman said earlier, the long-term mortality should be calculated, and also there should be things that should be measured beyond mortality, that is functional ability, socioeconomic consequences, and care burden of the survivors. As we know, the consequences of ICU stay increases 2.5 mortality in the survivors, and it restricts the predicted 6-minute walk distance. It reduces the expected quality of life. It causes depression in the patients themselves, and also on the family and caregivers. It reduces their daily activities by 20%, and it causes depressions in 23%, which is the family. So look at the impact. Now, we don't have post-ICU care Sri Lanka. We did not have, but in 2019, the MICU intensively started the first post-ICU care follow-up clinic. This is their clinic model, which they have got approval for. And these are the things that they measure. They measure the physical outcome, the psychological outcome, the pulmonary function, nutrition, the social support, and the palliative care. So in our experience, so as I said, there was a recommendation, then there was what we had. There was a gap. Can we fill that gap? In our experience, central and national level acceptance of the need to improve critical care services is needed. We needed data to understand our population who have become critically ill in order to improve care and services. And there is training of staff that should be uniform and consistent all over the country. And also the attitudes of everyone should change with regards to audit and research. So in summary, critical care facilities have come a long way in Sri Lanka since its establishment 50 years ago. Data on critical illness and management are...
Anushka, may I draw your attention, please?
Yes.
Your time is over. I think it would be better for us to manage the time if you finish your presentation within 1 minute next.
Yeah, okay, that's fine. It's finished. I was in my summary. So, okay, thank you very much and best regards from Sri Lanka.
Thank you very much for your nice presentation and sharing your experiences with us. I think it will be helpful for the participants. I would like to draw the attention of all the participants because due to our time limitations, time constraints, we are not going to the question and answer session. But if you have any question, you can ask it by mentioning the name of the presenter in the chat box, and I will request the presenter to respond there. Thank you very much. I would like to go to the next. Anushka, do you like to say something?
No, that's fine. Thank you.
Okay. Okay. Thank you very much. Now, I would like to request Professor Arshad Taki from Pakistan. He will talk about specialist training in critical care in Pakistan, how we started, where we stand. So I think it will be another important topic for our participants. May I request Professor Arshad Taki to start your presentation?
Thank you very much. Can you hear me?
Yes, it's okay. Please proceed.
And can you see the screen, please?
Yes.
Is my screen visible? Thank you. That's great. That's lovely. So I am Arshad Taki, and I work for an organization known as Call Associates. A word about that. At this point in time, incidentally, I've also been entrusted to look after the Pakistan Medical Commission. I am the president of Pakistan Medical Commission, which I've just joined them there last 2 weeks ago, which is the main regulatory body of all healthcare, all doctors in the country. So that's the dual responsibility that now I have. But primarily, I am an anesthesia and critical care consultant. And so if a word about Call Associates, this is essentially a unique model. It's an association of partners formed in 1994, started small, with the objective of providing more than just the kind of anesthesia services that were being provided all over the country in private sector. So we started off as around-the-clock service, which was consultant supervised, and with the presence of anesthesia personnel manning the post-anesthesia care units, PACU and ICUs. Now we have grown over the years to be more than 150 doctors in that organization, plus allied health professionals who have worked for this organization. This organization now covers 3 major hospitals in the city, with the which was, and in 2001 we actually also shifted towards becoming a postgraduate training organization, which was formally recognized by the College of Physicians and Surgeons Pakistan for training in anesthesia in 2001, in critical care in 2012, and in pain medicine in 2020. So we provide services all over the anesthesia services. Besides that, we are also involved in nationwide training of doctors and now nurses through basic courses and CER courses, which are those by. But that's a word about us. But that's not what I'm talking about. That's another topic for another day. What now I'm talking about is the development of evolution of FCPS critical care medicine program by the College of Physicians and Surgeons, Pakistan, which is the premier postgraduate degree awarding institute in the country by law. So, let me begin from where we stood in 2009. There had been attempts by the College of Physician Surgeons and other authorities, other entities to develop a postgraduate training program in critical care in the country. Khan University started a fellowship program with, of course, which was producing a very limited number of fellows. Pakistan Institute of Medical Sciences, with the help of a French university, actually started a diploma program which they thought would lead to a master's in critical care. And realizing the shortage and the need for critical care personnel, trained critical care personnel, College of Physicians and Surgeons Pakistan actually decided to launch a formal post fellowship in critical care medicine. At that point in time, critical care workforce or intensive care workforce in the country largely consisted of anesthesia personnel who were manning intensive care, surgical intensive care units, which were rather more like an extension of the anesthesia services. Some of the pulmonary critical care fellows primarily from US or UK had moved back, and some of them had actually established with some public support from public institutions as well as other institutions in pulmonary ICU, largely pulmonary ICUs. So the college actually summoned the first meeting of critical care faculty. This faculty was formed keeping in view that the college should involve both anesthesia and pulmonology or internal medicine and make them devise a common curriculum for both surgical and medical ICUs. So that the faculty first met on the 12th of June. I was fortunate to be a part of that faculty, and I've been on that faculty since then. So the faculty met, they elected their first president, who was Professor Fawzia Anis Khan, and the secretary, who was General Aslam Khan, who was a pulmonary critical care fellow. So the position of president and the secretary also was kind of divided between anesthesia and pulmonary critical care. So we went on. This critical care medicine faculty actually is appointed by the president of College of Physicians and Surgeons Pakistan after approval from the College Council, and the faculty is constitutes 50% anesthesiologist and 50% pulmonary critical care med. In view of the short kind of a small anesthesia fraternity at that point, this faculty usually was consisted of about 4 to 6 members most of the times. Their task was to develop a curriculum and then make recommendations for further changes in the curriculum as and when the need required, develop a complete training program that determine the syllabus and conduct the exams, which was FCPS critical care medicine. We met and we decided that it is going to be a competency-based curriculum. So, and this is going to be a second fellowship, which means those who have already had earned their fellowship in anesthesia or internal medicine or pulmonology and nephrology. At that point, these 4 pathways were identified. However, eventually, a couple of people from cardiology background also applied, and then the discipline of cardiology was also included in this second in the pathway. This was supposed to be a 2 years program. It was to run it, and it runs in recognized units, which are recognized under a very stringent criteria, under supervision of CPSP approved supervisors, and I'll come to the criteria in a while. And so we identified, based on Povertris, we identified 11 competencies in 11 domains, and these domains as I would say, included the resuscitation, initial management, diagnosis, assessment, investigations, monitoring, and data interpretation, then disease management, which included acute illness, chronic illness, organ failure. Therapeutic interventions was another domain, practical procedures, which included all the procedures that a fellow or a doctor working in the ICU is supposed to be performing. And then there was a domain of perioperative care. We identified comfort and recovery as a separate and big domain, end of life care, transport of critically ill patients, patient safety and healthcare systems, and professionalism. So they were the 11 domains identified. In all those domains, each one of those domains, we identified those individual competencies which were measurable, identified the level at which these competencies were supposed to be achieved by the end of their training, and at what stage of training, what competence they were supposed to be have achieved. The college recognizes these post-operative, these fellowship training institutes after a rigorous system of inspections, which and then those institutes are recognized, and within those institutes, individual disciplines are recognized according to a predefined criteria. So what the first thing in that criteria is presence of a CPSP recognized supervisor or more than one supervisors as need be. An optimum pay caseload, which is and an appropriate case mix, so and equipment support, learning aid, and all kind of other logistic support to put a training structure in place. So once the inspectors are satisfied that an institute and that particular discipline meets those criteria, they make a recommendation to the college, and then it goes to the college for approval. The supervisor, we had to at that point make a compromise, because at that point there were two sets of people who were practicing intensive care. Most of the anesthesia fellows, people who were working in the post-anesthesia care in the ICUs, were actually did not have a formal certification of training from in critical care medicine, but they had worked in recognized ICUs at some point in time after their fellowships. So the college, they agreed to let anesthesia fellows with that experience, more than 10 years experience of, and having worked for 1 year post-fellowship in unrecognized ICU to become supervisor. The supervisors during that transition time till the time the actual fellows took over. In case of medicine or pulmonology, because in our medicine pulmonology curriculum does not really involve an extended rotations in critical care, which anesthesia curriculum has. So they were required to have a formal postgraduate qualification in critical medicine in order to become approved supervisors. What we were envisioning at that point was that as the second generation of supervisors who were fellows of the college and people returning from abroad with formal qualifications would take over, then this need for the first generation would gradually fade away. The CPSP approved supervisor is supposed to have attended certain workshops. These workshops are actually designed to tell them all about the teaching methodology, including research, and all the other soft supervisory skills that are required in order to conduct appropriately supervise a trainee. It is also mandatory for them to have an advanced cardiac life support certification. And once they have meet all that criteria, then they have to submit 50 MCQs, which are then reviewed and approved, and only then they are given a certificate for supervision, provided they are working in a recognized training institute. So there's a fairly stringent criteria for recognition there. The rotations that were decided included rotation in anesthesia, pulmonology, cardiology, nephrology, transplant, oncology, emergency medicine, internal medicine, neurology, and an external ICU rotation. But it was agreed that it would be 6 months of external rotations, 18 months in the parent unit, and the kind of rotations would actually be determined decided by looking at the competencies and the previous competence of the trainee, and it would be discussed and between the supervisor and trainee, and knowing that the trainees are mature people, adult learners, so they need know their limitations. So those rotations are then agreed between supervisor and trainees. There is a proper formal e-log and a formal competency chart in which each competency is defined at the level that needs to be performed. The trainee by the end of their training is required to perform a clinical audit, which is then approved by the institute, and also have a research publication in a CPFC approved journal. The College of Physicians has got a fairly robust e-log system wherein the trainees are supposed to input all the data required regarding their experience, daily working in an e-log. They do give an allowance for a week's delay, but if there is no data input within a week, the resident gets a warning that they have not been entering their e-log. And the supervisor, of course, is supposed to approve them. And if they do not approve them within that prescribed time, they also get a notification that they have not been. And then they are supposed to submit a quarterly report of the trainee's progress. And all this is actually fairly robust because then you got all the data to support what you're looking for. At the end, the supervisor certifies the trainee has achieved all the requisite competencies in all domains and is ready for examination. We are working at actually putting the work-based placed assessment in place, and critical care is going to be one of the first funds which will formalize those workplace-based assessments within the e-log and the training program. So that's the next step that we are looking at. The exam is, once again, we realize that the real certification comes from the supervisor, but still it's a very robust exam. It includes a theory paper, which is short answer questions and MCQs, and they involve all the domains. Then a task-based assessment of clinical skills, which is a CPSP version of OSCE, but more interactive and not just based on observation, but rather more on interaction and demonstration of skills. So we have a lot of simulations there and tasks that they are supposed to perform. There's a long case, and there are 2 case-based discussions, which we call short cases, but where a case is pretty exhaustively discussed in the form of a case-based discussion. So that's the exam. So where do we stand? We had a slow start because in the beginning, we were very careful about not making this program, excuse me for using the term cheap. We had to maintain our standards. And initially there was a slow progress. We managed to have 36 fellows in the first 10 years because the criteria for recognition was stringent. But over last 1 year now, it is beginning to have that snowball effect. Those 36 fellows that we were produced, now a few of them, very small number of them, have actually encouragingly gone and to work overseas in the Gulf. Most of them have stayed back. They have found career opportunities here, and now they are becoming leaders. So over the years, over this last few 1 year or so more, we have had larger induction. Now we've got 35 trainees inducted and working. And the number of training centers has by this now increased to 15. So now we are looking at a snowball effect, and hopefully over the next few years, we will be looking at large numbers. What are the challenges? So the biggest challenge, the biggest impediment is actually of critical care as a career. So because the critical care initially was not very well rewarded and financial compensations were few and institutional support was not very high, so the way the healthcare system works and used to work, and that's beginning to change, but used to work in Pakistan, was people making their own living off their private practices in the evening, and critical care was not a very attractive domain there. So most of the people would then cling to their primary critical care, primary specialty, and just treat critical care as an extension of primary, which was an impediment to making these institutions actually closed ICUs. Anesthesia fraternity.
Professor Arshad Taki, sir, please, may I draw your attention, please? Our time is limited and it is over.
Is it over? 1 minute?
Yeah.
Over. Okay.
Yeah,
so
sure.
Just
sure.
30 seconds. So
please continue for 1 minute.
Okay. So the only concern has been the anesthesia has not really been at the forefront of critical care programs. At this moment, our training force is 20% anesthesia, 80%. And that has got a lot to do with because the anesthesia people find more career opportunities after fellowship. Medicine people have come here because they find another. We are looking for support from nursing and other staffs and funding. COVID has been a great blessing in a way, and I'm not really happy about that, but it has given critical care an image, and people are finding it more attractive as a career, and we see this happening. So if you have knowledge, let others light their candles in it, as Margaret Fuller said, and that's what we're trying to do. Thank you very much.
Thank you, sir. Thank you, Professor Arshad Taki. From your presentation, we came to know some modalities of specialist training in ICU, I think, which will be very, very beneficial for our trainee doctors who are going to be trained in ICU in coming days. Thank you, sir. Thank you for being with us.
Thank you very much. Thank you very much.
Our last but not the least presented of this session, Dr. Wahid Altaf, who is from Ireland. He will talk about outcome of elderly patients in intensive care unit. May I request Dr. Wahid Altaf to continue your presentation? Dr. Wahid Altaf, do you hear me? Hello.
This is our Karjanol.
Can you hear me?
Yeah.
Good afternoon, Bangladesh. My name is Dr. Wahid Altaf. I'm one of the intensive care consultants working in University Hospital Waterford, which is one of the 32 counties in Ireland. So Ireland is made up of 32 counties, and I'm working as a consultant and a clinical lead in one of the intensive care units, which is called University Hospital Waterford. So before wasting any much of time, I would like to go to the presentation directly. I'll be talking about the outcomes of elderly in the ICU, which is a bit of a change from previous discussions. So if you talk about disclosures, I have nothing to disclose except that I know a few elderly people, and I can see a few elderly faces among your panelists as well. So to start with, I'll be talking about demographics. I'll be talking about mortality, especially ICU and the post-ICU mortality, and I'll be talking about factors affecting the mortality and the ICU outcomes. So if you talk about the elderly, the first question which comes to your mind is, okay, who are the elderly? Do we define elderly by some chronological age, by just picking up a number and saying, okay, 64.9 is not elderly and 65 is elderly? Or should we talk about some physiological status setup? Then beyond 30, our physiological processes don't start to grow anymore. So should we pick up 30? Or should we say the age of retirement, which is different in different countries? So it's all very complex when we have to define a particular group of population as an elderly. So in most developed countries, and what WHO has defined as well, we take 65 as an age of elderly. Above 65, we think most of the people are elderly. And for ICU purposes, when we define elderly, the age goes between 65 and 90, depending on the country where you are and the continent where you are. So they'll be all changing. So the second question comes to your mind, okay, why do we see elderly? We see elderly because our life expectancy is increasing. And if you look at Bangladesh, like, current life expectancy of 72.59. So as the life expectancy of people is increasing, the number of elderly people is obviously going to grow with time. Now, sorry. And what consequences does this have if the number of elderly population is increasing worldwide? How does it affect the ICU? Well, it does affect the ICU because more and more of our population being admitted to the ICU is elderly, and the proportion of these patients, the absolute number, both are increasing. If you look at any study around the world, if you look at this study done in New Zealand or Australia, the more population being admitted to the ICU is elderly, and the proportion of the population being admitted is increasing as well. So what's the problem then? Okay, let's admit all of them to the ICU. Why not? Well, obviously there is a problem. ICU is a very expensive resource and we can't waste it, and we have to be very careful in who do we admit and who do we not admit to the intensive care unit. If we look at Bangladesh, I'm not sure I have the right data, but as far as before COVID, the population of around 161 million people and 1,169 ICU beds, which makes it around 7 beds per a million population. So if the resources are limited, so you obviously have to think, okay, who do I admit and who do I not admit to this intensive care unit, and who is going to get benefited? Now, if you look at the elderly population, which is being admitted to the intensive care unit, if you follow them through up to a year of discharge from the ICU, you'll say, okay, suppose I admitted 10 people to the ICU today. Out of these 10 people, suppose 8 go out to the ward. Out of 8, only 6 will be discharged from the ward to the home or to a nursing home or to a residential care. And obviously, if you follow them up to a year, you find only 1 or 2 of these 10 people who came to my ICU a year ago are alive. So you begin to think, you say, okay, did I do the right thing? On the other hand, I had a 40-year-old gentleman who could live for another 40 years, and I'm just not giving him an ICU space. I'm not giving him the bed while I gave it a bed to a 90-year-old. So does this make any sense if you have limited resources? So it obviously does not make any sense. So you have to be careful in who do you admit and who do you not admit to your intensive care unit. Now, if you look at the mortality of elderly population in the ICU or in the hospital, you'll say it is obviously much higher as compared to the younger population. If you see the crude or the adjusted mortality, you'll see if the mortality in the ICU is twice as compared to the younger population, while as the hospital mortality is 4 times as compared to the same people of same elderly people is 4 times as compared to the mortality of the younger population. So obviously you have to think before admitting any patients. And it's not only one study, there's lots of studies, whichever continent you look at being done, and they all show that the population greater than elderly has a higher mortality as compared to the younger population. And the difference, if you look at the delta gap between the ICU mortality and the hospital mortality, it grows further. So that means more of these people who get, suppose you admit the elderly to the ICU now and you discharge them to the ward. Obviously, when you discharge them to the ward, they have an even higher mortality in the ward. Why is this? Because they don't get the same level of care as you give them in the intensive care unit. There's no one-to-one nurse. There's a one nurse looking after a few patients. So obviously there's limited number of doctors looking after them in the wards. So they have even higher mortality in the wards rather than being in the ICU. So even though they have the higher mortality in the ICU, but they have even higher mortality when they go out to the wards. So a huge mortality associated with it. And it's not only ICU and hospital mortality. If you follow these people and you look at 6 months mortality, suppose looking at this study, it shows that if you at emergency triage or an ICU triage found people who were very sick and you admitted them to the ICU, the mortality was around 80% by the end of 6 months. So obviously you have to think. And with time, whatever study you look at, with time, the mortality keeps on increasing of these elderly population. So you have to think at every step. But age alone cannot predict the mortality. It's obvious to us. And not all 80-year-old, 90 years old are the same. And they may not continue to be the same. You know, our attitude is changing. If you told me a 65-year-old maybe 20 years ago, I might think he's elderly. Now I'm thinking, and living in Europe, I'm thinking around 80, 90 year. When somebody talks to me about admitting a 90-year-old, I have a different approach now. So if you look at this study, like, this was done it was a Danish study. They looked at 93 to 95-year-old people who were 2 cohorts, one born in 1905 and another cohort born in 1915. They looked at all of them when they were 93 or 95 years of age. They found that like people who were born in 1915 had a daily living scores much better, and they were much more cognitively, or living conditions were better than those who were born in 1905. So people born in different ages may have different outcomes, different attitude at the end of their 90 years. Obviously, if we look at ourselves, we are all used to so much of mobile phones and all this technology. I don't know how it's going to affect our life. Maybe at 90-year-old, we'll be all crippled in the bed, like sitting with a mobile phone. So obviously, things change over time. So you cannot say 90 is elderly today and tomorrow it can change. It can't change. It will change surely. Now, again, if you look at these two, images, all the 90 years old, all the 80 years old are not same. If you look at them, they are different. Now you have to define how are they different. Okay, so if you look at them, they are different in terms of frailty scores. If you look at them, there is a nice clinical frailty score which you can look at. So every elderly is different. They could be very fit or they could be terminally ill. So you can't take all of them with the same, you can't beat all of them with the same stick. So they're all different. So you have to look at, okay, how frail is this patient which I have to admit to the ICU? Then you look at the nutritional status. You see, okay, some people are healthy, some people are not healthy, some people are emaciated. So obviously that has consequences once you admit anyone to the intensive care unit. And every elderly has comorbidities, and not only the comorbidities, the severity of these comorbidities is different. So somebody might have well-controlled hypertension, somebody might have uncontrolled, controlled diabetes, uncontrolled diabetes, controlled dementia, early dementia, and late dementia. So consequences are going to be different when you admit them to the ICU and then discharge them to the ward. And then again, they get admitted to the hospital for different reasons. Somebody might come for an elective surgery. Somebody might come for an emergency surgery. Somebody might get a medical admission to the intensive care unit. So they're all different. You can't say they are all same. And again, the severity of sickness. Okay, they got admitted with, somebody gets admitted with pneumonia. It could be very severe pneumonia. It could be just mild pneumonia. So the Apache scoring, which are different scoring systems for admitting patients to the intensive care unit, they could be different. So you can't beat all of them with the same stick. So you have to look at this population in terms of all these factors. And how do these factors affect these, anyways, the outcome of these patients? If you compare a fit elderly with a frail elderly, what is the problem? The fit elderly is also already living at the baseline. He is balancing well with his physiological aging, with his comorbidities, and with his functional alteration in his autonomic capacity, autonomic functional capacity. He can't move out much. So he's balanced if he's a fit elderly. While as a frail elderly, he's already living below the baseline. He's already struggling with his life. And when you give them acute stress of admitting them into the intensive care for any serious infection or any serious surgery, obviously they go much beyond the baseline. And then they find it hard to recover, go back to the baseline. So obviously, the more frail the individual, the worse is the outcome going to be after being discharged from the intensive care unit. So it's not only intensive care unit. When you discharge them to the hospital, obviously, if they are more frail, they're going to have worse outcome. If you look at them discharged from the hospital to the nursing home to the home, again, it affects how frail was the person. If he was very severely frail, he may not go out to even if he gets discharged from the hospital, he may not go home. He might have to be admitted to the nursing home. So it affects their outcome anyways, whether you admit them to the ICU or not. And again, if you look at the frailty, the reason for their admission, if you admit a frail individual for an elective admission, his mortality may be lower. But if you admit for an acute admission for some surgical condition or a medical condition, his outcome is going to be worse, with some studies suggesting a mortality of around 80% by the end of a year. So you have to be careful. The second factor which we are going to look at is the comorbidities. Okay, how do the comorbidities affect the ICU outcome? If you look at the comorbidities, obviously there's no rocket science in thinking about that. Okay, if a person is more comorbid, he's going to have worse outcome. If a person is less comorbid, he has less comorbidities, he's going to have good outcome. So if you have a person who has no comorbidities and you admit him for a planned surgery, obviously his outcome is going to be good. He's going to be discharged well to the home. But on the other extreme, you have a person who is living under the burden of so many comorbidities, then you admit him for a medical admission, and obviously his outcome is going to be worse. So all the other categories, suppose you have a planned surgery, you have a medical patient, you have an urgent surgery, they lie in between. So they are the two extremes. So if you have a medical patient with lots of comorbidities, the outcome is going to be worse. So there's no point in offering them a critical care if you think their mortality is going to be higher. Again, if you look at their mortality, depending on the type of the ICU admission, if you look at the medical admission, some studies suggesting that, okay, 1 to 30 day mortality of around 40%. Surgical population, if you admit them acutely, around 40% mortality. If you admit them for an elective surgery, their mortality is going to be much lesser. So with time, their mortality is going up and up. And This is all the elderly population, depending on the type of ICU admission. Now, again, some different studies looking at different quarters. If you look at this study, this showed that, okay, 60% mortality for, 60% of people who were admitted to the intensive care for planned surgery had a good outcome, while as around 40% had bad outcome. This is elective surgery. And if you look at the people admitted for medical or acute surgical problem, their mortality was even higher. If you look at the 1-year mortality, 80% for the medical patients and 67% for the subgroup of unscheduled or an acute emergency surgery. So obviously a huge mortality associated with this. So let's just ignore, okay, we thought their mortality is higher depending on their comorbidities, frailty, nutrition, okay, all that accepted. But are we being a bit biased? Do you think we are being biased in admitting these elderly and then we're saying they have the higher mortality? Let's look at that, okay, if we are not biased, if we admit elderly, okay, every elderly to the ICU, does that change? So let's presume for a while, for a few minutes, that all elderly are same, and it it will change their mortality and they'll spend less time in the hospital if we admit them to the ICU. So let's presume for next few minutes time. Okay, let's look at this study. This was a French study which looked at around 3,000 patients, critically ill patients. And when they looked at them in 24 hospitals in France, they categorized them into two groups, one control group and one other, the intervention group. So they divided these 3,000 patients into 1,500 each. And what they did, they said, okay, let's just look at these 1,500 patients in the, in the intervention arm. Whenever these patients come up to the above 75-year-old age, for any reason, if they were cancer-free and they had good functional and nutritional status, they came up to the hospital A&E being sick. The A&E consultant picks up the phone. He calls on the intensive care consultant, says, I have this gentleman. Can you admit him to the ICU? And if he needs ICU, he gets admitted to the ICU. No saying that we don't have beds or we don't have the resources. Admit them directly. Okay, let's see what happens. So admit them into the intensive care unit. And while as the other group was the normal care, where a person picks up the phone in the A&E, calls the ICU consultant, he says, I have no bed or whatever, so for those reasons. So they divided them into two groups. One got the best care and the other got the normal care. Okay, they looked at their mortality. So you expect, obviously, people, you might think, okay, people who were admitted to the ICU, they would have good outcome and they would stay in the hospital less and they would go home quickly. So you would think that, but on the contrary, when you look at these populations, you found that, okay, in the intervention group, people who came to the ICU, obviously a greater number of them were admitted to the intensive care unit. Around 60% of them were admitted to the intensive care unit, while as in the control group, 34% of only patients were admitted to the ICU. What do you think about the mortality? The mortality is starking. If you look at the hospital mortality or the ICU mortality, the mortality was much higher in the people who got admitted to the intensive care unit, 30% versus 21% only in the people who did not come to the intensive care unit. So obviously, if they followed them up at the 6-month mortality was even higher in the people who got admitted to the ICU rather than people who did not get admitted to the ICU. So the intervention did not change anything except that it increased the people coming up to the ICU and it increased their mortality at the end of few months. So this was the graph, if you wanted to look at how many patients in each group. And obviously, as I said, the mortality was higher in the people who were admitted to the ICU at the end of the 6 months or at the end of discharge from the hospital. Now, again, do we provide them less care in the intensive care unit? No, not obviously. If you look at the mortality rates as compared to the younger are not much higher in the elderly population in the ICU, but when they go out of the ICU, there's mortality is even higher. So if you can't provide the same level of care as you provided them in the intensive care unit, that doesn't mean you should just provide that care because you want to get them through the intensive care. It's not the point of getting people through the intensive care unit. It's the point of getting people healthy back to their places where they came from. Now, it's not only about, as I said, the mortality. If you look at the quality of life of these ICU patients when they get discharged from the ICU, so looking at this study, their quality of life, even after admission to the ICU is worse, like around only 20% recover to their full functional capacity at the end of the year, while a huge amount of these populations are either dead or are living poorly at the end of 1 year. So don't just look at the mortality, look at their lifestyle. Okay, how are they living after being discharged from the ICU? Because living in ICU is not easier. Having come to the ICU with a critical sickness is not easier. It's difficult for a younger population and not to talk about the elderly population. So as I said, it's not mortality, but quality of life as well. So if you look at this study, they looked at the people who were admitted to the intensive care unit at one particular time, and they found that, okay, their disabilities were much more when they got, good number of people died, and the good number of people had severe disabilities when they were discharged from the ICU, when they were followed up. So no need to think, if you are thinking about this 99-year-old gentleman who is healthy, elderly, no or well-controlled comorbidities, and is coming for an elective surgery, please go ahead and admit him. You will obviously have a good outcome. But on the other hand, if you have a frail elderly who's living with comorbidities, who has multi-organ failure and is coming for emergency surgeries, think before admitting, think before offering them the intensive care unit. So use your resources very wisely, because being healthy is not a matter of just absence of disease or infirmity, but a state of complete physical, mental, and social well-being. So elderly patients and family members value care if it is. So different studies look at this. So they value, the family members of these elderly value the care provided to their patients, but patients have to be comfortable and has to suffer as little as possible. And that is the most important value. The thinking that, oh, everybody has to survive the ICU and have the belief that life should be preserved at all costs is least important to the family members, if you look at that. Sorry.
The time allocated for Dr. Wahid Altaf is over. May I request you to conclude your presentation?
Thanks. I'll take 2 minutes. So
okay, proceed.
So the family members will care value much more, and you will spend less resources on these patients if you think before admitting these patients to the ICU. So hospital, like, what do you do if you don't admit them to the intensive care unit? Obviously admit them to the hospital on a regular ward, have the geriatric physicians looking after them. And because coming up to the ICU comes at a cost, there's nosocomial infection, there's iatrogenic complications from our invasive monitoring, and there's increased hospital length of stay. They're most restricting visiting hours for families too. So they all affect the outcome of these families. So obviously, in conclusion, admit based on severity of illness, comorbidities, the levels of frailty and disability, the expected impact of treatment on the outcome, and take into consideration the expression of wishes regarding do not resuscitate orders. The resource like ICU bed is taken into account as well. So efforts to ensure rapid, and even if these patients get admitted to the ICU, make sure you discharge them as quickly as possible. And elderly population is predicted to grow and grow significantly. More ICU resources will be required to look after this population. And early discussion with family and patients may significantly alter the resource in the course of patient's admission. So should elderly people with every high risk of death be given opportunity to end lives in another way rather than turning off noradrenaline and ventilator, we should have a thought about that. And obviously, who will admit this lady into the ICU and who will not, you have to think. And that's all. Thank you very much.
Thank you, Dr. Wahid Altaf, for the nice presentation. With this, I think the mortality of the elderly people in ICU would be reduced. Thank you very much. Now I would like to go to the chair. First of all, I would like to request Dr. Raghib Manjur to make his comment. Dr. Raghib Manjur, sir, can you hear me?
Yes, please.
Yes, sir, continue, please.
Can you just unshare the screen, because it's a bit problem. Anyway, so this is a great honor from the excellent e-conference 2020 organizers to invite me to chair, along with highly dignified anesthesiology professional personalities from home. Burden of sepsis globally is huge. 49 million people get sepsis and 11 million deaths throughout the world. Every day, ICU researchers are trying to introduce new medications, procedures, or treatment modality to reduce the death of ICU patients. Hyperbaric oxygen therapy is one of the new modality, which is this year, they have a lot of efforts given because this COVID-19 has opened the eyes, because high flow nasal cannula is one of the definitely promising procedure, but hyperbaric side by side has given some benefit to the patients and being prevented a lot of patients from intubation and ventilation. In Wuhan, China, as well as in Western countries. Because I'm mentioning this thing because this is not being discussed in many forums, especially in Bangladesh. It's very much new concept. Interestingly, that Dr. Cunningham, who treated many Spanish flu patients in 1918 with HBOT, hyperbaric oxygen therapy, was also an anesthesiologist. So what I mean that our juniors, they have a lot of scopes because from anesthesiology, critical care, pain, and a lot of other subspecialties has developed. So there are a lot of scopes for the new anesthesiologists. I think they can explore. And today, the speakers were excellent, definitely. And Professor Khalilur Rahman, who is also my teacher, is here to comment more about the lectures. But I found many very interesting Dr. Wahid Altaf's presentation, that frailty score, which is very interesting because many of the people, I mean, physicians, even the physicians of the critical care, they think that any elderly people who goes to the ICU ventilation, they will die. It's not true. There are a lot of, I mean, points to care, and I think frailty score is one of the things to be considered. So there are a lot of challenges, definitely, but in every ICU, there are a lot of, I mean, elderly patients are coming up, recovering due to the, I mean, the treatment modality, nursing, nutrition, physiotherapy, lot of things we have to do in the ICU. So infection control in ICU, about Professor Naila mentioned, we know it is very challenging because this is the only thing, or what we always think that what else we can do for our patients to, I mean, to manage them, to save them from dying. So gradually we are thinking, so that's why I'm thinking that why not hyperbaric oxygen therapy also we can try in our country, in Bangladesh in future. And the organizational setup in critical care service, which Dr. Salimujjaman Bhuiya has mentioned, and I know he's a very potential Bangladeshi. We missed him really in our country, but hopefully he is doing fine there. And his presentation was very good, interesting, because he can guide many of our junior anesthesiologists how to develop, how to get, even in the abroad, to get the residency programs and to educate them properly, equip them properly in critical care. Dr. Anushka has mentioned resource limited setting. This is very interesting because in our country also, one of the resource limited country. So we have to think, but my request to the juniors that always work professionally. And you will find very interesting that with your personal effort also, some patient will be survived, some patient will escape a lot of complications. So everybody can think that how we can serve more in the critical care patients. And specialist training, Dr. Ashad, I think he left already because of his meeting, but this is very interesting. And I think this is a good guideline for our teachers, faculties, and also our junior residents who are going for critical care training program. So the time is very short. I will not take too much time. So thank you very much. Thank you all, the participants, the organizers, and Bangladesh Society of Anesthesiology. Thank you.
Thank you, sir, Dr. Ragib Manjur sir, for your valuable remark. I think the anesthesiologist, especially the junior anesthesiologist, will be encouraged with your speech. Thank you, sir. Thank you for being with us. Now, I would like to request Professor A.K.M. Shamsul Alam sir to make his remark. Professor A.K.M. Shamsul Alam sir, can you hear me? I like to draw your attention, sir. Professor Shamsul Alam sir.
I think he's trying. He's there. I have seen him.
Kashyap Goyal, can you stop your sharing for a few minutes? After this session, you can share. Thank you. Okay, so carry on for the next.
Problem with some
sir, we cannot hear from you.
Yes.
Shamsul Alam, sir, we cannot hear you.
Can you check your connection with the earpad?
I think there are some technical problems.
I think you can remove it better.
Sir, I think your earphone is not working well.
So can you disconnect it?
Yes, can you hear me now?
Yes, yes.
Yes, sir. It's okay now.
My earphone is not working. Okay. Thank you very much, Dr. Mohammad Amin Hossain Rahat. First of all, I want to thank the organizing committee of the Bangladesh Society of Anesthesiologists who was giving me the opportunity to chair a session with my teacher, Professor Khalilur Rahman, and my senior brother, Dr. Agim Monjur. Then in this session, all the speakers were excellent in their presentation, and we have all learned a lot. And I think that's all from me. Thank you, Dr. Rahat.
Thank you, sir. We are also very happy to get you with us in this first international e-conference on critical care. As you know, the critical care is a very burning issue at this moment, not only in Bangladesh, all over the world. Now, I would like to, my teacher, better I say, teacher of my teachers, Professor Mohammad Khalilur Rahman sir, to make his valuable remarks.
Okay, shall I shoot? Can you hear me?
Yes, sir.
Shall I shoot?
Yes, sir.
Yeah, the only thing is that when a session extends by 1.5 hours, there shouldn't be any comment. Only one comment. After listening to Wahid Altaf, I will instruct my family members never to take me to any ICU for my treatment. Thank you. That's it. That's it.
Oh, thank you, sir. Thank you very much. You are the living legend of anesthesiology, and you are inspiring all of us in every moment. Thank you, sir. May Allah bless you. I wish you good health and long life. Before concluding this session, I would like to thank again Professor Naila Asad from Pakistan, Dr. Muhammad Shalimuzaman Bhuiya from United Kingdom, Dr. Anushka Mugalis from Sri Lanka, Professor Arshad Taki from Pakistan, and Dr. Wahid Altaf from Ireland for their nice, valuable presentation. And I am expressing my gratitude to BSF for giving me the chance, the opportunity to conduct such an important event. Thank you very much. Thank you, Kausar Sardar. Thank you, Professor Debabrata Monik, sir.
Thank you. Thank you very much, Rahat Bhai, for your nice moderation. At least you have saved the time, and thanks a lot all the speakers for their nice presentation and their respect to the time also. It is very difficult to control actually for everyone, but yes, it was a very nice presentation. A lot of things you have incorporated in your presentation. We have been benefited. We will definitely, all the attendees have been benefited from your presentation. So we are moving to our next session because we are one session down already. So we are moving to the next session. Next session will be conducted by Dr. A.K.M. Habibullah, and same, we have five speakers here, and here we have the fourth chairperson here, Professor A.T.M. Khalilur Rahman. He is the head of the Department of Anesthesiology and Critical Care of National Heart Foundation. Professor M.A. Haisar, he is the professor of Department of Anesthesia, Analgesia, and Intensive Care Unit, Bangabandhu Medical University. And Dr. Lutful Aziz, he's from Evercare Hospital. He's the consultant of their anesthesia and pain medicine. And Dr. Ritesh Ramsal from Nepal. He's the Joint Secretary of Society of Anesthesia Nepal. So I'm handovering the mic to Dr. A.K.M. Habibullah to moderate the session.
Thank you very much, Professor Kausar Shodhar, to select me to conduct this session. It is very valuable session. All the session is very important for the practice of ICU. Welcome to everybody, every participant and foreign delegate, ICU expert, intensivist and learner in first International E-Conference on Critical Care 2020. This conference is arranged by Bangladesh Society of Anesthesiologists. Anesthesiologist has the vital role to establish the concept of advanced intensive care. In 1950, anesthesiologist Peter Schaeffer established the concept of advanced life support, keeping patients sedated and ventilated in an intensive care environment. Schaeffer is considered to be the first practitioner of intensive care medicine as a specialty. Intensive care unit has the vital role in the COVID pandemic situation in now whole the world. Already we save a lot of valuable life in intensive care unit in whole the world. In this session, there are the 5 foreign speakers. They are the more experienced and learned person in intensive care field. I believe that we achieve a lot of new idea after completed this session. Now I requested the chairperson to take their seat. Already Professor Kausar Shodhar has announced the name of our more valuable, experienced chairperson. There are 5 foreign speakers in this session. And we have only 15 minutes allocated for this session for each speaker and 5 minutes for the question and answer session. At first, I requested to my first speaker, Dr. Keshav Goyal from India. His topic is multimodality neuromonitoring in neuro ICU. Thank you, everybody. I want to request Dr. Keshav Goyal to start his lecture. Hello, Dr. Goyal.
Yeah, and very good evening. Am I audible?
Yes,
Yeah.
yes.
Yes,
yes.
Okay,
Dr. Goyal,
thank
you can
you.
start.
Okay.
Yes.
So from elderly population, now I am taking you through the neuro patients. So basically, I would at this outset, I would like to thank Bangladesh Society of Anesthesiology and also Dr. Kausar Sardar, who has given me this opportunity to be here in this August gathering. My topic is multimodal neuro monitoring in neuro ICU. Now the question comes, why? Why this multimodal neuro monitoring is required in neuro ICU? The neuro patients are slightly different because the main goal, main aim of these patients, main aim of the neurointensivist is to prevent and manage secondary brain injury. And as these patients are comatose, these patients are sedated. So to get the information what is happening inside the rigid non-expansile skull, we need to have some gadgets so that we can decipher what is happening inside the brain. That what is happening, the secondary brain injury, what is happening, whether there is a cerebral hypoxia, whether there is a cerebral hypoperfusion, whether the seizures are happening, or there is raised ICP. What is happening to the metabolism? So all these questions can be answered by the multimodal neuromonitoring. So initially, the monitoring in the past was something like that, the finger on the pulse, but now we have entered the age of multimodality monitoring. So just to show this, the current reactive model, how we do. Primary injury has happened, then there occurs the early stages of physiological derangement. And then over time, there occurs evolved stages of physiological derangements, which depict when the patient is already symptomatic, patient is already hemiplegic, patient is already deteriorated. So basically this window of opportunity is lost. This window of opportunity is lost, and this window of opportunity can be utilized with the help of multimodal neuromonitoring, where we can identify the early stages of the physiological derangements, early secondary damage, and can detect it and can try to treat it and mitigate it so that the patient does not go into the evolved stages of the physiological derangement and the patient can have better outcome. So let us see what all multimodal neuromonitoring we are having. The clinical neurological evaluation is the gold standard. We are not removing it. It has to be done. But yes, we can add to the clinical neurological evaluation. We can add cerebral flow. We can measure ICP, the intracranial pressure. We can measure the cerebral perfusion pressure. We can measure cerebral blood flow. We can monitor cerebral autoregulation, oxygenation, metabolism. So let us deal with them one by one. The clinical evaluation, the gold standard, measuring the GCS, measuring the 4 score in the ICU. Everyone knows, whosoever is dealing in the ICU. Measuring the lateralizing sign and seeing the pupils, their reactivity as well as their anisocoria, whether there is size is there. Now measuring the pupils at times becomes subjective by the nurse. Someone is writing sluggishly reacting, someone is writing not reacting. To make it more objective, we have infrared pupillometer. So that measures to the basically exactness of 0.1 mm. So that tells you the size of both the pupils and also the rate of reaction to the light. So it becomes an objective thing. Now coming to the cerebral flow directed techniques. We know we can measure ICP, intracranial pressure. The whole ICU and the neuro patient, they are basically dependent on the ICP and CPP. So we can measure ICP here, intracranial pressure. We can measure with the external ventricular catheters like the intraparenchymal ones. We can monitor with the intraventricular ones, which are the gold standard. So like you can see here, in this is in our ICU at AIMS, where we have seen the Codman catheter is being placed and the ICP 13 is seeing the patient. So we are comfortable. We at least can measure. Now, regarding the ICP monitoring, there came a landmark trial, the BEST strip trial, which said that the ICP monitoring was not shown to be superior to imaging and clinical examination alone. But this paper was followed by many editorials, many papers that they said that the move away from ICP monitoring would be detrimental because it is not only the number, you shall also look for the waveform. So ICP waveform as well as the number should be analyzed. That will tell you the compliance of the brain. Now the question comes, yes, they can be this is an invasive thing. Can we have something non-invasive? Yes, we can measure ICP non-invasively with the help of optic nerve sheath diameter, and it is considered a strong and accurate predictor of increased ICP. You can see we can have this high frequency probe, and we are taking all the due precautions, and we're just keeping lightly on the eye, and we get something, a picture like this. This is the globe with the retina and the optic nerve sheath diameter. So here at the 0.3 centimeter away from that, we measure the optic nerve sheath diameter. If the optic nerve sheath diameter is more than 5 centimeter, you are dealing with a patient of raised ICP. And with this, the ICP, the recent advances in the ICP is now the ICP cutoff for treatment is 22. Concept of overall burden has come in. That is how much duration the ICP was high and for how long. And optimal positioning is given very much heed, where it is the ICP and the mean arterial pressure, the arterial can, they should be kept at the same level, and thrust on the waveform analysis. So not only the number, should be the wave should be the. In the Brain Trauma Foundation guidelines also, it has been given that it should be measured because it reduces the in-hospital and post-injury 2-week mortality. So ICP should be done. Now regarding this accurate location, I was saying the location of the arterial blood pressure and the ICP should be the same, the level of tragus and foramen Monro. If you are keeping it at the level of the heart, then your CPP can be somewhere less than 11 mmHg, which is going to be very significant and very detrimental to your patient. Now, we can measure cerebral autoregulation also, and then the cerebral autoregulation like PRX, the pressure reactivity index, when we plot it with the CPP, we can find out the optimal CPP for a patient in that particular scenario. This optimal CPP is the CPP where the autoregulation is best preserved. And our target would be to keep the CPP in the range of plus or minus 5 within this range of CPP optimal. So you can see CPP optimal is directly associated with the outcome. If you are keeping your CPP within plus minus 5, then there is a good neurological outcome. And if you are keeping it lower or down, there is chances of higher mortality and severe disability at 6 months. So measuring ICP and CPP is required in a NIDO ICU. On to the next monitoring, the cerebral blood flow can be monitored. We can monitor it with the help of TCD and Doppler flow, which gives you an indirect flow of cerebral blood flow by measuring the cerebral blood flow velocity. We can have CT and MR perfusion, which give you a qualitative. PET and SPECT can measure the quantitative blood flow, but these all give you snapshots. What we require, we need for the continuous cerebral blood flow monitoring is there. This can be monitored with the help of thermal diffusion method. So here there are two thermistors, and the rate of heat transfer is converted into ml per 100 gram per minute. That is the cerebral blood flow. So we can measure the cerebral blood flow in real time and can know whether the patient is going in the hypoperfusion or not. Coming on to the most promising one, the cerebral oxygenation. We can measure the invasive jugular venous oxygen saturation. We can measure brain tissue oxygen tension and near infrared spectroscopy, which is non-invasive. Let us deal with them one by one. Jugular venous oxygen saturation, here you are retrogradely cannulating the IJV. The internal jugular vein, we are retrogradely cannulating and we are reaching at the level of C2 and below the C1. So we reach the jugular bulb. And this jugular venous oxygen saturation either by aspirating or by the regular this fiber optic catheter that gives you the value that measures the balance between the demand and supply. If the demand is more, like the patient is seizing, patient is having fever, patient is having raised ICP, all these things will make the jugular venous oxygen saturation low. And if the supply is less, like patient is having vasospasm, so then the patient may have this jugular venous oxygen saturation less. So we can decipher what is happening to our patient in that particular time and accordingly treat that patient. There are various situations where this jugular venous oxygen saturation can be low. And jugular venous oxygen saturation should not go below 50%. Multiple or sustained more than 10 minutes of desaturation is associated with poorer outcome. And this is also included in the Brain Trauma Foundation guidelines. Coming on to the promising one, the brain tissue oxygen monitoring. This catheter is put in the penumbra zone, the at-risk zone. And Brain Trauma Foundation suggests that PVTO2 should be maintained at about 20 mmHg. There are various studies, and this is the most upcoming. The randomized control trial has been done, and it says when the PVTO2, when added to ICP, showed a trend towards improved outcome with less mortality and more favorable outcome. So it is not only the ICP and CPP, you should also combine PVTO2, because in the raised ICP, what is happening to the PVTO2, that will guide the treatment. So it is multimodal. You have to see your patient when you examine all the things together. This is the near infrared spectroscopy, which takes into consideration this is non-invasive thing and takes into consideration the near infrared light absorption. And there are many things related to it. This is very promising because it is non-invasive. You can estimate the cerebral autoregulation continuously, non-invasively. That is the beauty of it. Ultrasound tagged NIRS has come, where we can measure the oxygenation as well as cerebral blood flow. And there are some NIRS-based handheld devices have come to screen intracranial hematoma in the pre-hospital environment. Now, reflecting cerebral metabolism. You can measure with the help of microdialysis. You can know what is happening to the metabolism of the brain, whether it is aerobic, whether it is anaerobic, what is the status of the glucose, what is the status of the lactate or pyruvate. This is done with the help of this. Basically, there is a dialysate membrane is there, and the fluid is basically by the osmosis you can collect in these vials. This is in our ICU. You can see this is the dialysis machine. These microvials which are collected from the patient are kept here, and you can measure glucose, you can measure lactate, lactate-pyruvate ratio, you can measure glycerol, glutamate, and chalybeate. And this comes as a graph also. So does microdialysis have a role in the clinical decision making? Currently, no. But when you combine with them with the other monitoring, then yes, it has. The recent advances are the concept of hyperglycemia and neuroglycemia. With the microdialysis, you can know, in spite of having a normal systemic glucose, your brain glucose can be low, which is going to be very significant in these patients. That can be identified with the help of microdialysis. We can differentiate whether it is ischemic etiology or non-ischemic etiology of the basically mechanism is going on. So it has a use. Now the patient's cerebral global function, the non-convulsive status epilepticus, non-convulsive seizure. Patients are having electrographic seizures, they are non-clinically. It is non-convulsive status or non-convulsive seizures, which is common in the neuro ICU in the acute brain injury patient to the tune of 20 to 50%. So we need to have EEG. Continuous EEG is the need of the hour in these patients if we want to improve the outcome. This was when I went to the Florida. So this is an 8-channel EEG which is being used, and it even produces sound in relation to the electrographic seizures. The recent advances are continuous EEG at least for 48 hours for ruling out non-convulsive status epilepticus. We can measure quantitative EEG because there are technical things are limited in this. Even it can be read by the nursing staff. And invasive EEG is more specific as compared to the scalp EEG. Now there are so many monitoring, so many data, and there is a lot of data, volume of data. So how to assimilate it, how to acquire it, and then how to interpret. So for that also the kiosk type critical care acquisition system have come in, which analyze everything, which keep the, like here you can see the physiological thing. Here the ICP is rising. At the same time, CPP is going down. And you can see the PbTO2 is going down and the lactate to pyruvate ratio is rising. So you can see the patient is going in the secondary damage. The physiological things are happening. So we need to act upon here. Here you can see the data, how it is assimilated. This is the number of the patients in the ICU. You can choose one. You can see his biochemistry. You can see his radiology. You can see his vitals parameters, ECG and everything. And then you can see all the multimodality monitoring, the neuro monitoring. And then with the help of assimilating data from everything, you can decide what is required for that patient, whether that patient should be given hemoglobin, whether the patient should be given blood, whether it should be given oxygen, or whether the blood pressure should be increased. So what is the need? So multimodality monitoring it's approved by many FDAs, and it has come in the consensus summary statement of a Neurocritical Care Society as well as from the European Society of Intensive Care Medicine. And as far as the complications are there, they are very less. So what is the future of this? Still, there are only observational studies are there. There are not much of the prospective randomized control trial. So we have to move beyond the observational studies and conduct good prospective randomized control trial to prove or disprove whether it is useful or not. I will just play this video, which is from Dr. Martin Smith. He has a very beautiful article in anesthesiology.
Traumatic brain injury is a leading cause of death and disability. Beyond the severity of the initial injury, secondary injury due to molecular or inflammatory responses and worsening cerebral ischemia strongly influences patient outcome. Minimizing secondary injury requires effective neuromonitoring to guide the timing and type of therapeutic intervention provided. Numerous variables can be monitored, however, and those that should influence treatment decisions aren't clear. Now, an extensive literature review has examined the strengths, weaknesses, and treatment thresholds for various neuromonitoring methods, providing information that might improve patients' neurologic outcomes after traumatic brain injury. Management of traumatic brain injury requires assessment of several variables associated with secondary injury. These include intracranial and cerebral perfusion pressures, brain oxygen levels, and cerebral metabolism. Alone, none of these elements comprehensively portrays the spectrum of pathophysiological changes occurring after traumatic brain injury, but tracking them together through so-called multimodal monitoring gives a fuller picture of the injured brain. Monitoring of intracranial pressure and cerebral perfusion pressure is a routine component of traumatic brain injury management in many centers. Keeping a patient's cerebral perfusion pressure within an optimal range, rather than using a generic threshold, is central to avoiding the risks associated with values that are too high or too low. One way to obtain an individual's target cerebral perfusion pressure range is by monitoring cerebral autoregulation. Although intracranial pressure and cerebral perfusion pressure values are widely used to help manage traumatic brain injury, neither variable describes the adequacy of cerebral perfusion, an important factor when managing an injured brain. Indeed, cerebral ischemia frequently occurs even when intracranial pressure and cerebral perfusion pressure are within normal limits. But monitoring cerebral oxygenation along with pressure informs on the balance between oxygen delivery to and utilization by the brain, which can produce superior outcomes. Energy dysfunction is another key factor in traumatic brain injury pathophysiology that is not identified by routine neuromonitoring. Cerebral microdialysis can assess markers of cellular processes associated with glucose metabolism, oxygen supply, and cellular energy failure. Although high-quality evidence confirming that neuromonitor-guided interventions improve patient outcomes is needed, focusing on the interactions between different neuromonitoring variables could enhance personalized treatment. Understanding how to interpret combinations of different monitoring strategies is a promising step in this direction.
Hello, I'm very sorry.
Yeah, I think it's complete.
Hello,
This is
Dr. Goel, I'm very sorry to interrupt you. We're in very short
I've already
time.
completed. I've already completed. So this is my department, and I thank you for the
Yes,
patient
thank
here.
you very much.
Thank you.
Yes, your presentation was very informative and give us the more new idea about the new monitoring. So now I request to start the next lecturer. The topic is the basic of neuroradiology in neuro-intensive care. Dr. Zulfikar Ali from India. Dr. Zulfikar, can you hear me?
Yeah, good evening, everybody. Yeah.
Yes, thanks. Dr. Zulfikar Ali.
Yeah, sure. Just 1 minute.
Yes.
Good evening, everybody. I first of all thank the organizers, the Bangladesh Society of Anesthesiologists, for giving me a chance to be a part of this excellent academic event. I'll be briefly speaking today about the basics of neuroradiology in the neurointensive care. These are some of the main objectives that I will try to cover in my lecture. We'll try to understand clearly the basics of computerized tomography in terms of attenuation, density, and Hounsfield units. A basic understanding of the supratentorial and the infratentorial cuts of the brain scan. identification of various important structures as the right and left cerebral and cerebellar hemispheres, gray-white matter differentiation, what are the physiological abnormalities in the CSF circulation pathway along the pathological anomalies that we get in the intensive care unit, how to identify the various types of bleeds, and more important, the basics of mass effect and the herniation patterns that we see in the intensive care unit. Well, if we see the computerized tomography scan, it's a little bit more complex than a normal chest radiograph. In chest radiograph, usually we have X-rays which travel in a particular direction, while in a computerized tomography scan, they travel in all directions. If we see from this chest X-ray, these are the areas which are black in color, and they are usually formed by the structures that are hypodense. While as the hyperdense structures, the structures which are more density, they appear white, as we have the clavicle on this X-ray or the vertebral column with the blood in the heart. There is something that we need to know about a computerized tomography scan in terms of Hounsfield units. Conventionally, the Hounsfield units, it measures the density of the structures in the brain. And if we see the water, it has been given conventionally a unit of 0, with air a unit of -1000, and dense structures as bone and metal, a unit of +1000. Soft tissues, they have an increased value of around 50. Fat, normally we presume that it may have a value more than water, but we need to understand that fat, it's hypodense, because if we place oil on water, oil usually always floats because oil is lighter than water. So fat will be always hypodense when compared to water. And CSF, it has a consistency similar to water. So Hounsfield unit is around 15. It's not the values that are important. It's the concept that we need to know while understanding and interpreting the computerized tomography images of the brain. If we see the white matter is mainly made up of myelinated fibers, which contain predominance of fat. So they are hypodense than the gray matter. And if we see the clotted blood, its density is more, so it's hyperdense in nature. If we apply this to a scan of a brain, we need to understand that Hounsfield units between -1000 to 0, they will appear black. Over 80, they will appear white, while 0 to 80, they will appear gray. So if we see from this structure, this is the air with a hypodense appearance. This is the CSF, again black with a hypodense appearance. If we see, this is a blackish material here, and this is the white material. And we need to remember that the white material, that it always is seen, this is the gray matter, white is the gray matter, and black is the white matter. If we see a typical CT scan, they are usually conventionally what we did, we formed a line, orbitomeatal line, from the orbit to the external acoustic meatus, and then progressive cuts were taken at 5 to 10 millimeters. This is how we do a routine head scan. And then if we see the various cuts, the supratentorial cuts, they are usually seen at the level of the lateral ventricle and the third ventricle, while as the infratentorial cuts, they are above the foramen magnum, and they are usually show the fourth ventricle. We have to have an understanding of this image. This may be helpful for us in understanding the computerized tomography scans of the brain. So here we see, this is the this is the lateral ventricle, this is the lateral ventricle, this is the third ventricle, and here we see the fourth ventricle. This is the cerebellum, this is the pons, medulla, sella turcica, and these are the cerebral hemispheres. So if we see in an axial image, these structures, these are the lateral ventricles, this is the frontal lobe, and here we see this is the internal capsule, this is the external capsule. We'll try to have a clear understanding of these structures in the forthcoming slides. So if we see a typical CT scan with context to the image we saw, we need to understand that A and B, these are the supratentorial cuts. Now, this is the lateral ventricle, the frontal horns. This is the third ventricle. These are the lateral ventricles, the posterior horns. So these two, we see the lateral ventricle, we see the third ventricle, these are the supratentorial cuts. And if we see these two images, C and D, this is the fourth ventricle, inverted comma-like appearance. This is the pons, this is the prepontine cistern. So this is an infratentorial cut. And again, here we see this is the medulla oblongata and we see the CSF around it. So again, it's an infratentorial cut. These are the bony cuts. If we see the bony cuts, we see this is the anterior cranial fossa, the middle cranial fossa, the posterior cranial fossa, and this is the external acoustic meatus. Now, the second thing that we need to understand is how to differentiate the various lobes on a brain CT. So we need to identify the Sylvian fissure. This is the Sylvian fissure on the right side. This is the Sylvian fissure on the left side. So the Sylvian fissure, it will always differentiate the frontal lobe from the temporal lobe. And then we need to identify the central sulcus. This is the central sulcus. We'll see how to identify the central sulcus in the forthcoming slides in detail. So this is the central sulcus, and we need to remember, once we identify the central sulcus, it differentiates the frontal from the parietal lobes. So how do we identify the central sulcus? There are three things that we need to keep in mind. The first is the reverse omega sign. This is the normal omega sign. This is the reverse omega sign. So if we see keenly, this is the reverse omega sign. This is a particular feature of central sulcus. The second thing is central sulcus is the longest sulcus that we see. The longest sulcus that we see, this is the central sulcus. This is the central sulcus on right side. This is the central sulcus on left side. And the third thing, the central sulcus, if we see the central sulcus on two sides, they form what we call the mustache sign. This, if we clearly observe these two central sulcus, they form a mustache-like structure. If we go into the infratentorial compartment, this is the midbrain. Again, I will see in the future slides how to identify the midbrain. These are the basal cisterns, and this is the pons, as I told you, inverted comma appearance. This is the fourth ventricle and the prepontine cisterns. So this is the medulla, and this is the CSF around the medulla. We need to identify if there's no CSF, I'll show in the future slides. This may be, if there's no CSF present, this may be an indication of tonsillar herniation, which is very important to detect in a neurocritical care setting. So how do we identify the midbrain? We need to have an idea about the Mickey Mouse appearance. This is the head of the Mickey Mouse, the midbrain. And these are the two cerebral peduncles. This is the right-sided cerebral peduncle. This is the left-sided cerebral peduncle. And the pons, a rough approximation, is a Daphnet head appearance. So this is the pons, this is the cap of the Daphnet, and this is the fourth ventricle. This is the prepontine cistern. Now, we need to have an idea about the CSF pathways. If we see the CSF pathway, all of us know that the CSF is formed in the lateral ventricles, and from lateral ventricle, it goes into the third ventricle. So how do we identify the third ventricle? Third ventricle is always a set-like structure. And from the third ventricle, if we see, the CSF will go through the foramen of Monro from the lateral ventricles through foramen of Monro. This is the foramen of Monro in the third ventricle, and from third ventricle through aqueduct of Sylvius into the fourth ventricle. Then we need to see the other CSF spaces, very important, particularly in patients with head injuries. So we have to have an idea about the various cisterns. First of all, we see the suprasellar cistern. How we will identify, I'll just clarify in the future coming slides. after that, we have the interpeduncular cistern, ambient cistern, quadrigeminal plate cisterns. So how do we identify them? First of all, I showed you this is the prepontine cistern. If we see, we want to identify the suprasellar cistern. First of all, we identify the sella turcica. Bone, it will be white. So this is the sella turcica. Once we identify the sella turcica, we go one cut up. And in one cut up, we see a star in the sky. This is a star-like appearance. So this is the suprasellar cistern, one cut up above the sella turcica. And then below the suprasellar cistern, in the interpeduncular fossa, we have the interpeduncular cistern. And this is here we see the ambient cistern, the right ambient cistern, the left ambient cistern. This is the quadrigeminal plate cistern. This is the quadrigeminal plate cistern, seen more clearly in this cut. Now, we need to have an idea about these CSF spaces with various pathologies. So normally, we see that this is the cisterns, this is the lateral ventricle, this is the lateral ventricle. But if we have brain atrophy, what happens? The lateral ventricles, they are dilated, and at the same time, the subarachnoid spaces, they are also dilated. But if we have hydrocephalus, what happens? The ventricles are dilated, but the subarachnoid spaces, they are not dilated, they are not seen, they are effaced. And if we have a lot of brain edema, diffuse brain edema, particularly in head injury, we can see that both ventricles are chinked as well as subarachnoid spaces are chinked. The second thing that we need to understand is the bleeding. What are the basic concepts of various bleeds? We saw at the initial point of our presentation that water has a Hounsfield unit of 0, followed by CSF, followed by white matter because of predominance of myelinated fat-laden fibers, followed by gray matter. And then we have the hyperdense structure, which is seen in the form of bleeds. So if we see an extradural hematoma, we have a lenticular opacity, which is hyperdense in appearance, which has a biconvexity shape. Now, if we see a subdural hematoma, how does it differ? The difference is we have a crescentric shape. That's one. We have a concave inner border and a convex outer border. And then there's something more important we need to know. We need to always remember that the color of the bleed, it will change with the age. If we have an acute blood, it will be white, hyperdense. As time passes, that is around 1 to 3 weeks, it will be isodense. I will show in the few coming slides. And as time passes, beyond 3 weeks, it becomes black. That's hypodense. That's the chronic STH. So this is the subacute blood, has a similar appearance to the brain parenchyma, and this is the chronic STH. This is a hypodense appearance, blackish appearance, when once compared with the brain parenchyma. Again, we need to understand something more important. That's the hyperacute blood. That's patient is having an ensuing blood loss. So how will it look in the CT scan? This is what we call the swirl sign. If we see there's a white appearance, this is an EDH, but we see black spot. This is an ongoing blood loss, which appears hypodense, and this is the swirl sign, which is very important. There's an active arterial bleeding going at the point when we take the scan. And we saw this, in this scan, there's something very interesting. This is an acute on chronic STH. This is the chronic STH, black in color. And there is another bleed that has occurred recently, which is hyperdense in color. This is an acute on chronic STH. We need to remember something very important. Not everything white that we see on a scan is blood. There are 4 structures we need to remember. They are always white on a brain scan. So what are those 4 structures? The first is the choroid plexus in the lateral ventricles. The second is the pineal gland. The third is the globus pallidus. And the fourth is the dentate nucleus. So these 4 things will be seen as hyperdense structures. And then if we are dealing in an intensive care unit, we need to follow something on a day-to-day basis on our neurocritical care rounds. That's the Marshall grading, where we need to have an idea about the volume of the blood, have a look on the basilar cisterns, whether they are obliterated or open. We need to measure the midline shift. We'll see in the coming slides. And based on these four things, we graduate the prognosis of the patient who is admitted with us. These are some of the bone cuts. Here we see a parietal bone fracture, and here we see a frontal bone fracture in a patient who was admitted with us. Then we have to have an understanding about the various types of infarcts. This is the patient with middle cerebral artery infarct. As we know that middle cerebral artery, it supplies about 80% of the blood to the brain. So we have a wide infarct. Now, if we see, we have reduced the window on this scan. This is the brain window, the upper three sections, and here we have the stroke window. And on stroke window, we see the loss of gray-white matter, the loss of insular ribbon, and the obliteration of the basal ganglia. So this is a typical appearance of a middle cerebral artery infarct. And here in the ACA infarct, it again has a typical appearance that we have, this is the large ACA infarct on the right side and small ACA infarct on the left side. These two ACA infarcts, they touch the frontal lobes on the interhemispheric portion of the scan. And if we see this is a typical appearance of a posterior cerebral artery infarct, which usually occupies the posterior regions of the brain. We have to understand in our neurocritical care setting how we have to detect mass effect. There are various forms. We'll discuss briefly. The first and subtle is the sulcal effacement. We need to detect the patient at this stage. If there is loss of sulcal effacement, if we do not treat appropriately, it may increase with a midline shift. So how do we measure this midline shift? We draw two lines. One line joins the anterior interhemispheric fissure with the posterior interhemispheric fissure. This is the line A. And we see the distance from this point, the septum pellucidum, with this line. And if it is greater than 5 millimeters, there's a significant midline shift. And then we need to understand the various herniation patterns. So how do we detect? The first is the subfalcine herniation. There is movement of the falx under the anterior hemispheric fissure to the other side with a midline shift. We see in this patient, the subfalcine herniation. Then bilateral uncal herniation. We commonly miss this in our intensive care setting. So why do we miss it?
Excuse me, Dr. Zulfikar, we are in very shortage in time.
Yeah, it will just take me 2-3 minutes. I'm just closing.
Yes, thanks.
So in the uncal herniation, we see loss of sella turcica. If we see, this is the suprasellar cistern, this is the sella turcica. So we do not see the sella turcica, so we can miss it because there's no positive finding, there's the negative finding. And here we see the tonsillar herniation. This is the normal medulla with CSF spaces. And here we see no CSF spaces signifying the tonsillar herniation. Thank you very much.
Thank you very much. A nice presentation from Dr. Zulfikar Ali from India. His presentation was very palatable and it was very informative for the new learner and also us. Our next presenter is Dr. Satyen Parida from India. His topic is focused transthoracic echocardiography in the critical ill. Where do we stand?
Okay, thank you very much. Can everyone hear me?
Yes.
Thank
Dr.
you.
Satyen.
Yes, this is Dr. Satyen.
Yes, thanks.
Okay, so thank you very much for having me here talking to you guys, and hello everyone from Chipma, Pondicherry. Special thanks to Dr. Kauser because without him, this presentation really would not have happened, honestly. So I'll be talking about the progress that we have made with respect to focused transthoracic echocardiography in the management of patients in the ICU. in terms of how we actually got to where we are today doing echocardiography over the years. So this is how my presentation will be structured. So I'll be going through the evolution of practice of transthoracic echocardiography in the ICU, and we'll be talking about a curve that actually catapulted focused echocardiography to becoming one of the most sought after hemodynamic modalities for critically ill patients. We'll be discussing a little bit about the evidence base that went into this shift in practice, basically looking at the frailties of routine hemodynamic monitoring and what drove practice towards echocardiography. We'll be looking a little bit about training, because training is an issue, still an issue. And in this regard, I'll be sharing our experience in training our intensive care residents with in the modality of echocardiography in the ICU. And finally, hopefully, I'll be able to leave you with 1 or 2 messages to take home. So to begin with, the evolution of practice. Now, the initial challenges to conducting echocardiography in ICUs has always been the fact that if echocardiography had to be conducted, the cardiologist had to come and do it. And that often was not possible. So there was no 24/7 echocardiography cover basically for ICUs. The second issue was that of training, major issue actually, because if people had to use echocardiography consistently in the ICU, then they had to invest some time, energy, and resources in training in this modality, just as you had to for any other modality. And that often was not forthcoming, and that's a running issue until now. Finally, in the 1980s, there were groups of anesthesiologists who actually decided that the time was right to develop training programs and accreditation programs in basic transthoracic echocardiography, so that this could become a part of a global and comprehensive evaluation of hemodynamically unstable patients in the ICU. And then evidence began to pile up slowly, especially in the context of the fact that the values that were being obtained from the pulmonary catheters were no longer making much sense to the intensivist. And by 1996, the American Society of Anesthesiologists and the Society of Cardiovascular Anesthesiologists came to believe that there was enough evidence to bring out recommendations in this regard. And the recommendations that they brought out were divided into 3 categories. Category 1, where echo is frequently useful in improving outcomes. Category 2, where it might be useful. And category 3, where it was infrequently useful. And if you look at the recommendations in category 1 at that point of time, this is how it stood. They said that echo should be used in the evaluation of persistent and life-threatening hemodynamic instability in the intensive care unit patient, where the ventricular function and its determinants were unknown, and the patient had basically not responded to the initial resuscitation efforts. So they were very specific with regard to this indication. And then, of course, there were the regular indications, the HOs, the hypertrophic obstructive cardiomyopathies, the aortic injury, tamponades, etc., which were already there at that point of time. And in category 2, the most striking indication was the perioperative use in patients with increased risk of hemodynamic disturbance and multiple trauma or chest trauma patients. So there was a level 2 recommendation for use of echo under these circumstances at that point of time. And category 3 had some indications like intraoperative evidence of emboli during orthopedic surgery. And then as echo began to be used more and more in the ICU, there accumulated incremental evidence as to its utility as a hemodynamic monitoring tool in the ICU. But I think the watershed moment in the utilization of echo in the ICU was with regard to, was when people actually started looking at functional hemodynamics. So people started looking at the SVC diameter, at the change in the SVC diameter. They started looking at the IVC diameter, the collapsibility of the IVC, transesophageal echocardiography came up, and people started basically using echo to look at, to assess volume status in patients. And that, I think, was the pivotal moment which strongly established echocardiography as a hemodynamic monitor to stay in the intensive care unit. 2003, basically the same set of people, but from different other organizations, including the American College of Cardiology, the American Heart Association, the American Society of Echocardiography, etc., brought out a revision of the guidelines that they had proposed in 1996. And here, if you look at the category 1 guidelines, the first one said the hemodynamically unstable patient, full stop. So if you remember from the 1996 guidelines, they used to say that echo was to be used only when the ventricular function and its determinants were uncertain, and if the patient had not responded to the initial resuscitative effort. So by now, there was evidence to suggest that echo was to be used in every hemodynamically unstable patient. And that was quite significant. In category 3, again, they were comparing the pulmonary artery catheter with echocardiography, and they found out that in multiple trauma or chest trauma patients with pulmonary artery catheter already in place, there were some data which were disparate with the clinical situations. Basically, what they were saying is that they were no longer trusting the numbers that they were getting from the pulmonary artery catheter. And in these situations, echocardiography was very useful in directing the therapy therefrom. So, and then there were some category 3 indications as well. And by 2014, other indications had come up. These included hypertrophic obstructive cardiomyopathy. We'll come to the 2014 guidelines in a bit. Then pulmonary embolism, cardiac arrest. And cardiac arrest was very significant because this prompted the acute life support guidelines to use cardiac ultrasound, to consider cardiac ultrasound in the diagnosis of the cause of cardiac arrest in the peri-resuscitation scenario. They were very specific in how they wanted to use it, how much time had to be expended doing this, who was supposed to do it. It was only to be done by the experts, not by everyone. But the very fact that cardiac ultrasound came into the 2015 ACLS guidelines was extremely noteworthy. And then by 2014, the European Heart Journal had published these guidelines, basically encompassing the entire set of evidence that had accumulated by that time regarding the use of echocardiography in any acute care scenario. And this was followed a couple of years by a similar statement from the intensive care societies also, which basically established echo firmly as the hemodynamic modality to be used in echocardiography in the intensive care units to assess and treat hemodynamically unstable patients. So the utilization of echocardiography exploded over the next 15 to 20 years, roughly. So this is a paper from Antoine Villard-Baron, who along with his colleagues, Michel Salama and Bernard Choli, was very instrumental in propagating the use of echocardiography in most of the European ICUs. So this is a paper which goes back to 2008 actually it got published, and it details the number of echocardiograms which they did in the unit between 2000 to 2006, and that was around 140. Now, Antoine Villard-Baron's unit at that time was a 40-bedded unit. My general intensive care unit today is a small 10-bedded unit, and we conduct about 100 to 150 echocardiograms every year, which basically tells you that the use of echocardiography in ICUs in current practice has become very, very significant. So coming now to the second objective, that of looking at the evidence base. Now, before I progress any further, I would like to divide this into hemodynamic indications and, indications for diagnosis, prognosis, and a few other things that we will be discussing. So coming to the hemodynamic indications, I'm sorry about that. So coming to the hemodynamic indications, now when you for the better part of their history, they I'm sorry about the noise. For the better part of history, can you hear me? All right.
Yes.
Can everyone hear me?
Yes, we hear you.
Okay, so for the better part of the history of critical care, intensivists have had to depend upon the pulmonary artery catheter as the gold standard of monitoring. And there came a time after that when you actually, intensivists started questioning the values that they were getting from the pulmonary artery catheter, and they started making comparisons between the pulmonary artery catheter and the and echocardiography, basically. And what they found is, even with the pulmonary artery catheter in place, echocardiography was able to change the line of management, was able to influence therapeutic decisions in a big way in at least more than 50% of cases. And all of that evidence is actually encompassed in this review article, which was published in the Intensive Care Medicine Journal, where the authors have remarked that whenever available, echo should be performed because it provides rapid and comprehensive hemodynamic evaluation, while the pulmonary artery catheter should be relegated to use only in the post-cardiac surgery setting. Now, if we are to use the echocardiography in lieu of the pulmonary artery catheter, we need some assurance that the values that we were actually getting from the Swan-Ganz could actually be replicated by the use of the echo. So this was one paper which dealt with at least one such parameter, that of the pulmonary artery systolic pressure as obtained from the Swan-Ganz against the RVSP, or the right ventricular systolic pressure obtained on echocardiography. And what the authors concluded was that if you actually put in an invasive central line and measured invasive CVP, then the RVSP, the right ventricular systolic pressure, which was obtained from the echo, correlated very well with the pulmonary artery systolic pressures which were obtained from the Swan-Ganz. Majority of the times, however, this is not how it's done in the echo lab, and that's why you get disparities. So you could argue that we don't need the pulmonary artery catheter. We have all this vast array of arterial pressure-based cardiac output monitors, which we could use, and you'd be correct, of course. A lot of these arterial pressure-based cardiac output monitors have shown a good correlation with the Swan-Ganz, but then there is no gainsaying the fact that they're still invasive, that they have to be recalibrated repeatedly, especially when hemodynamics change, specifically if the SVR changes, etc. They do not give any idea about the LV compliance of the patient, and they are virtually useless when you have an arrhythmia like atrial fibrillation, hence the echo. So coming to the other indications apart from hemodynamics, the vast majority of in the vast majority of cases, echocardiography has been used principally as a diagnostic tool in the ICU, and the major indication has often been to quiz the cause of unexplained shock. So you have this patient presenting with unexplained shock, and then you do an echocardiogram on him, and you find a collection all around the heart, with the heart swinging around in the pericardial cavity, the right atrial wall, basically demonstrating abnormal movement in systole, and the right ventricle collapsing during diastole. It doesn't take much to diagnose cardiac tamponade. So that's the kind of impact that echo has as a diagnostic tool. But apart from diagnosis, there have been various instances where echocardiography has actually been used for prognostication, especially in patients having septic cardiomyopathy. And in this regard, speckle tracking and global longitudinal strain have shown good correlation with mortality rates following septic cardiomyopathy. One could argue, however, that these are advanced modalities of echocardiographic imaging, but then there are some simpler parameters that one could use, like mitral annular plane systolic excursion, which shows good correlation with global longitudinal strain and could maybe used as an alternative, but whether that actually could replicate this kind of prognosis is something that only future research will tell us. Now, looking at the MIMIC-3 database, which is a free critical care database that is available for everyone to use, there were some interesting findings from this database in terms of the fact that transthoracic echo apparently had a significant effect on a significant beneficial effect on 28-day mortality, that it helped direct the fluids being administered to the patient during the resuscitation phase, that it helped to rationalize the use of inotropes and vasopressors in patients who were in shock, and that helped them to be weaned quickly from these supports. And then there was some evidence also that patients who went an early basic transthoracic echocardiography had actually early basic, meaning during the subclinical phase of their illness, they had lower incidences of acute kidney injury as compared to those who did not. Now, we talked about the diagnostic implication of echocardiography in the pericardiac arrest situation. It could also have some prognostic implications in that patients who have pulseless electrical activity are more prone to have a resuscitative effort being successful. That is, they can respond to ROSC much faster if they have some intrinsic cardiac contractility intact, as opposed to patients who do not have that intrinsic cardiac contractility while they are being resuscitated. In respiratory failure, echocardiography can be used to optimize ventilatory strategies, especially in situations like RV dysfunction. And whether this can be used to prognosticate the recovery from respiratory RV dysfunction or not, we are not sure. That needs to be studied in greater detail. But an emphatic use of the echocardiography in the ICU for me is the risk stratification and management in pulmonary embolism patients. So there are a whole lot of these patients who are far too sick to be actually taken to the CT suite to get a CTPA done. And there have been instances when we have actually thrombolized patients, we have revascularized patients based totally upon their echocardiography findings without having a CTPA done. The NICE guidelines, of course, would not agree with that, but when patients are that sick, desperate measures are called for. And finally, in the use of mechanical circulatory support, echocardiography could help in assessment of such mechanical cardiac support. This was a cardiogenic shock who presented and was put on veno-arterial ECMO. And if you look at his echo from the subcostal window, you can see the access cannula in place in the right atrium. The RV is well decompressed, but the LV function remains poor, and there are no complications of ECMO such as pericardial effusion or any LV clot therein. So that is how echo could help in patients who already have mechanical circulatory devices in place. So coming to the last part of my lecture about training. Basically, when you talk about basic transthoracic echocardiography, it gives the impression of a shoddy transthoracic echocardiography. That is not really how it is. In fact, the basic transthoracic echocardiography is a very meticulous examination, but within a very narrow framework of specific echo parameters to be quizzed, so as to be able to answer certain basic binomial questions, such as, is it an LV failure or is it an RV failure? Is there a pericardial effusion or is there not? And most of such work was popularized by Jensen and his colleagues in 2004, and they packaged this idea under the acronym of FATE, or Focused Assessed Transthoracic Echocardiography. Many of the other structured programs such as FIELS or FICE, which came up later, have their legacy in the work done by Jensen at this point of time. So in this regard, I would like to share my department's experience in actually conducting the echo program that we started off. So this was assessing the competence of intensivists in focused transthoracic echocardiography in the intensive care unit. Basically, the intensive care residents were asked to perform asked to undergo a training course in focused transthoracic echocardiography, which was designed in consultation with the cardiologist. And the entire protocol was a very specific and very narrow echo protocol, which was devised between the intensive care team and the cardiology team. And these were the results. This study was carried out over 1 year, and 82 ICU patients and 104 echocardiograms were performed. The training program itself consisted of 60 hours of treatment, which was basically divided between posting in the echo lab as well as training on some educational videos. And at the end of this training program, the intensive care residents were actually assessed for their competence in comparison to 2 blinded cardiologists, all of it within this narrow echo protocol that had been created. And these were the results. What we found was that within that narrow echo protocol, that very stringent echo protocol that had been created, intensive care residents were. I'm almost finished. This is the last slide. So as I was saying, our intensive care residents were able to replicate the results that were being obtained by the cardiologists within that extremely stringent and tight protocol of echocardiographic views and measurements that they had been asked to perform. So the whole idea is intensive care echocardiography is extremely valid, especially when it is properly protocolized. So I will end my lecture with these thoughts that echo helps us to look at the big picture. We're not looking only at the volume status or not looking only at the pressures as we normally do in conventional hemodynamic monitoring. we're looking at overall myocardial performance, and that could have a significant impact on patient outcomes in critically ill patients. I thank all of you very much for listening to me. This is a Sunday evening, and I'm really humbled by the fact that you have listened to me with so much attention. Thank you very much.
Thank you very much, Dr. Shotten Parida, to give us a lot of idea about the echocardiogram. And
thank you, sir.
Yes, our next speaker is Dr. Mr. Jean Nurain Jaigidar from Ireland. His topic is the ICU management of liver transplant recipients.
Just 1 second, sir. I'll stop sharing.
Yes.
Yeah, done.
Dr. Jaigidar.
Yes, please. Can you hear me?
Yes.
Okay. Can I go ahead?
Yes. You can.
My presentation is, you can see my presentation, is it?
Yes.
Okay, great. Good afternoon, everybody. I welcome you to this presentation. My presentation is, the critical care of the liver.
Habib, we can't see his presentation.
Okay.
Yeah.
We can please share it.
Yes.
You see now?
Yet not.
No, just a minute.
Share the screen first.
Yeah, just a minute.
Share it in the bottom of your screen. See. At the bottom, share screen, green one. Yeah. Great.
Yes. Now we can.
Is there now?
Yes.
Yes.
Now.
Thank you. Okay, so my discussion is on critical care of the liver transplant recipient. So I have big questions in my mind because the recipient has come to the intensive care unit for the management of liver transplant. We have so many things to do, and within 20 minutes time, how many questions I can answer, it's a very difficult task. So I'll show you the questions in the first. First, you can see a liver. So a donor is providing a liver. We have to see the quality of donor and the type of the donor, and the quality of the recipient and the quality of the recipient's life as well. So, and the type of surgery and the time of surgery and the extent of surgery. So this is liver itself, from the donor and the recipient, it becomes a vital question. Next question is the recipient. Usually we do the liver transplant. The commonest one we can see either end-stage liver disease, number one, and number two is you can see acute pulmonary liver failure, and some of the cases are hepatocellular carcinoma. There are other cases too, but commonest one of this. So end-stage liver disease, and the recipient, we do a scoring system that called is MELD, which is Model of End-Stage Liver Disease, and which prognosticate the ultimate result of the recipient in the unit, in the critical care unit. So MELD scoring is very important for us. So we should know the MELD scoring. Next one, I think you all know about this. This is child scoring system. The child scoring system also helps us to prognosticate the recipient's prognosis in the intensive care. So we should know this thing as well. And next is the commonly we encounter with the ventilation, whether the patient comes to the intensive care unit extubated or comes intubated, and then if comes intubated, how we do the ventilation and how long we do the ventilation, when to extubate, and how we're going to prognosticate with that. So that's very important. The next one is very vital in the case of liver transplant, because there are a lot of fluid displacement, blood loss during liver transplant surgery, and the patient comes to the unit, and we should know the status of fluid balance as well as the volume status of the patient. And the next one is acid-base balance. So as we know, liver disease patients can have some acid-base balance and a same imbalance, and there is massive surgery with tissue destruction with acid-base imbalance, and then the patients coming in with maybe oxygenation problem and the ventilation issues are there. So these questions are there. The next question is, this is a paper which I'm presenting showing you is the primary liver graft dysfunction and non-functioning. So the graft itself can start, it can function quickly, it can non-function. So we should be able to know the graft is functioning or not. Now you can see here, you can see primary non-function. The liver can non-function primarily, or it can have graft dysfunction. And both of these could be due to ischemic reperfusion injury. So we know that after reperfusion, there can be an injury, and that can lead to primary and liver graft dysfunction. So we should know about this, that when the liver is functioning or not. And then you can see the non-functional ischemic reperfusion injury can depend upon the graft itself. And with the graft, you can see there can be macrosteatosis, metabolic profile, cold ischemia time. Then comes the flushing of the reperfusion technique. So this is graft function and also with the donor quality. And then you do some logistics, and then you can see the recipients. The recipients with the age, creatinine, previous abdominal surgery, MELD scoring, we're using propofol or not, and then African American race. So all those factors will come into play. And next question comes with the, we're using allograft and the patient's immunological status, and we know there'll be immunological reaction. So we should take care of that as well. And the next come with liver disease, we have significant cardiovascular impairment with cardiomyopathy, vascular dilatation, and so many problems will be there. So these questions in mind. And then, as we have told, there is gross fluid electrolyte imbalance. Patients can have hyponatremia, hyperkalemia from blood transfusion, hypocalcemia, hypoventilation, all these things. So electrolyte imbalance could be there. And then we know that with liver transplant diseases, there can be hepatorenal syndrome, there are nephrotoxic drugs, the respiratory system, there could be hepatic hydrothorax, acute lung injury, aspiration risk, encephalopathy, cardiovascular problems, metabolic problems, massive transfusion, and then the question of rejection. And we need postoperative analgesia, we need good parenteral nutrition or enteral nutrition, and we need risk of infection, so we have to control the infection. And as we know, we can have portopulmonary hypertension or hepatobiliary syndrome. So all these questions, so many questions in mind. And then last questions come with my audience present today, because the thing is, so far I know in Bangladesh, you can see this paper, which was published in I think it was 2014, and it seems at that time in ICD-DRB, the true liver transplant was done, and this was published in the journal. And later on, I found another information from the recent in 2019 in a newspaper. It came in Bangladesh, Bangabandhu Sheikh Mujib Medical University, one liver transplant was done. And that news shows that in Bangladesh, up to that time, that was the 5th liver transplant done. All were from a live donor transplant. And the last 4 had, out of them, only 50% survived. And that was not a good news for us, because we did in Bangladesh, only till now, we have done 5 transplants. And the audience who are with me today, all of them, we expect to be anesthesiologists. And maybe none of them are involved in the past and may not be involved in the future, but we should make a milestone. We should make a brighter future. So with those, I will try, because all these questions, we are confused. And I want to show you that bird's eye view of the short management intensive care unit. This is a picture which has been taken from where I live in Ireland for the last 17 years. And you can see this picture is the cliffs of Moher. It's a 700 feet height cliff over the Atlantic Ocean. So we can static, a stunning view. Millions of people come from outside to see this view of Ireland. And we can see, I am standing on the ocean, on the Atlantic Ocean, and talking about recipient management in the liver transplant. So I will just go for a bird's eye view, and a few things I'll discuss in a short. So this is a picture of our intensive care unit where we work, and the patient goes to some. The first question, as I told you, the quality and type of liver transplant. So there are two types of liver transplant. We can get liver from the living donors, as you can see here, living donors, and can be from cadaveric donation. And from the cadaveric donation, we had dead brain death patients, or death from cardiac donation, cardiac standstill. So we can have brain dead donation and from cardiac death, and we can have from living donors. And you can see here, when you take cadaveric donation from brain death, which is the commonest one done, and as you know, they started liver transplant in around 1963, where Dr. Stars, he started and then had bad experience, and later on a lot of improvement from surgical techniques and donor liver quality and the recipient's quality, and improvement in the intensive care management has made significant progress, and now the prognosis has significantly improved. And you can see here, if you do donation from brain death or from this cardiac death, you can have whole graft or can be split graft. The liver can be split into two, and one can be usually used with the child or part of the, and as you know, liver can grow up. The second one is a living donation. As you know, in Bangladesh, the 5 transplant was done, this one, and then that was also can have segment graft, left lobe graft, right lobe graft, and whole liver graft. So as we have discussed about the quality of these livers, it depends. So we have to know about the liver donor quality. Now we can see a study which was done in Donor Risk Index and the Decade Experience, which is a review article in 2017, where you can see they have found out 7 factors which can give us indication of the risk of the donor liver. And you can see where the 7 factors are age. As the age grows up, and you can see the hazard ratio is there, goes up, and the race and the height, cause of death is severe or other death of causes, and donation after cardiac death, and partial or split liver. So these factors increase the risk. So they have studied and found out this is validated with the study, and you can see there's a critical calculation is there, and they found that donor liver is risky or not. So we can know that donor liver has significant risk, or the recipient liver with the MERD scoring system and the child scoring system, and we can see the risk of both of them. So what is our practice? The place where I work, you can see there are mainly there are 3-4 surgical techniques, which is initially they started with conventional surgical technique, and nowadays we're doing the piggyback technique. And sometimes it may need venous bypass as well. This is usually we do, the donor is from the brain dead donor, but rarely we can get from the cardiac death. In our places, is very rarely we get liver live donor. We do mainly the donor from the brain dead patients, and you can see here the split liver graft, and from the piggyback technique and liver donor graft is the live donor graft is here. So this is our practice here. Usually we do from the brain dead patients, and then the surgical technique is the piggyback technique. Next one is the postoperative ventilation and extubation. Now you can see here the fast track anesthesia, the critical care management has gone significantly improvement, and then where initially it was it took prolonged ventilation, but nowadays these things have changed. Where I'll go to the next slide and show you. You can see this study. This is a meta-analysis where they've showed, this study had shown, you see it was 546 patients. They have divided into 3 groups, group 1, group 2, and group 3. In group 1, 102 patients were extubated in the operation theater. And group 2, 383 patients were extubated less than 24 hours. And group 3, 61 patients were extubated more than 24 hours. And you can see here, this is the criteria for extubation was hemodynamic stability, neuromuscular, the normothermia, tidal volume, respirate, as we all know about these things. And you can see the result. In group 1, where the patient was extubated in the operation theater, 9 out of 102 patients needed re-intubation. In the second group, where the patients were extubated, within 24 hours in the ICU, 50 patients out of 383 had to be re-intubated. And group 3, 22 out of 61 needed re-intubation. And you can see regarding the survival at 5 years, greatly reduced in group 3, that is, which were ventilated for prolonged time. Mortality was higher. The survival rate was less in 5-year time. So it shows that early extubation helps the patients in the recovery profile. The other study also shows a similar picture. You can see here, this study, 652 patients were then, and most of them, 575, were extubated in the OR, and seven patients were non-extubated patients. And ultimate result, you can see here, 30 of the 575 patients needed re-intubation, and within 48 hours needed re-intubation. And that causes of those they found out over sedation and pulmonary failure, pulmonary edema. So the recommendation currently is to extubate as early as possible. In some of the institutions, they do extubation in the operation theater, but in our practice, we take straight the patients to the intensive care unit, where we find these criteria. So hemodynamics, we want patient hemodynamically stable, and ventilation, spontaneously breathing patient, respiratory status is there. We see the consciousness of the patient. If the consciousness is good, muscle strength is good, and normothermia, and the visual analog score for the pain is less than 3, we try to extubate. And usually 90% of the patients are extubated within 4 hours, and some of the patients, they can be extended. So this is regarding extubation. Next one is the most important thing, is hemodynamic monitoring and optimization, because the surgical patient of this and this hemodynamic monitoring is very complex. And we can see here, because of the risk of bleeding during surgery, and then resuscitation with blood transfusion, massive blood transfusion sometimes, and with fluid resuscitation, and then third stage losses are there. And then you can see the complex end-stage liver disease, having hepatorenal syndrome, having portal hypertension, having cardiac dysfunction, and high cardiac output condition. It needs proper hemodynamic monitoring, and then you can see the vascular. Now, our goal here is in the critical care unit is to maintain proper preload, and you can see here, and preload can be dependent on central venous pressure, and you can see as long as we have blood volume and venous capacity adequate, in that case central venous pressure is maintained and preload is maintained. But these are all dependent on heart rate, atrial contractility, ventricular compliance, aortic pressure, all those things. But the way we need ventricular filling, but at the same time, we don't want to go for hypervolemia. So hypervolemia is also not very uncommon, because excessive resuscitation during surgery, and then may lead to hypervolemia, which can lead to expanded blood volume, dilutional anemia, and can have heart failure, all those things. So our aim is to maintain an even balance and maintain the preload. So how do you do that? I'll skip this one and then go. Now, the monitoring. The gold standard monitoring is pulmonary artery catheter. And as we know, this is dependent on the principle is thermodilution, and this is found to be an accurate, measures cardiac output. It directly measures pulmonary artery pressure and right ventricular and diastolic volume index, and also measures, we can see the pulmonary portal hypertension. But limitations are there. This is, you see, there are a lot of people, it needs experience, and it's difficult. It's a very invasive procedure, and it involves a lot of risk. And the use of nowadays in surgical anesthetic practice, this pulmonary catheter utilization is very less nowadays, but still it is very helpful in these cases. Now, the second thing is monitoring is PICO, and this is PICO is, the principle is based on pulse control analysis. The PICO is less invasive, it gives us continuous measurement of cardiac output, stroke volume measurement, and we can measure with that is the intrathoracic blood volume index, extravascular lung wall index. So you can, the pulmonary edema is there, we can see that. There is the pulse variations, pressure pulse variation, and stroke volume variation, all those we can get from this. But this is, the PICO system has got a disadvantage. It needs regular recalibration, and we'll show about this. These are similar PICO, LEADCO, and 3 flow track Vigilio. These are nowadays used in anesthetic practice in the intensive care units to see the cardiac output monitoring, and this gives a quite reliable, but in comparison we'll show in the next one. The next one which is coming is transesophageal echo, and in the last lecture we have seen this, Dr. Satyan has discussed about the transthoracic echocardiography, but in this setting, because there are changes are rapid, the volume loss is rapid, and we need to visualize this, and transesophageal echocardiography has found to be very useful, and that is dependent principle is ultrasound Doppler, and it is less invasive, and we can directly visualize the cardiac function and the volume status.
Excuse me, sir.
Yes.
We are in very shortage in time.
I'm finishing within a minute, and I'll go this one. Now you can see the this is the ABG with the acid-base balance, and I'll show this one is regarding. I'll skip this one and Okay, so this is the piece pulmonary cardiac catheter, which you can see the cardiac index, and its dynamic status nowadays. It can give us all the informations on stroke volume index and right ventricular index and left ventricular stroke index. So we can know the preload and we can resuscitate. So this monitoring technique helps us, and the transesophageal echocardiography. So you can see this transesophageal echocardiography, and next one is, I'll just show the last slide and go away. Now, what is our own practice? So our practice, we do arterial line, and we do the arterial line is radial arterial line as well as femoral arterial line. I couldn't discuss about this because there is some variation in the reperfusion injury. So we do both arterial, femoral and art line in the radial artery, and then we do CVP line. We do the pulmonary catheter. We do the transesophageal echocardiography. We do the thromboelastography to see the clot formation and decide what to replace. Point of care ultrasound is very helpful in sometimes to diagnose the volume status, and the BIS, temperature, and the ABG. And that's it. Thank you very much. There is a question. Is that okay? Yeah.
Dr. Habib, 1 minute, please.
Okay, I finished now.
Our last speaker in this session, Dr. Tahir Ali from UK. His topic is the intensive care for the burn patients. Dr. Tahir Ali, sir.
Oh, thank you. Sorry. Can you hear me?
Yes, sir. Yes, sir. I hear you.
Thank you very much for the invitation. Thank you for Dr. Koser for arranging this. We've got limited time, as everyone does, and obviously this is a huge topic, so I'm going to be going through as many principles as possible rather than significant details. I work as an intensivist and an anaesthetist in Buckinghamshire Healthcare NHS Trust, and I have no disclosures. So hopefully following this presentation, we'll all be able to understand a little bit better about the classification and the different classifications of burns, the priorities when managing a patient with burns, how we fluid resuscitate, and the different types of inhalational injury, which is a major cause of morbidity. And of course, the ongoing management on ICU very briefly, and then hopefully together appreciating the importance of a multidisciplinary team involvement in the management of burns, including the emergency physicians, the intensivist, the anaesthetist, and absolutely the plastic surgeons. They are a vital part of this management, and of course the intensive care nursing staff and the paramedics as they are bringing the patient in. So we're going to talk about a case, because I always find learning any condition is far more useful when it's done with a case. So we'll talk about a kitchen fire. We have a 45-year-old woman who was previously very fit and healthy, no comorbidities. She was cooking and caught fire. And she was wearing several layers of clothes, had just come from outside, hadn't taken them off, and she caught fire and ended up in fire for about 5 minutes at least. After which her housemate managed to cut off and rip off her clothes and throw a lot of water using saucepans and various other methods to try and put out the fire, noticing she sustained quite significant injuries. So normally I'd like to put the question out to the audience, but obviously we've got several hundred over here, and it's not feasible in the time duration. So what are the injuries we're thinking? As this patient is being brought in, or we're being alerted to this patient, we need to start imagining what sort of injuries this patient may have in order to plan and prepare for the likely requirements from our help. So skin burns, of course, I mean, that goes without saying. The patient has skin burns. We will have to assess the extent of it, and that will be very important and crucial in guiding our management. Facial burns are likely because the front of her body was burned, so she's very likely to have facial burns with their implications, and they consequently are involved in airway burns, inhalational burns, and if she's been in a confined space, or if any upholstery and sofas or any upholstery like that has been burning, then we need to think about other sort of poisoning, such as cyanide poisoning. But the one that we really need to think about is carbon monoxide poisoning. Then we thought we need to start imagining our management priorities. So when this patient arrives, we start to think there's a lot going on. There's a lot of horrible smell of burnt hair, burnt skin, burnt tissue, burnt clothes. And the patient is stridorous, the patient's struggling to breathe. Where do we begin? And it's always useful to fall back onto the simple ABCD ATLS protocol with the addition of the wound assessment, which is crucial in the ABC assessment. So obviously we'll do that. We don't need to go through the ATLS protocol. You must think about hemorrhagic shock. So whilst the likelihood of her hypotension is going to be fluid loss, we do need to think about hemorrhagic shock, so we must rule out other causes. And also part of the assessment, as we said, is to evaluate the burn severity and implement urgent management protocols to resuscitate and then plan her management. So what do we do in A? We must control the C-spine. In the history, it wasn't very suggestive of any C-spine injury. However, if there's any doubt, immobilize as much as possible. This lady has extensive burns to her face and her neck, so a collar is not really an option. Therefore, immobilize as much as possible, and also send for investigations that will rapidly be able to assess for any immediate C-spine injury, which would be a CT neck. She has burnt hair, her tongue and lips are swollen significantly, and she's drooling, stridorous, and she's got soot in her mouth. So what do we do? So here, immediately, we had everything ready, and we prepare to intubate the patient, and the patient would be intubated with an uncut size 8 cuffed oral ET tube, and the tube was tied around the incisors. Now, the rationale for mentioning this is that it's important. It's uncut because as the burn extends, or over the course of several hours, the facial swelling can increase significantly. And also the swelling inside the lips and the mouth can increase significantly. So the tube embeds itself in the mouth and you won't have access to it. So for any anesthesiologists who end up cutting their tube, in this situation, you don't cut your tube at all. Use a size 8 preferentially, and that is because they will likely need a bronchoscopy or multiple bronchoscopies, and therefore using a size 8 tube, it's much easier. And of course, tying around the face is not a wise option, because as the swelling in the face tends to increase, then the tube will migrate outwards. So we tend to stitch it around the gum, or stitch it in, suture it into the gum, or wire it onto the teeth. Other principles, we spoke about C-spine immobilization and CT neck as part of our CT scans. Whether or not to intubate, I mean, there are many reasons. We don't need to go through in-depth discussion, but of course, if the patient's comatose, they've got symptomatic inhalational injury, they're profoundly hypoxemic, they've got deep facial burns, they've got a significant percentage body surface area burns, which is likely to be very, very painful, requiring a lot of surgery, we will need to intubate them. And this is not one that will require someone who is having a go first time. This needs to be an experienced person, a senior person, and you need to have your difficult laryngoscopy equipment ready to go. Suxamethonium, usually people ask, it's safe in the first 24 hours, but I think we don't need to discuss in a lot of detail. The tube needs to go in. This is not one of those situations where you can wake the patient up if you can't get the tube in. So really make sure you prepare everything for and anticipate a difficult intubation in order to and have all your kit and equipment ready. Other principles, general principles, this patient or any patient with significant smoke inhalation is very likely to develop ARDS type injury and therefore lung protective ventilation. So types of inhalation injury, they depend on whether it's a flash burn or prolonged exposure. Flash burns generally just affect the upper airway, while prolonged exposure and prolonged enclosed areas can usually affect the lower airways as well. And that can range from pure upper airway obstruction due to swelling to lower airway and noxious gases. So briefly going through it, because again, we are limited with time. Upper airway injury. It's due to thermal injury to the mouth, oropharynx, and larynx. Now, air can be hotter than 150 degrees centigrade. And it does not happen immediately, so you have to observe them for the next 24 hours because the swelling can increase, the stridor can develop and then worsen, and the symptoms can worsen significantly. And don't forget, with this, you're very likely to have a distorted anatomy as well, which can obviously have implications in terms of laryngoscopy. So what do you do? So in this patient, back to them, they are intubated with an uncut tube. Soot was aspirated from the ET tube with a bit of suctioning, and obviously that has implications. We are now thinking they are very likely to become more hypoxemic and develop the lower respiratory tract symptoms. Fluid management, now that we know there's respiratory injury and there's soot inside the airway and they've very likely inhaled a lot of hot air, they're very likely to require much more fluid than we initially calculate, and how we're going to discuss. So that's the upper airway in a very, very, very short nutshell. Then the second type of injury you can get is the respiratory injury, and that's due to chemical and particulate constituents of smoke. And it's much worse than just heat alone. The heat obviously has initial injury, but the constituents trigger a chemical pneumonitis as well. And that can have multiple implications in terms of atelectasis, mucus plugging. And of course, you will require more fluid and the mortality goes higher. The more injuries are added, the higher the mortality. Pathophysiology, we're not going to go into a lot of detail, but they have a combination of factors: mucosal edema, surfactant, cast formation, and so on and so forth. So how do we diagnose it? Obviously, the history is important. Physical findings. In this lady, you see soot coming out of the ET tube being suctioned in large quantities. And obviously, if someone has got carbon monoxide levels, we need to consider that there is going to be very likely to get worse before they get better. So how do we treat? Treatment of the lung injury. Good resuscitation. Nothing beats good quality resuscitation from the very onset of or arrival of paramedics to them going through theaters onto ICU. Good quality, standardized assessment, not a person coming and saying, let's do this when others have not got experience with it. Use standardized methods. Bronchoscopy and washout to consider, and that is something that we do, and we encourage it to be done at the first instance, when able, where we do a washout and we clear out all the soot, and then we implement our nebulization protocol. lung protective ventilation, judicious use of PEEP, and humidified oxygen for sure. Steroids are not something we should be using in these situations, and antibiotics are not to be commenced initially unless there's a strong clinical indication. And I know we always reach straight away for our antibiotics, but there's no specific reason here unless there is a good clinical reason for it. Point of care ultrasound has been discussed already. Point of care ultrasound is widely used, and also a lot of us are enthusiasts, and we use it on any patient who is sick, certainly in these patients to assess our extravascular lung water. Now, the other type of inhalational injury can be the metabolic asphyxiation from carbon monoxide, cyanide, and so on. And without going into a lot of details, carbon monoxide binds very strongly to your hemoglobin, and therefore reduces your oxygen carrying capacity and also shifts the curve to the left. So you become hypoxic at a tissue level. There's a varying degree of severity and symptoms that can occur. With the higher concentration of carbon monoxide in your blood, the higher the mortality and the worse the symptoms. So we do talk about this cherry red discoloration of the nose. Generally, they are so hypoxemic, you don't see it that often. However, don't rely on your pulse oximeter. The pulse oximeter will probably read 94, 95, but in reality, an arterial blood gas is essential, as that will give you an accurate reading of the arterial saturations, the PO2, and for sure the carbon monoxide levels. And the treatment of carbon monoxide poisoning is fairly straightforward. The half-life is 4 hours, and if you give 100% oxygen, it will drop it down to 1 hour. All the texts talk about hyperbaric oxygen and hyperbaric therapy, but hyperbaric therapy is not easily accessible, certainly not widely available, and it's not an ICU. The chamber cannot contain ICU equipment. And usually the difference is from 1 hour, it will shorten the half-life to half an hour. Unless you are in a center that has it, it's not always that straightforward to get it done and get the patient across. So good quality, high flow oxygen, whether it's via CPAP mask, if the face will permit that, high flow oxygen, or via an ET tube. That is what we should go for immediately. Back to the patients. They're on 100% oxygen. Carbon monoxide levels were toxic levels above 40. She was stridorous and she was seesawing with significant respiratory distress. And assessing and exposing her lungs, or her chest rather, she had full thickness, circumferential burns to her thorax, which was significantly restricting ventilation. And when the tube was inserted, the ventilation was very difficult, very stiff. So plastic surgeons were right there at hand. And the advantage of after the intubation, they had just received a big dose of the anesthetic. Escharotomies were performed, and that was slits across the chest to try and allow expansion. We'll briefly mention our BA bronchoalveolar lavage protocol, and that is taken from our colleagues in the Mid-Essex Hospital, where they have the major burns center. We nebulize various things, and that is to help reduce the consequences of smoke inhalation and the inhalational injury. So we nebulize heparin, acetylcysteine, and salbutamol. The rationale behind, now of course, if we go through in-depth scrutiny of all the evidence behind all of these are not very strong. However, these are techniques and methods that are used around the world, certainly in US and UK and certain parts of Europe, for management of inhalational injury. Now, if it's a standard process, it's very difficult to randomize people into two groups, then we adapt certainly the same protocol. And the rationale behind it, and you can look up the evidence, we're limited with time, but the rationale behind anticoagulants like heparin is to actually reduce the formation of fibrin casts, because that can promote airway obstruction. The rationale for mucolytics such as N-acetylcysteine is they can actually break up some of the mucus. The big problem with N-acetylcysteine is that it can also cause bronchoconstriction. So that's the rationale behind the bronchodilators. There are various protocols around different centers around US and UK where they use a similar version of this. SCARs, again, we're not going to go to a lot of detail, but I think everyone's familiar with escharotomies. The rationale is you tourniquet around your chest or your arm or a limb, and that consequently results in further ischemia and vascular damage and a compartment syndrome. Now, circulation. So we need to think about this. The patient's tachycardic and hypotensive. We must think about hemorrhagic shock for sure. IV access is difficult, but you get it wherever you can. Think about intraosseous access. Think about central access. She had femoral access immediately placed in, and for sure use point of care ultrasound to assess the cardiac function, assess the lung volumes, assess for lung atelectasis, and assess for any intra-abdominal fluid. Fluid calculation, there are different calculation methods that we can use, different formulas. We still use the Parkland formula, and it has to be given over 8 hours and 16 hours, half and half. However, we have found that almost always, in fact, always we are required to give a lot more fluid than we initially calculated. So you need to guide it using your parameters, using your heart rate, using your blood pressure, using your urine output, which is the gold standard, because heart rate is going to be reset at a higher level. So it's difficult to assess that. And you need to try and aim for a 30 to 50 mils per hour of urine output. And of course, if you have the ability and the resources to use point of care ultrasound, very important to use that. A real important principle that's worth thinking about is the fluid creep. And the fluid creep is another way of saying you're ending up giving more fluid than you should. And that happens for many, many reasons. We may not calculate the patient's weight accurately. We may not calculate the burns appropriately. We're not adding the propofol, the sedation, the muscle relaxant, the antibiotics, and various drugs that we're giving. We may not include that, and therefore the fluid will increase, and that consequently causes edema, pulmonary, pleural, pericardial, and so on. Again, important to start using point of care ultrasound to assess for these changes. You can get intraocular hypertension requiring ophthalmological assessment. I see I've hit more than 15 minutes. I will be shortening this and we'll be finishing soon. Massive edema, compartment syndromes, and so on. So how can we ameliorate, how can we reduce that? Measure everything accurately, try and ensure we measure all the inputs, and we are very careful about that. Assess the burns appropriately, and use hemodynamic monitoring. There's very limited evidence for this. However, use whatever monitoring you are familiar with and you're comfortable with. And do not forget point of care ultrasound. Okay, so very briefly, severity of burns can be classified using different methodology. The older or younger the patient is, the more severe. If they have comorbidities, it's much more severe. If hands, perineum, and feet are involved, much more severe. And of course, if there's inhalational burns involved. We don't need to go through details of the depth, first, second, and third degree. This can be looked up. And how do we assess it? There are different charts that can be used. I would recommend no one should go and memorize any rule or any chart. Pull it up on your smartphone, pull it up in your ED, have it readily available, get someone to stand there and scribble and mark which areas are involved to accurately assess the burn size. Why is that important? Because it does have prognostic implications, and it does have implications in acute and long-term management. And major burns have various other criteria, which we will skip and we will move past, but certainly inhalational, chemical, electrical burns are important. So obviously the higher the burn percentage, the more important to manage in a specialist center with experience. And it needs a thorough assessment, preferentially in a theatre environment where they can be assessed appropriately. There are various criteria. We use the British Burns Association referral criteria for which patients should be referred to a burns centre, and some of which we have touched on. Back to the patient finally, their GCS is 3, they were transferred for a CT head and neck, and we talk about pain. Now everyone go on about when there's full thickness burns, it's painless. Yes, it is, but usually surrounding those full thickness, there is partial thickness, and the patient, if their GCS is not 3, they are in significant pain, and they're very likely to, over the next few days, develop neuropathic pain, so we need to think about their pain. Exposure, so initially in your primary survey, it's not always easy to expose fully and log roll. That was done late. We did that in theatre, and when we log rolled, we realized we even further underestimated the burns, and therefore that was added to the calculation. CT was done, a whole CT is done, and that's to assess any intracranial problem in case the fall had resulted in an intracranial bleed, C-spine, thoracic, intrathoracic injury, and any intra-abdominal bleeding. Now, they were taken for surgical management. For all the anaesthetists out there as well, it's an absolutely essential case, and we need to be very careful. Senior person, the airway is likely to be difficult. Get ready, prepare for it. They're not going to be fasted, so that's not really relevant here anymore. The vascular access is likely to be complicated and tricky. Monitoring, you will very likely need invasive monitoring. They are likely to have significant blood loss due to the amount of skin loss, and likely a lot of fluid requirement. They will very likely go into DIC and develop a coagulopathy. They have a major hypermetabolic syndrome. Use whatever anesthetic you want, whatever you're
Excuse me,
comfortable.
sir.
Finishing?
Yes.
Yeah. So I'm just going to wrap it up now, okay? Post-operatively, they need to be managed on ICU. And as we said, burn shock, we need to assess with an echo. We need to assess whether it's actual cardiogenic or it's vasoplegic. Various mechanical ventilation methods need to be used, but our classic ARDS, lung protective ventilation. Bear in mind, our temperature is readjusted. So if your temperature is above 39, then you need to start thinking about infection. Below 39 is not something we need to think about, but we need to just bear in mind. They need nutrition, they need psychological help and rehabilitation, and of course, pain needs to be multimodally achieved. She had a rocky course on ICU, tracheostomized, multiple trips to theaters, multiple grafting, and then made a good recovery. So if we were to summarize the entire thing, 7 phases of management according to the National Burn Care Review is rescue, which is what the paramedics who are key, resuscitate, which is ED, anesthetics, ICU, retrieve, and get them across to the right place, theaters, resurface, rehabilitate, reconstruct, and review regularly, and have a low threshold for suspecting skin infections and any other complications. Thank you for that. It was a rush through it, but thank you very much. We'll leave the questions to another time.
Thank you very much, Dr. Tahir Ali sir, for your nice presentation about the burn patient management in ICU. Now we would like to go to today's panelist and the chairperson for their valuable comments and some question or answer. At first, I want to go to the very renowned person, Dr. Ritesh Lamsal. He is the renowned person in the field of anesthesia and intensive care, and requested him to pass his valuable comment about this session.
Thank you.
Ritesh Lamsal.
Yes. Am I audible? Hello, am I audible?
Yes.
Yes.
Yes, sir.
Okay, I would have actually loved to ask a few questions, but you and the organizers have repeatedly emphasized that we're running very short of time. So in the interest of time, I'll keep my comments very brief. The first presentation on multimodal neuromonitoring by Dr. Keshav Goyal was wonderful. I think he simplified the very difficult topic really nicely. It was also very nice to have the opportunity to listen to him after over a year. Dr. Zulfikar Ali's topic on neuroradiology was also very simple and very useful for all of us working in the neuro ICUs, especially to make prompt decisions based on CT scan findings, particularly in terms of identifying those acute lesions in the ICU and taking immediate measures to lower the ICP or prevent secondary neurologic injury, or sometimes even taking the patient immediately to the operating room or the neurocath lab for intervention. Similarly, our third speaker, Dr. Satyan Parida's talk on TTE was enlightening. I'm sure Dr. Parida's amazing talk will be the catalyst for some of the non-cardiologist listeners of his talk to do more TTEs in our ICUs, which most of us, quite frankly, don't do enough. Our fourth speaker, Dr. Mohammad Zaigirdar's presentation on intensive care management of liver transplant patients, and the final presentation by Dr. Tahir Ali on intensive care management of burn patients were very well prepared and extremely informative. So I would like to thank all the eminent speakers. And lastly, thank you, Professor Debobrata Banik and Professor Kausar Sardar and the Bangladesh Society of Anesthesiologists for this wonderful opportunity to chair this important critical care session by expert anesthesiologists and intensivists. We are running very short of time. Thank you all. Thank you very much.
Thank you very much, Dr. Ritesh Lamsal. Now I request the renowned anesthesiologist, Dr. Lutful Aziz, sir, for his valuable comment about this session. Dr. Lutful Aziz, sir.
Thank you, Abdullah, and thank you, BSI, for giving me this opportunity to chair this session. This is the first
আনমিউট করেন নাকি? আনমিউট আছে? আনমিউট
We
করেন।
can't hear. We can't hear.
Hello. Dr. Aziz sir, can you hear me?
হাবিব, লুৎফো, এই শোনা শোনা যাচ্ছে না।
আমাকে শোনা যাচ্ছে না স্যার? হ্যালো
না
স্যার।
লুৎফুল আজিজ।
জি স্যার।
লুৎফুল আজিজ, you are unmute.
Yes, he's unmute, but something is wrong there.
Something in connection problem, Lutful Aziz.
না স্যার, ব্লুটুথ ইউজ
You
করছে
cannot
তো
hear
স্যার,
me
এজন্য স্যার নাও আই থিংক আপনি যদি ডিভাইসটা আরেকটু কাছে নেন তাহলে শুনতে সুবিধা হবে।
Now you can say.
Hello.
Hello.
Yes sir, we can hear you now.
Yes.
Now you can start with your comment.
Thank you, BSA. I'd like to thank BSA for giving me this opportunity to chair this session. This is a wonderful e-congress, the first of this kind in Bangladesh. I am happy and honored to be a member of this society. This beautiful session of 5 presentations by different eminent speakers of India, Bangladesh, and England.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.
We are sort of discussing. Can you please mute the other speakers? To ask you this question, whether it's a taboo subject in our region, right? So without taking much time, I would like to go straight to the talk. So I hope that most of you would have seen this picture, which is a portrait, which is there in the Tate Gallery in London. And this is a physician in 1800s. So you can see that there's a very sick child lying, probably very sick, and presumably due to typhoid fever at that time. But you can imagine that there's nothing around her compared to what we all are enjoying today. There are no monitors, there are no infusions, there are no life-sustaining machines. But what you can see is there is a physician who's very empathetically looking at this child, while there is one of the parents in the background as well. So one thing was sure at that time, you make this diagnosis, but there is no proper treatment. Death was quicker, it happened in the familiar environment. But compared to that time, we enjoy so many new, advanced stuff nowadays. So this diagram witnesses what you enjoy at the, latter part of the life. You will be surrounded by so many machines, and actually the cause of death has transformed pretty much from the infectious causes to non-infectious causes nowadays. And actually you really don't get a natural end, probably, if you look at this thing, if at all, if you consider the patients who are not surviving in the ICU. So people were worried that they will lose the liberty to decide on their end at this sort of a stage, and at the same time people were dying as a failure because of these advancements. So when you look at the models of care during all this time, it has also transformed from, what we call that we were trying curative treatments till end at one stage as we are advancing on with the treatments, more and more advanced treatments available, but finally failing everything we, were considering the end of life care since everything is failing. But is it the best way to, manage patients that we are caring for? But this second diagram shows that the, care models has been changing from what is called the rectangles to triangles. So you need to consider the comfort measures from the early part of the management. As the chances of the curative potential is going down, you need to focus more and more on the comfort measures. So traditionally, it's in the intensive care, we are trying to save patients. So we are trying to improve the mortality and morbidity, and we provide organ supports, and we are trying to mitigate the effects due to organ supports, maybe the complications like ventilator pneumonias and so on. And later on, as the patients are improving, we are trying to bring them back to the normal life by providing rehabilitation. But after all, are we, good enough to defeat this particular topic, death? It's not the case. Death is inevitable. So then people were worried, okay, we are trying to have a good life, so why not a good death? How do we define the good death? And they were trying to define it using the term dignity. So dying with dignity, intensive care. So dignity encompasses different, terms, which may be, external and internal factors. And then if you look at this interesting paper by Prof. McLean about 17 years ago, she started telling this dignity may be a useless concept. So then we all are a bit confused. So we thought of, exploring what is happening in our part of the world. So unfortunately, we don't get much, data on this particular topic. So we thought of sending out some, online questionnaires as a small survey regarding the, perception of end-of-life care practices in Sri Lanka. So we have sent 140 questionnaires to
most of the specialists in various fields involved with acute care. So we were getting 69 responses, probably less than 50% response. Itself means bit of lack of interest on this particular topic. And most of them are young specialists, and most of them are having reasonable experience with involvement in the acute care. So if you look at these responses, most of them are agreeing with these statements. So most of them are agreeing that we need to go by the consensus of the decision making when it comes to the life-sustaining treatment at the end of life. And we need to consider the shared decision making as opposed to the paternalism. And most of them thought that autonomy should be the defining the ethical principle at the end of life care decision making, which is more or less similar to what the West or the developed countries are practicing. So if you remember this study, well-picker study done in 2014, so they were looking for, they were seeking the consensus among the medical communities regarding the end of life care. Most of the statements, more than 80 of the statements were endorsed by more than 80% agreement. So some of the statements that I just showed are also agreed upon by more than 80% of the agreement. And in that sense, you might think, okay, well, we are also thinking in the same way. Is it really the case? So now, when you consider the patients who are in the intensive care unit, so you get different types of patients. Some of the patients are getting what is called the level 3 care. So they are getting escalating, supports of organ life-sustaining treatments. And some of the patients, some of the patients are getting level 2 care. They are basically for the monitoring purposes. And there is another category of patients who have basically failed most of the options, and therefore maybe they are getting futile treatments, and we need to make decisions. Who's going to make the decision is the question. So most of the time, these patients are, not having any capacity to make decisions because they are unconscious. They may be on sedations. So then, from whom we are expecting these decisions? So probably you need to go to the surrogate decision makers. That may be the next of kin. That may be the family members of the patient. So we may probably asking a difficult question from them. We are making them extremely distressed. So to avoid that, probably people used to practice what is called protective paternalism. So shared decision making may be a very good concept, came from West, that we both sides sit together and make decisions. But when it comes to our part of the world, it's not going to be that easy. That I'm going to discuss a little later. And when it comes to decision making, it is found during this study, some of the patients who are having serious head injuries regarding their options at the latter part of the life, when there's a prognostic uncertainty, non-clinicians thought clinicians should make the decision on behalf of them. And what about the autonomy? So is it going to be the same ethical principle which is going to prevail during the decision making compared to beneficence and non-beneficence? But when it comes to the respect for somebody's wishes, we need to consider certain values, thinking patterns, and the communication modalities in our part of the world. We usually as Asians, based on our cultural practices, we don't make individual decisions most of the time. We are practicing what is called collective decisions, because we think everything is interconnected. So way you make decisions might affect others. And also when it comes to the communication, it is a bit of indirect way of communication compared to what the West is practicing. They mostly go by individual decision making, and also they are explicitly making decisions when it comes to the difficult topics like this. So we can't just go by the autonomy in that sense. Probably we need to consider familial healthcare facilities and also the social factors during the process of decision making. There were some other interesting responses during our survey, and people thought death should not preferably happen in ICU. So we were making that statement in a negative way. And also people thought that diagnosing dying may not be possible. Majority thought like that, but there are people, going by the opposite way. And majority thought that the end of life path is not similar to euthanasia. And when it comes to the withdrawing and withholding organ support, majority thought withdrawing is illegal compared to withholding. These are some of the responses from most of the specialists. So in that sense, there are some vague consensus related to that. So if you look at this study, which is done in England, since we don't have a study with regard to this particular topic, when they ask people where they would like to have their death occurring, so most of them wanted to avoid their death in a hospital. So if you ask this question from yourself, probably you might also say the same. But what is really happening is we see most of the patients are getting futile treatments during the latter part of their life. And it may not be their wish, but according to the Schneiderman, this particular topic, particular paper, as he says, probably we may be abusing the term futility. That may be why we continue to deliver futile care to some of these patients who are really dying. So can you diagnose dying? So is it an easy thing? Probably it may not be so. So according to the GMC definition, you need to consider somebody is dying when he is likely to die within next 12 months of time. It may be a quick occurrence or it may be a very slow process. And you can't just make the diagnosis of dying by doing investigation or whatever. You need to consider trajectories of decline, which are the physical, social, psychological, and spiritual trajectories according to the Murray. And probably you need to go back to the history of the patient and see what was happening really during the last so many years, so many months. Then only you can come to this conclusion, which is not going to be easy, maybe due to the significant uncertainties associated with this diagnosis. So at best, people thought we may not be diagnosing at least one third of the patient that we are trying to diagnose as dying. But this study says if you just practice this, repeatedly, probably your diagnosis is going to be better. So how can we make this change? Probably we need to change the way that we are thinking. Probably we need to teach our students during the undergraduate curriculum. So I hope that nobody would remember anybody was taken to see a dying patient during your medical student days. But we probably need to change these practices simply because the population dynamics, the causes of death, everything is changing. So we should not let somebody to die on machines simply because of its availability. And the other most debated topic is euthanasia. So India had a landmark decision in 2018 by the Supreme Court, if I'm right. So this is regarding the living will. So they decided to let the living will to be enacted during the latter part of the life. And as I heard that they have, enacted the passive euthanasia, but I'm not sure whether, the definition given there is correct, because when you consider the euthanasia, the intentional termination of patient's life is going to be the definition for euthanasia by omission or commission of some sort of act. But when it comes to end of life care, we don't talk about death. It is caring for dying patients to make them comfortable during their latter part, but we anyway don't intend to bring the death about, but we are trying to support them more. But during this process, we may be using some drugs and certain medications which may be affecting or which may be sometimes hastening their death, which is called the doctrine of double effect. So people used to confuse these two terms and take both terms as one thing. So that may be one of the reasons why people are more resistant to this particular area and leading patient to suffer in the machines. So legal standpoint is another important area. So most of these practices evolved in the West because of some of the court orders. So you would have heard of this Karan and Quinlan's case. And similarly, there was a case recently, the Aruna Shanbog's case, but unfortunately, as a reflection of our perception on this particular topic, it was declined. And similarly, there are so many gray areas related to the legal proceeding in this part of the life. Probably that may be one of the barriers that we are reluctant to enact this pathway for caring for the dying patients. So when you consider the withdrawing and withholding supports, people have different ideas regarding two practices. But when it comes to the Europe, especially the northern part of the Europe, both of the the modalities are being practiced similarly. But when it comes to the Asia, so you see people don't hesitate to practice withholding most of the time, but they are really reluctant to use withdrawing, but they think these two are different. But if you look at what is called suffering due to these futile treatments. So this Liverpool care pathway is one of the landmark during the whole journey of end-of-life care. So 1990s, this particular pathway was enacted in the Royal Liverpool Hospital, but later on, due to heavy public criticism, it was withdrawn and it was stopped in 2014. So there are so many lessons that we can learn by this pathway. One of the lessons is that we need to make sure public is aware of such things, otherwise there will be serious problems. So when it comes to Sri Lanka, so we also have a diverse cultural and religious, population, but we don't practice most the end-of-life care practices. So we thought of having an end-of-life care task force, and so many different specialties were involved. And the Sri Lanka Medical Association, as the apex medical body in Sri Lanka, took the leadership. And ultimately, we managed to prepare the document regarding the practice guidelines of end-of-life care, after so many deliberations and so many discussions. But finally, a group of ethicists actually denied this document, saying it's a highly offensive document, though it was tried, there were so many cultural adaptations. So this system is such that we are so resistant to this topic. But if you look at the facilities available, intensive care is less. So we need to improve that. At the same time, we need to make sure end-of-life care practices are being appropriately implemented. Otherwise, we may be really struggling with the model of our healthcare delivery due to the resource constraints. And also, it's a fact that there is a very little contribution to the public health interest by improving the intensive care, unless we look at the end-of-life care aspects as well. So we need to make sure that one thing is for sure that even if you diagnose end-of-life patients, what to do. So we need to have palliative care practices established in our part of the world as well. And also we need to respect the wishes of the patient as well. And sometimes there may be effects on the organ donation prospects as well, not forgetting the dead donor rule. So the WHO rightly identified it as the human right, and emphasizes that you need to, make sure that these practices are being enacted in our part of the world as well. Right, thank you for listening. So message is cure sometimes and comfort always. Thank you.
Thank you. Thank you, Dr. Moros Edisuria from Sri Lanka. Now, sepsis for his elaborating discussion. Now, sepsis is a leading death of cause of death now, and early starting treatment in the sepsis patients save lives. Our next topic is an update on sepsis, and it will be delivered by Professor Jadat Salim from Pakistan. Professor Jadat Salim, are you hearing me? Professor Jadat Salim. Professor Jadat Salim from Pakistan.
Yeah, can you hear me?
Yes, we are here.
Thank you very much. Let me share my slide with you.
Okay, please start. Professor Jadat Salim.
Yeah, just give me a minute.
Okay.
Yeah, Jadat,
yes.
Please open your video. We can't see you. Open your video. The sound up. Okay, thank you.
Now,
Good.
can you see me?
Yes, very nicely.
Actually, I'm not getting to my presentation, which is present on the desktop from the share screen.
Yeah, share screen.
How to proceed?
Okay, share. Click on share screen.
Yeah.
Okay, then your desktop has come, and go to your presentation straight from here.
No, this is not desktop.
Salim sir, may I interrupt? Please
Okay.
open your presentation.
Yeah, I've got it. Fine.
Oh, yeah. Okay.
Thank you. Sorry for the delay. Bismillahirrahmanirrahim. Let me introduce myself first. My name is Dr. Jodit Salim, and I'm working as Professor of Anesthesia and ICU and Pain Management at Postgraduate Medical Institute, Lahore General Hospital, and I'm from Islamic Republic of Pakistan. First of all, I would like to thank the organizers for giving me this opportunity to talk about this very important subject, which is in fact a debate going on for last 2 decades in terms of management of sepsis. So to brief you, sepsis was taken as a challenge in year 2000 and in 2004. First time, the Surviving Sepsis campaign, they give their initial clinical practice guidelines, which was updated in 2008, 12, 16, and we had a new definition of sepsis. Later on, a little bit of the modification was made in 2018, and these are the new current guidelines and scoring system, which we are going to discuss and share with you in a couple of minutes. Now, before I start the sepsis, I was searching for some literature. So I found this Rory story. So just give me a minute. This was a boy who was 12 years old while he was playing football. He had an injury, and like another day after the injury, he was taken to the hospital where he was discharged with the diagnosis of stomach upset and dehydration. And unfortunately, this poor chap died within a span of 3 days, and the diagnosis was made of sepsis. His parents were shocked. They found a Rory Staunton Foundation, which is working for the sepsis prevention. So the topic and my message is an infection which is unnoticed, it becomes unstoppable. It can lead to serious morbidity or mortality. Now, briefly, we'll go through and we'll try to understand and discuss why sepsis has been revisited. We have already its definition, its management plan. What is the need of revisiting sepsis again? What is the difference between the older and the newer definitions? What is the morbidity and mortality in relation to cost of healthcare systems? And changes, what are the current changes which have been laid down in terms of management and scoring systems? Now, according to 2018 Surviving Sepsis Campaign Bundle, sepsis has been labeled as a medical emergency. It is as important as an acute MI, stroke, or polytrauma. You need to rush to the patient. You have to take every possible precaution when you would diagnose and receive a patient with sepsis. And the retrospective data shows that immediate measures, they improve the outcome of the patient with sepsis. Now, starting with the key concept of the sepsis. Sepsis is a primary and leading cause of the death from infection, particularly if it is not recognized and if it is not treated promptly. Sepsis is not just single entity, it is a syndrome. And the underlying factors like pathogen and the host factors, they play the major role in the progress and management and prevention from the sepsis. That what differentiates sepsis from an infection, from a simple infection, it is the dysregulated host response, which is the hallmark of the sepsis, and the presence of the organ dysfunctions. Now, this is a very important slide, and it says that sepsis-induced organ dysfunction may be occult. You may not find any clinical features at the initial presentation of the sepsis, but its presence should be considered in any patient who is presenting with mild infection as well. Because if you're not able to diagnose it promptly and in time, it might lead to a morbidity or even mortality. So what was the need of the new definitions? And why new scoring systems? Now, if you see that the economical burden all over the world, it is one of the leading causes of economical burden in all the world. I'll have shared maximum data from the US because that was the most refined data. So they spent around $20 billion in 2011, and in 2019, the figure goes to $24 billion. Sepsis is still the leading cause of death in non-coronary care intensive care unit, where mortality ranges between 30 to 50%. In the developed countries, it ranges between 22 to 30%, whereas in underdeveloped countries, the mortality rate goes up to 60%. If you see the slide, patients hospitalized for septicemia or sepsis were more than 8 times as likely to die during their hospitalization as compared to non-septic patients. As I mentioned earlier that in 2004, we had first guideline, then we had a review of them, then updated guideline were published in 2008. Then a concept of 6 hours bundle was given in 2012, which was reviewed to 3-hour bundle. And then finally, we have a definition of sepsis, new definition of sepsis in 2016. So what was the need of new definition? So definition of sepsis and septic shock were last revised in 2001. So there have been considerable advancement in the pathology. Now we have better understanding of the organ function, cell morphology, biology. We have better gadgets. We have better monitors. We have better pharmacological agent on board. So we need all of these. They suggested to re-examine the definition of sepsis. We need to differentiate the straightforward infection from one that can cause organ dysfunction, morbidity, or mortality. So there was an overlap between the SIRS, infection, sepsis, inflammation. So we need to be more specific towards the sepsis. So that was the need. We come up with the newer definitions. So SIRS criteria, they have been used to diagnose sepsis initially, and we have been using these criteria in the previous 2 decades. So what new concept said, the SIRS sound to be a good idea in early 2000, but it has lost its steam and it has a poor concurrent validity. So in 2016, in the 3rd international consensus definition for sepsis and septic shock, they proposed the new definition of sepsis. So sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. And the septic shock, it was again redefined. Septic shock occurs due to the underlying circulatory and metabolic abnormalities leading to the profound hyperperfusion. And the management plan was also changed, because before that we used to have 6-hour bundle, then 3-hour bundle, and now we have 1-hour septic bundle management plan, which state that we need to measure lactate level and we need to remeasure if it is more than 2 millimoles per liter. We should obtain blood culture prior to the administration of the antibiotics. We must administer broad spectrum antibiotic according to the underlying clinical condition, or just go with the broad spectrum antibiotic if you can't anticipate anything. Start administration of the crystallite solution at the rate of 30 mils per kilogram body weight for the hypotension, or if lactate is more than 4 millimoles per liter. And apply vasopressors if you're not able to achieve a mean arterial pressure of more than 65 millimeters of mercury, despite adequate fluid resuscitation. And the very important concept was given, that is at the presentation of the patient. That is called as time 0 or time of presentation. It is defined as the time of triage in the emergency department, or if patient is presenting from another care venue. So this will be considered as time 0, and you will start your management right from the time when you receive the patient. In this particular slide, I have shown the strength and recommendation and the level of the evidence. So lactate measurement is a relatively weaker recommendation, but the rest 4 are like obtaining a blood culture prior to the administration of the antibiotics is the best practice statement, and the rest 3 are the strong recommendations. This is a diagrammatic representation of the 1-hour bundle, which I've already stated. And this is the comparison of the surviving sepsis campaign definition versus the sepsis-free definition. In sepsis-free definition, SIRS is no longer a part of the management and the diagnostic criteria, and severe sepsis has also been taken out from the definition. Now, coming to the scoring system, before in the previous time, like till 2016 and before that, we used to go for the SOFA scoring, which is a combination of the 6 different components in which PO to FAO2 ratio of less than 300, platelets of less than 100, bilirubin of more than 2, hypotension requiring vasopressor support, GCS of less than 12, and creatinine of more than 2 milligram per deciliter. Each of these components has a scoring system from 0 to 4, and 0 stands for normal function, and as the function deteriorates, you keep on increasing the score. So if the collective score of all of these components is increasing, that means a greater morbidity or mortality. In this particular slide, you can see that if at the 7th day of admission in ICU, if a patient has scoring system of 0 to 3, he has got a mortality of less than 10%. But if this collective score goes to more than 20%, the mortality goes to more than 80%. So a new concept, a new scoring system has been devised, which is relatively easy and which doesn't require any laboratory investigation. You can repeat it even on the hourly basis. So this is called as a quick SOFA or Q SOFA scoring system. So Q SOFA scoring system state the presence of 2 Q SOFA criteria is a predict ICU stay of more than 3 days in an ICU in a non-ICU patient. It has got 3 components, and these 3 components are altered mental status, that is GCS of less than 15, faster respiratory rate, that is respiratory rate of more than 22 per minute, and hypotension, systolic blood pressure of less than 100 millimeters of mercury. Now, if you talk about in terms of economics of sepsis, so increased hospitalization was found in more than 1 million people in 2008, which goes to more than 2 million people in 2019 in the United States of America. Between 1999 and 2014, more than 2.4 million people, they died of sepsis. Here you can see that these are the 5 top most expensive diseases which are managed in the United States of America. And again, the sepsis is on the top with an expenditure of more than $20 billion in 1 year. So sepsis is a major health problem with increasing prevalence, high cost, and poor outcome. Here you can see 26 million people are affected every year, and the cost is increased to 19%, and it is #1 cause of readmission in ICUs of United States of America with a mortality rate of 25 to 30%. Unfortunately, the one who survived from the sepsis, they have got increasing complication, morbidity, high cost of care, and they have got a poor quality of life. So coming to the individual parameters which we have discussed so far, so talking about the lactate level. Serum lactate level is not a direct measure of the tissue perfusion. It acts just as a surrogate, and if it is increased, it presents that there is tissue hypoxia and there is accelerated aerobic glycolysis. Random control trial have demonstrated a significant reduction in the mortality when they are treated with the lactate-guided resuscitation. Now, coming to the fluid resuscitation, there's always a controversy in the past which fluid should be used. These are the latest recommendation. If your patient is having sepsis-induced hypotension or a lactate of more than 4 millimoles per liter, so on the left side, you can see if your patient does not require high flow oxygen, it's not a case of end-stage renal disease, he's not suffering from congestive cardiac failure, you start infusing the patient with the crystallized solution of 30 milligram, 30 ml per kg body weight. On the right side, in the red, which is written in the red and marked with the red, you can see that the patient with end-stage renal disease or a patient with congestive cardiac failure, you need to give them a total of 30 ml per kg body weight fluid, but you have to give it, you have to be clinically vigilant, you have to reassess the patient again and again if they are requiring oxygen requirement or any this clinical deterioration in these patients. In the middle corner, you can see the patient who are already having pneumonia or acute lung injuries. So there are two conditions. Either patient is ventilated and intubated. So if patient is intubated and ventilated, straight away go for the 30 ml per kg crystallite solution without any weight. But if your patient is not intubated and not mechanically ventilated, but he's dependent on high flow oxygen, then you reassess the patient. If required, intubate, ventilate the patient, and give them solution. So that is the importance of resuscitation with the fluids. So as I'm telling you that there are debates are still going on, which fluid and what to give, what not to give. So one thing is clear, we need not to give them heta-ethyl starches during the resuscitation. Heta-ethyl starches are associated with a high incidence of acute renal failure. Albumin is confined only for a particular group of the patient, and the mainstay of the management is crystallite solution, and with the ringalactate is your primary choice. Now, when to add vasopressor support? So it is, as I've discussed earlier, that if despite adequate resuscitation with the fluids, you're not able to achieve a mean arterial pressure of more than 65 millimeter of mercury, then you need to add certain vasopressors. And what should be our first line of therapy? So our first line of therapy is norepinephrine solution. We can titrate it from the 35 to 90 micrograms per minute, and we'll try to achieve a mean arterial pressure of 65 millimeter of mercury. If it is not working, the second line of defense is vasopressin, and we can add it in a amount of 0.03 units per minute to achieve a mean arterial pressure of 65. If we can achieve the target, fine, we can reduce one of these inotrope gradually. But still, if we are not able to achieve our mean arterial pressure target, then the third choice is the epinephrine. And it can be added in a manner of 20 to 50 micrograms per minute to achieve this target. Still, if we are not able to achieve the target, then phenylephrine in a dose of 200 to 300 micrograms per minute can be used. Now, regarding blood cultures, we need to obtain the blood culture before the initiation of the antibiotic therapy, and the appropriate blood culture, at least 2 sets, aerobic and anaerobic, they should be sent for the cultures, and the administration of the appropriate antibiotic therapy should not be delayed. They should be started, the antibiotic therapy should be started within 1 hour after the severe sepsis presentation. And there's a question of using a monotherapy versus the combination therapy. So depending upon the clinical condition, you can use either monotherapy or the combination therapy. That's purely a clinical decision. And then comes the now coming to the when to administer steroid. There was a controversy regarding the use of steroid, but now it has been said that if after adequate fluid resuscitation and vasopressor therapy, if still you are not able to maintain the hemodynamic stability, it is the time that you can use corticosteroids. Hydrocortisone in a dose of 200 milligram per day can be used in divided doses. And that has proved to be the game changer at times. There was a study which was done with the use of the hydrocortisone and high-dose vitamin C and thiamine for the treatment of severe sepsis and septic shock. The only limitation was that the number of the patients were quite low in this particular study. They just treated 47 patients, but what they found was that the hospital mortality rate was 8.5% versus 40% in the control group. Now, coming into the recent research trials which are going on in the management of sepsis, so I'll quote you 3 trials. This is called as ATHOS-3 trial, SENSOR trial, and Andromeda shock trial. So in ATHOS-3 trial, what they have used is they have used angiotensin II for the treatment of the refractory shock. So what they have done, they have used this is called as Giapreza, if I'm pronouncing it correctly. So they have started, the recommended starting dose is 20 nanogram per kg per minute, and they keep on increasing the dose every 5 to 15 minutes by 15 nanogram per kg per minute, and till the desired effect was achieved. So what they found that it proved to be an effective vasopressor with a catecholamine sparing effect, and it may provide benefit in certain population. But again, the problem was that the data was, the trial was on a very limited number of the patient. And the another very important point is that it is a very, very costly drug at the moment. What they found was that mean arterial pressure
time
response.
is constraint.
I'm just finishing, just give me a minute. Mean arterial pressure response at 3 hours, mean change in the SOFA score, 7 days and 28 days mortality, they were much better as compared to the control groups. So coming to the SENSOR trial, what they have done is they have used norepinephrine in those patients who presented with hypotension, and they have compared it with the conventional trials, the conventional management methods. So they found that they achieved target mean arterial pressure in 76.1% patient. They achieved target mean arterial pressure with good urine output and lactate clearance in 31% of the patient, and overall mortality rate was less. Andromeda shock trial, what they've done is they have basically they target the peripheral perfusion, and they compared it with the lactated guided therapy. And this trial was not a success. They said that this randomized trial of adult with septic shock found that the use of peripheral perfusion target resuscitation strategy compared with the targeting serum lactate did not significantly reduce the mortality. So I end up with the comment that we must be vigilant in the diagnosis, and we must institute proper early antibiotic, early empirical therapy, and finally the good fluid resuscitation along with the vasopressor use. Thank you very much.
Thank you, Professor Zadat Salim, for his excellent elaborative discussion. All the speakers are requested about if the presentation should be appreciated if they could be done within 15 minutes. Now, in COVID situation, the various system is included in the treatment. Finally, we are using in different countries the ECMO in COVID-19 patient. Now our topics is ECMO in COVID-19 patient. It will be delivered by Dr. Sambit Shaho from India. Dr. Sambit Shaho, are you hearing me?
Subrata.
Yes, sir.
Dr. Sambit Shahu, he fall in emergency care right now. He can join actually. For that, you can move to next one. I think Bimal yet not joined. Next speaker, can you call for the next speaker? Bimal, I think he is absent.
Bimal Kudavidange.
Yeah, from Sri Lanka, he is absent. So this.
I'm here. Can you hear me?
Okay. This is your name. Oh, change your name. I could not find you actually for the name. Okay, good. So go. Okay. Next one is the
Bimal. Next, hemodynamic monitoring in resource-limited countries. It will be discussed by Dr. Bimal Kudavidange from Sri Lanka. Please, sir, start presentation.
We'll be very happy, Bimal, if you are a little bit faster so that you can end it at 15 minutes.
I'll try my level best.
Yeah, thank you.
Can you see my screen?
Yes, sure. Yes. Just slideshow.
First of all, I would like to thank the organizing committee and especially Dr. Sada giving me this opportunity to talk on this topic. And then I would like to congratulate the Bangladesh Society of Anesthesiology conducting this successful webinar, this conference. So coming to my hemodynamics monitoring lecture, this is Colombo where I work. And so what do we want from our patients? We want our patients to have a good peripheral perfusion, good oxygen delivery to the tissues, and a correct fluid balance as well as plasma constitution. Then a paper by Professor Sherin in his review article showed that there's a need for hemodynamic monitoring. What he proposed is that why we need hemodynamic monitoring is to detect hemodynamic alterations to diagnose the underlying problems. Just hold on a minute. Just want to translate this. Right. And optimize oxygen delivery to the tissues. Precisely what he proposes that there should be a precise, personalized hemodynamic monitoring rather than goal-directed therapy to improve outcome and safety of the patients. We have various parameters to monitor for the hemodynamic monitoring and fluid therapy in ICU as well as in OR. With dearrangement of these parameters can lead to tissue hypoperfusion and hypoxia. Dr. Sarkoni showed this in editorial intensive care some time back that it's a fine line between fluid overload and hypovolemia. Fluid overload as well as hypovolemia can cause tissue oxygenation, tissue hypoxia, which Professor Moment also confirmed in his review article, where either hypovolemia and fluid overload can risk multiple organ failure. In further, Professor Moment, in his next review article in Annals Intensive Care, showed that almost all the organ systems can be affected by fluid overload. So therefore, we need to monitor fluid in our system or the body so that the hemodynamic monitoring is very important. So what do we monitor in hemodynamic monitoring? We need to monitor macro circulation as well as micro circulation. So what we monitor in static and dynamic monitoring is we monitor macro circulation. But there is a micro circulation where at capillary levels, oxygen and tissue oxygen is delivered to the tissue level. There is a hemodynamic coherence between macro and micro circulation at health. But in ill health, this hemodynamic coherence is lost. So therefore, what do we monitor? We have static measurements where we monitor variables at a given point of time, such as CVP, pulmonary artery capillary wedge pressure, end-diastolic volume, IVC diameter. Whereas in dynamic measurements, we analyze waveform of flow or a respiratory cycle, or changes in parameters with the intervention, where we estimate fluid responsiveness and assume that patient's volume status, where he is in relation to the Frank-Starling curve, whether it's the steep part or a flat part of the curve. So Dr. Sarkoni showed this finance study that what are the hemodynamical variables physicians monitor to predict fluid responsiveness. Interestingly, he used more than 2,000 physicians, and on about 42% did not use any variable. This was done in either side of the Atlantic. And then about the rest of the 58%, out of those 35% used static variables, such as CVP. Then only about 22% used dynamic variables. Out of that, 10% used passive leg raising, and only about 2% used the echo-based systems. Then Dr. Sarkoni and his fellow Hofer, Dr. Hofer, in their review article, analyzed the available cardiac output hemodynamic monitoring systems. They divided into invasive, which is pulmonary artery thermodilution technique, where we inserted a catheter and the tip of the catheter is left in the pulmonary artery and to measure various pressure measurements. Over the years, over the decades, its use has been declined to various reasons, which we know, and now there is only specific indication for use pulmonary artery catheters, such as right ventricular dysfunction. Then comes the group of monitoring devices where they analyze the arterial pulse wave and use pulmonary artery thermodilation system, where they need repeated external calibrations. Dr. Monet and Professor Monet and Professor Tribute in their review article on pulmonary thermodilation advantages and limits review these type of methods, and they showed that almost all cardiac indices can be measured through the transpulmonary thermodilation methods. In addition, these methods can measure extravascular lung water and pulmonary artery permeability index, which are very useful in critically ill patients' hemodynamic management. This method can be used continuously, but they need frequent external calibration. Then there is a lithium dilution technique where lithium is used as an indicator dilution. This is a more or less same technique to transpulmonary thermodilution, but the accuracy is the same as the transpulmonary thermodilution. But the drawback is repeated calibration is not possible due to the lithium toxicity of this technique. Then there's another group of minimally invasive techniques where arterial pulse waveform is analyzed, but they did not want any external calibration, such as FlowTrack or LitcoRapid. What they did was that they had a catheter inside the arterial line. They had in an artery, and then waveform is replicated in a monitor. Then series of algorithms used to analyze these characteristics of the arterial waveform, and then using patient-specific anthropometric and the demographic data, they measure the cardiac output, or rather calculate. It's a continuous method, less complicated, but it does not give as much as variables as in transpulmonary thermodilation. Then we have the esophageal Doppler technique, where the Doppler effect technique is used to look at the flow in the descending aorta, where it can use calculations to give us a continuous cardiac output monitoring. The drawbacks on this technique is that we can only use in sedated and ventilated patients, and we need to frequent adjustments. Then there are a group of methods where you don't need invasive techniques. Still, there's a way of using arterial waveform analysis by non-invasive method like volume clamp method or arteriotonometry, where they give cardiac output, and then bioimpedance and bioreactance is used to measure cardiac output. And the carbon dioxide rebreathing methods can be used, and pulse plethysmography variable is also used. Although these are non-invasive techniques, each method has its own limitations. So we have to know the limitations when we are using them, and we need further studies to validate these systems for our clinical practice. Dr. Sarkoni and Dr. Hofer also in their review article to the critical care some time back analyzed the factors affecting selecting of cardiac output monitoring devices for monitoring hemodynamics. They divide these factors into institutional, device, and patient. Institutional factors like type of institution, availability of monitoring technique, and the experience of the staff to measure and interpret the variables or values is called institutional factors. Then the device factors like invasiveness, accuracy, technical limitations, handling, and then what are the available hemodynamic information it provides are considered as device factors. Then the patient factors are severity of the patient's illness, whether the patient is vasoplegic, whether their cardiac rhythm is regular, or whether there are any specific contraindications to any likely method can be taken as patient factors. In addition to these factors, there's a cost factor in low resource settings as a major factor in deciding which cardiac output monitoring hemodynamic is used for hemodynamic monitoring. So what is the question do we have to answer during our hemodynamic monitoring? Is there adequate tissue perfusion and oxygen delivery? To answer this question, we have to answer the following questions. Is there acute circulatory failure? Is there obvious hypovolemia? Is the patient preload responsive? Is the patient fluid tolerant? And what is the limit of your fluid resuscitation? So if you take acute circulatory failure, we can do the clinical assessment like capillary refill time, basic hemodynamic monitoring like NIBP, ECG, and obviously central venous catheters taking central venous oxygen saturation and the blood lactate levels can be used to assess acute circulatory failure. Is there an obvious if the patient is having acute circulatory failure, we have to decide whether the patient is having obvious hypovolemia. Yes, so we can give fluids. But if there's no obvious hypovolemia, we need to assess fluid responsiveness. To decide whether patient is fluid responsive or not, we use heart-lung interaction. We know that we have during our cyclical inspiration, respiratory and expiration, inspiration and expiration respiratory cycle, we have cyclical increase in intrathoracic pressure, which affects in cyclical manner to venous return. This cyclical change in venous return can manifest as cyclical change in stroke volume changes and thereby cardiac output. This cyclical change of cardiac output can be reflected on arterial waveform and velocity time interval at left ventricular outflow tract and also in IVC diameter. So how do we monitor fluid responsiveness? So we can use IVC distensibility index. To do that, we can measure the IVC at the subcostal window with a mode, and then we can assess the distensibility index of the IVC. And if it is more than 18%, we assume that patient is fluid responsiveness. There are a few caveats on this method, so that we have to be careful when we measure this. Then another method to assess patient's preload or the preload responsiveness. We can measure stroke volume at left ventricular outflow tract by using a GoPro. So we can measure various velocities and calculate stroke volume, and thereby calculate stroke volume variation. If the stroke volume variation is more than 12% with the respiratory cycle, or we can assume that patient is having fluid responsive. Yes. Then we can assess maximum velocity at left ventricular outflow tract or the velocity time integral, where with the respiratory cycle, their changes are more than 20%. We can suggest or assume that patient is fluid responsive. So measuring these values will have some limitations, so that we have to be careful when we measure these values. Then, as in we are assessing the patient fluid responsiveness. So we can use the methods shown in the slide. And if we have a continuous cardiac output monitoring device, we can use that. Hello, can you hear me?
Hello, Subroto.
Can you hear me?
Subroto.
Yes.
Hello, Subroto.
Yes.
Okay.
Can I proceed?
Yes. Yes, yes.
Hello, can I proceed?
Okay. Your presentation is over, Bimal? Okay, thank you. Thank you very much. I think we have a shortage of time, so we are moving to the next speaker. Moderator,
Yes.
can you hear me?
Yes, I'm hearing you, sir. Our next, thank you, Dr. Bimal Kudavirange.
Oh, sir. Only one speaker is there, or more?
Yeah, only one. Nahrin is here. Nahrin is the last speaker for today. Nahrin is the last speaker for today. Can you introduce Nahrin? Subroto, please. I think Subroto is disconnected. Subroto is disconnected.
Sir,
Thank you very much, Dr. Bimal. I'm taking over from the Subroto. Dr. Nahrin Husna Ahmed. She is a great lady. She is assistant professor of the clinical medicine division of the pulmonary and critical care, University of Pennsylvania. She has leadership and global health engagement with Med Global US-based nonprofit working in disaster relief sites, Yemen, Gaza, Rohingya refugee camps, Syrian refugees camps. She has a good work there. And she is head of ultrasound, Bridge to Health US-based nonprofit working in low-resource countries like Uganda, Rwanda, and Kenya. She is joining from Pennsylvania. Right now, there, I think, morning time. Yes, Naren, can you hear me?
Yes, I can hear you. Can you hear me?
Yeah.
Great.
I can. Please continue with your presentation.
Wonderful. Thank you for the introduction, and thank you, Dr. Kausar and the Bangladesh Society of Anesthesiology for the invitation to speak today. In the interest of time, I'll make this quite short. What I wanted to talk about today, which was a good segue from the last presentation, as well as a few of from the previous presentations earlier in the day, is the impact of point-of-care ultrasound in the ICU. The picture you see here is a training session in Yemen, where we were training Yemeni physicians in point-of-care ultrasound in November. So in order to talk about point-of-care ultrasound and the impact, I think we need to initiate with the discussion of the challenges with diagnostic imaging in the ICU. What you see here on the right is an image of one of the training sessions we had in Dhaka Medical College. And this is an ultrasound that was donated by crowdfunding. And one of the reasons that we donated this machine and initiated the point-of-care training courses was because of the following challenges. We often see in the ICU that patients are too unstable for transport. There are chapters in textbooks regarding this, the danger of transporting unstable patients. Portable X-ray may not be available reliably. CT scan might not be available at all. Expertise may not be readily available, as in cardiologists that can constantly come to the ICU to scan. Serial diagnostic imaging can also become quite expensive, not only for the patients, but for the hospital as well. So kind of launching into how we got to where we did, a little bit of history of ultrasound briefly. Interestingly, the sinking of the Titanic and World War I were catalysts for development of sonar technology, which is the basis of ultrasound. In 1942, the first physician who was an Austrian psychiatrist and neurologist was the first to use ultrasound in neurologic injury. After that, early adopters were what we're more used to seeing: radiology, cardiology, and OBGYN. By the 1970s, emergency medicine and surgical specialties adopted ultrasound, as we're all familiar with the FAST exam and vascular exams. And then the critical care division in most places across the globe started to adopt ultrasound for to decrease procedural risk was the initial reason. And in the last decade, diagnostic ultrasound in the hands of the clinician has been integrated into clinical practice. And that sort of lays the foundation for the discussion of what is point of care ultrasound. It's a new use of an old technology. What you see here are 3 images of 3 different ultrasounds. The image to the left is probably what most of us are used to seeing, these big bulky machines on wheels that are very challenging to roll around the hospital. The machine that you see in the center of the screen is maybe what we're more used to now, which is a laptop-sized machine that we can roll on a trolley. And the device that you see on the far right is something called a butterfly, which is an ultrasound device. The probe itself actually plugs into your cell phone. So as you can see over time, the portability of the device itself has lent itself to being able to use it much more readily from patient to patient, as opposed to transporting a patient. So what point of care ultrasound allows the clinician to do is to acquire the image rather than having a sonographer acquire the image, interpret the image, and integrate that into clinical management at the point of care, meaning at the bedside. So what's the clinical utility of point of care ultrasound? It's been alluded to in many of the talks that were given today about how we can, in a non-invasive manner, come to the answer of many questions about our patients, about what is clinically wrong with them. When it comes to POCUS, which I'll refer to point of care ultrasound from this time forward as POCUS, we're looking to answer specific clinical questions such as, why is the patient in acute respiratory distress? Why is the patient in shock? And a few of the things that you can identify with point of care ultrasound with POCUS are pleural effusions. You can see evidence of a pneumothorax, alveolar or interstitial processes such as pulmonary edema or consolidative processes like pneumonia. With a patient with undifferentiated shock, you can assess for pericardial effusion, LV dysfunction, RV dysfunction, signs indicating pulmonary embolus. You can assess for signs of volume responsiveness and free fluid in the abdomen, all of which can help you identify why your patient is in shock. So it's very obvious as to why POCUS is incredibly important and the clinical utility of it is so significant. But as clinicians, we all want to know, where's the data? How can this actually support programs in our own ICU? There are several costs that go into point of care ultrasound and POCUS, meaning buying the machine, implementing training, and it's important to understand why it's impactful. So I'm going to go over 3 studies that really outline that. The first was a study that was done in 2012. This was a study that assessed 125 patients. The initial diagnosis was made by history and physical exam, as we all normally do. Within 12 hours of admission, a POCUS exam was conducted on these patients. The protocol that was used was referred to as the ICU sound protocol, which looked at the following things in a systematic way: optic nerve, chest, heart, vascular, and abdomen. What I really want to focus your attention on is what I highlighted here in the table, which is the new findings. The first column shows you the number of findings that were observed with the ultrasound. And the second column shows, of those findings, which were new. I want to especially focus your attention on the thoracic and cardiac abnormalities, where you can see that the majority of the findings that were seen on POCUS were new findings, both in the chest, including thoracic and cardiac abnormalities. So this is incredibly important. Here are a few examples of that, because I would be remiss not to show this. What you see here in the top left image is one of the abnormalities that was found, which is a clot in the right atrium that you see here labeled as A. In the image that's in the top center of the screen, what you're seeing here is internal jugular vein thrombosis. Imagine you have a patient who might be hypoxic, who might be hypotensive, in whom you are about to place a central line, wouldn't it be more useful to be able to assess your vasculature before placing a blind line? So where POCUS really comes in handy is, one, allowing us to identify reasons as to why the patient is sick, but also allowing us procedural guidance as well. This is a patient you ideally would not want to place an internal jugular vein catheter on this particular side. The patient, the scan that's shown in the top right is a classic sign of acute acalculous cholecystitis. And these are all images that were obtained by clinicians at the bedside who are intensivists. The bottom image, I think, is probably the most telling. The X-ray itself suggests a pleural effusion and was read as such by the radiologist. However, as you can see in the scan that's adjacent to the X-ray, what this is actually a very small pleural effusion that's labeled as the number 2 here. And what is actually primarily the cause of this opacity is a large consolidation, which you see here. So according to the chest X-ray, this might have prompted somebody to place a chest tube to do a thoracentesis, which actually would have been the wrong thing to do in this setting, given that what we're seeing here is a very small pleural effusion and a large consolidation. So you can see how this changes potentially your diagnosis as well as diagnostic interventions and your therapeutic interventions. The second study really focuses on that particular point, where this is a much larger study, 968 patients were reviewed and over 1,000 studies were looked at. The POCUS exam changed the diagnosis in 302 patients. On top of that, the impact of the diagnosis, I think, is probably one of the most crucial things to look at here, and then the impact on treatment. Again, cardiac ultrasound had the most significant impact, which is a message that I think you've heard a few times today, that cardiac ultrasound in the hands of the intensivist can be quite impactful. The last thing of this study, which I thought was incredibly useful and especially great as far as the argument towards why it's important to bring POCUS into your ICU, because the median time to scan in many of these was 5 to 10 minutes. So again, it's not adding a ton of time to your physical exam and review of the patient, but it's adding a significant impact on your diagnosis and treatment. That leads me to the last study that I want to review very quickly. This was a smaller study, but with some really interesting findings, where 80 patients were looked at, 40 per group in the POCUS group and 40 in the standard clinical practice group. Routine POCUS-driven protocol was used in the POCUS group, and the POCUS study was done in the early phase of the ICU admission. The following outcomes are highlighted. There was a decrease in utilization of conventional diagnostic imaging. So think about cost, less time on mechanical ventilation, more judicious IV fluid administration. We just heard about the negatives of being hypervolemic or being under-resuscitated. So having a way to guide that that's non-invasive, as the Swan catheter is not really used anymore. And the reason for that is because the replacement with ultrasound. And there were no complications that were directly associated to POCUS use, so relatively safe procedure. And I want to focus on the 2 tables that came out of that study. So one, the modification and diagnosis and therapeutic decisions led by ultrasound. In the 2 images that you see above, this was in Ethiopia, and we were examining a patient who was a young patient who was short of breath. And the image that you see here to the right is a zoomed in image of what we were looking at. And as you can see, there is a pericardial effusion around the heart. This patient ended up having lymphoma. This patient was hypotensive because of the fact that he was in tamponade. It led to changes in our decision-making as well as therapeutic interventions. And so what I want to point out particularly in this table is that the new or unidentified diagnoses that you see here, the number of changes that were seen here were mostly in pneumonia and a significant pleural effusion. So again, thoracic abnormalities. Clinical diagnoses were changed because of that. Pharmacological therapy was changed, especially in the area of fluid challenge and diuretic. So again, 2 big questions that we struggle with in the ICU, both of which were guided by ultrasound. Invasive procedures were also changes that were made here, especially in thoracic drainage. So you can see the impact in therapeutic decisions is quite big. The last table that I'll review is this comparison of resource utilization and length of stay. While mortality did not really change significantly, and that's an important thing to understand in the ICU, that there are so many confounding variables to that end. But the number of patients in the POCUS group that had less utilization of high resource imaging technology was a really important impact here, as resource utilization in low resource countries should be thought about pretty heavily. So the summary of the benefits of point of care ultrasound I hope that you've realized from the last few slides and the studies are one, increases your diagnostic data efficiently in a very minimal time added to your physical exam and history. You can obtain new findings which may have been otherwise missed. It can also change or modify your diagnosis. It can help with also following up your interventions with diuresis, with fluid administration, and can help you track and monitor your patients. It can change or modify your therapeutic interventions, and it can improve resource utilization, which I think is probably one of the most important points here. It can lead to less expensive diagnostics needed, decrease your cost for the patient, and decrease cost for the hospital. All of these are fantastic arguments for why points of care ultrasound training should be implemented in your ICU. If it's not already, here are some ways in which you can go about doing this. I think somebody had mentioned that it takes a good deal of effort to get government money or to get funding for many of the projects and building of medical capacity in your hospital. So the first, of course, is the issue of purchasing a portable ultrasound or a handheld ultrasound, identifying local POCUS experts, and that would be cardiologists, radiologists, or anybody that's been trained in points of care ultrasound. There are several online platforms available for lecture content, both free and paid. The paid programs typically come with mentorship, which is great in the arena of trying to train a trainer and train local experts. I can tell you that the implementation of the POCUS training program at Taka Medical College started about 4 years back when I went with a few colleagues, and is now a self-sustained program where the experts that we trained are now training their colleagues without my involvement. There are also several free resources, and I believe I just want to focus on this last part, quality assurance by experts, meaning that scans are reviewed, feedback is given, so that your intensivists can be scanning patients confidently, knowing that they're finding the right diagnosis and being able to interpret them. I'll leave you with this last image of a very significant pericardial effusion. This was a scan that I obtained, and the importance of this scan to me was that this was a patient that came to me in undifferentiated shock, and within 10 minutes I was able to determine why exactly this patient was in shock, and then quickly make the intervention needed in order to improve the patient's case. And so this patient did survive, unfortunately had a malignancy, and so did not survive in the long term, but survived in this acute setting. And that's the last image I will leave you with, just to really show the impact of POCUS in the ICU. I thank you for the time. Please feel free to contact me with any additional questions. I'll leave my email here, my WhatsApp number. I'm very open to collaborating with helping to implement training programs in your ICU and hospitals. Thank you again for the time, and appreciate all the presentations today. Thank you.
Thank you very much, Nareen, for your nice presentation. Can you talk a little bit Bangla? আপনারা সবাই ভালো আছেন তো?
আমি ভালো, আমরা সবাই ভালো। হ্যাঁ, আপনারা কেমন আছেন?
Okay, great. Thank you. She is made in Bangladesh. Last speaker, but is staying in US. Okay, thank you very much. So I'm moving to our chairpersons of the last session. One announcement. I'm seeing Professor Adrian W. Gelb, sir, the President WFSA, already joined here. So after this session, we are moving to the valedictory session. Before that, I'm calling upon Dr. Malin Gunavardhana. She is the Secretary of the College of Anesthesiologists and Intensivists, Sri Lanka. Just a short comment, Malin, please.
Yeah, good evening. And thank you, BSA, for the opportunity to chair this session. It was very interesting. 4 different speakers from varying topics, from end-of-life care to ultrasound in ICU. Thank you very much to all the speakers. And because of the time, I'll ask my other co-chairs their comments.
Thank you very much. Nobi sir and Manan sir is not here, I think. Okay. I'm going to Dr. Paresh Chandra. Professor Paresh Chandra is the one of the panel of the chairpersons. Please have a short comment, please.
Thank you, Dr. Kausar. It is the last session, but not the least. So I must offer my thanks to the BSA and the organizer, special thanks to Professor Dr. Kausar Sardar, Secretary General, Professor Dr. Maksudul Alam, last president, and must say my thanks and gratitude to Professor Dr. Devbruto Bodik, the president of the BSA, and I must congratulate and thanks to the participants and speakers. And lastly, I would want to recite from the Ved, Sarve Bhavantu Sukhira, Sarve Santu Niramaya, Sarve Bhadrani Pashantu Mahakursi Dukku Bhavet. That is, I must pray, let everybody be happy, let there be no suffering.
From very good speakers around the world. Now, I don't want to spend any time moving to our valedictory session. Yesterday we did. Yesterday was a very good inaugural session. The inaugural session was inaugurated by our honorable
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.